in washing out the pollutants or some foreign bodies if they are on ocular surface, and overall it protects the globe. If there is an entropion, these are the signs and symptoms: ocular foreign body sensation, discharge, watering, redness, corneal erosions. So why do we need to manage entropion? Simple, these are the reasons. If a patient has to undergo a cataract surgery, if patient is having recurrent conjunctivitis, and in last obviously cosmesis. Okay. We all look for these things when we evaluate the patient of entropion. That is lid laxity, canthal tendons, movement of the globe in down gaze, whether there is any cicatrization or symblephrone present. Then we also see the ocular surface, that why the patient is having entropion. Okay, let's discuss case wise. Okay, is it clear? This patient is having a diagnosis of entropion. Everyone can see that? Okay. Now first thing what we need to evaluate is the horizontal laxity. How do we do that? Anyone? We have two tests. Okay. For this laxity, first of all we have to see medial canthal tendon laxity. So if we need to see all these things, we should have an normal anatomical thing to compare with. So to test medial canthal tendon laxity, we see the movement of the punctum. And depending on the movement of the punctum, we can say that yes, this tendon is lax. Same with the lateral canthal tendon laxity, we need to see the movement of the lateral canthus. So in first thing, if the punctum, these are the 6 grades. If the punctum is reaching like this, first, if it is reaching the medial limbus, it is grade 2, yes, tendon laxity is present. If it is reaching the pupillary margin, yes, grade 4, tendon laxity is very much high. And if the lateral limbus, then it is grade 6. Lateral canthal tendon is mainly subjective laxity. We'll pull the lid medially and see how lateral tendon is behaving. Okay. So coming back to this picture, first thing we saw is horizontal laxity is present. Second thing we need to see is vertical laxity. How do we assess that? So vertical laxity will be contributed by our orbicularis muscle and the skin. If we see the picture, there is overriding of the skin, that is overriding of the pre-septal part of orbicularis towards pre-tarsal part. Okay. That again will cause entropion like this. So these are, to complete the list, snapback test, we pull the lid inferiorly and see how much time it takes to go back. Okay. Second is eyelid distraction test, also called as pinch test. We hold the lid and pinch it and see how much loosened it is. We have to measure the distance between the globe and the pinch which we did. Okay. So now coming back to this thing again, this is vertical laxity which I told. Now our diagnosis will be left lower lid involutional entropion with both horizontal and vertical laxity. Okay. So this is again one of the classifications of entropion also. Classification of entropion, this is involutional type, how to evaluate that we have discussed. Now the management, what to be done? We need to take care of both the parts, horizontal part also and the vertical part also. So we will be going to the management simultaneously. For vertical laxity, we do Jones procedure. In 90 to 95% of cases, this works very well. Jones procedure is plication of the capsulopalpebral fascia. Okay. We need to find it out, we need to attach it to the inferior border of tarsus. Again, surgical steps generally are not asked in the viva, but yes, for this you need to know them because this is a very common procedure. So if your viva is going great, then they might ask. We give a lower lid incision around 2 to 3 millimeters below the lash line, separate out the orbicularis, reach the septum, open the septum and push the fat inferiorly so that we can find the shiny capsulopalpebral fascia. We need to pull it and attach it to the inferior border of the tarsus with plus or minus resection of the skin orbicularis if needed and if not needed. Okay. Second thing is to take care of horizontal lid laxity. So, for that we do a lateral tarsal strip. In most of the cases, this procedure helps in taking care of horizontal laxity also. Okay. So, involutional entropion, how to evaluate and management. Okay. Clear to everyone? Any questions in this? Moving on to second variety. Okay. So, there is one more thing, temporary procedure if we want to do, like if a patient is very fragile or having some systemic illness where somewhere around 25 minutes to 30 minutes of procedure cannot be done. Then we do a quick procedure called Quicker's everting suture that will give instant relief to the patient. We pass the suture from the fornix side, from the inferior tarsus towards the skin, 2 arms and just tighten them up. Because of the everting force on anterior lamella, the skin will turn out, the margin will turn out. Okay. This is what is explained in the diagram. So, this is the tarsus, we pass the suture from here, this is the posterior lamella, we pass the suture from here, tarsus and going to the skin, tightening here. Okay. Next, simple diagnosis of upper lid, commonly seen in all our OPD patients, upper lid entropion. Okay. In 90 to 95% of the cases, upper lid entropion, the cause is cicatricial entropion. So, for evaluating this, we need to evert the upper lid and we will be able to see the scarring below the lash line, somewhere around 4 to 5 millimeter below the lash line. Okay. So, this is a simple case, just evert the lid and diagnosis and the pathogenesis will be straight in front of you. How to treat this? Anyone? Very simple. I think this is the simplest procedure and we all get to do it in first year of PG, right? Yeah. So, tarsal fracture is supposed to be done in this case, and if there is significant scarring specifically involving lower lid or in cicatricial entropion, we might have to do grafting. What are the causes for cicatricial entropion? So, earlier trachoma was one thing. So, post trachoma scarring of upper lid was very common. Nowadays, chemical injury, patients like Stevens-Johnson syndrome or ocular cicatricial pemphigoid, this can lead to scarring. In few cases, sometimes when patients have recurrent allergic conjunctivitis attack, they have giant papillae which are not resolving, or sometimes post-viral there can be scarring. Though they are acute conditions, we need to wait to treat them, but still that can also present as cicatricial entropion. Okay. Any questions in that? We move ahead. Now, this is a rare entity which we see, a congenital entropion. That means entropion is present since birth, but there are 2 entities, congenital entropion and epiblephron. Okay. These 2 needs to be differentiated. Epiblephron is more common. Lower lid congenital entropion is very rare. Epiblephron generally gets resolved by 1 year or maximum 2 years of age. In epiblephron, basically there is an extra fold of skin which pushes the lashes towards the ocular surface, hence causing irritation or maybe corneal scarring later on. In congenital entropion, there is loosening or there is dehiscence of lower lid retractors. So, therefore, management is different for both of them. In congenital entropion, we need to reattach the lower lid retractors, whereas in epiblephron, if it is causing symptoms, then we can do a simple procedure of skin orbicularis excision, also known as Hod's procedure. So, in plasty, things are very much common with their names. we have to ratify them, okay? Like entropion surgeries, I'll be coming onto a slide, like orbitotomy incisions. So all are popular by their names and we need to know them. There is a rare condition, rare or maybe a very less commonly seen condition called spastic entropion. So we did classification 1, involutional, cicatricial, congenital, and this is last according to me, spastic. Spastic entropion is an acute condition which happens due to some irritation happening on the ocular surface, okay. So in this generally we do a conservative treatment like lid taping, we give lot of lubricants, and if patient is very much bothersome, we can give injection of Botox in the pre-tarsal orbicularis, and that works for at least 2 to 3 months. So this slide we need to ratify. Different surgical procedures. If you have a case of entropion, this will be the question asked, that what are the different types of surgical procedures you know to manage an entropion. So for lower lid, we have these procedure, Wheeler's and Quickett's procedure, and for cicatricial entropion, this is the list. So I tried to make a complicated entropion into a simple entropion. We did all the classification with their evaluation and management simultaneously so that you don't have to ratify the things. And of course, all the best for your upcoming exams. Thank you. I'm free to answer any question if I can.
Thank you, Smriti. An excellent exposition. So you understood the principles well. The whole purpose of oculoplastic presentations will be that basically you have to understand the pathogenesis, why the changes are occurring, age-related or due to cicatrization or due to trauma or due to any other tumor or any pathology, what changes in normal anatomy and physiology have taken place, and the principle will be to restore them. So she beautifully explained about horizontal and vertical laxity for the lower lid in involutional entropion and the interning in the upper lid due to shortening of the internal lamina. So if one lamina is shortened, there will be a bending like this. If there was a shortening on the front lamina, there would be an outturning of the margin like this. So basic, and she explained it very beautifully. Principles very clearly explained: horizontal tightening, vertical tightening for lower lid, and tarsal rotation primarily for the upper lid. Create a fulcrum in the upper lid by some incision at a few millimeters away from the margin, and with your sutures rotate around that fulcrum. So beautifully explained, all very mathematical, should be quite clear. Purpose will be to give you an orientation so that you understand what is happening, and then of course you can go and read up and brush it up. Thank you very much. Over to you.
Thank you very much, ma'am. I'm sure that now next time they will remember it's all written on the face of the patient. Okay, so after the wonderful talk on entropion, it's time for covering a little bit of ectropion as well. So we have with us Dr. Mukesh Sharma, sir. Welcome, sir. As he's a chair for the session as well, and he is a consultant at Center for Sight, Jaipur, and he takes care of nearly everything over there. He's like a pan-ophthalmologist. So over to you, sir.
So Mukesh is a stalwart of Indian and international oculoplastics. He was the Honorary General Secretary of the Oculoplastic Association of India for a long time, till he sets up his slides. And he's a wonderful person and a wonderful surgeon. We'll see that in his slides and his results.
Good morning, sir, and thanks for the nice introduction. Good morning, everyone. It's really a pleasure seeing all of you today so early in the morning, and we hope that the attendance will swell up as the day progresses. So, Dr. Smriti has given you a very good outline about the basic pathology. Entropion and ectropion, both of them, they are okay. I'm not seeing it here.
You have
All right, fine. So my screen is getting blank, but I'll see there and present. So they both are part of same pathological process. When we do grading of ectropion, this is the standard grading. Grade 1 is punctal eversion. Grade 2 is eversion of the sharp posterior lid margin. Grade 3 is when palpable conjunctiva is exposed. And grade 4 is when fornix get exposed. So this is the standard grading of ectropion, and then there are various other gradings also. This one is given by McGraw and Adamson. Here they have gone from lateral to the medial side. In the grade 1 of this particular grading, there is lateral rounding of palpable fissure. In grade 2, central scleral show. In grade 3, eversion of lower lid with tears pooling in inferior sac. And grade 4 is the frank eversion with the exposure of palpable conjunctiva. But what is universally followed is this particular grading. Now, what are the types of ectropion? Congenital, involutional, paralytic, cicatricial, and mechanical. So practically, entropion and ectropion, they follow the same kind of etiological classification. Congenital ectropion, it is a rare entity unlike the entropion, and generally it is associated with certain other problems. One entity is uriblepharon. Pointer chal raha hai kya? All right, so this is the uriblepharon. Here lid becomes almond-like. There is ectropion of lower lid, and also lower lid gets elongated. So it becomes almost like an almond, and there is a kind of more eversion at the lateral margin. So this is the uriblepharon. Then blepharophimosis syndrome. In this particular condition, you get a differential entropion-ectropion. Someone may ask you in the examination, tell us about a condition where you get both entropion and ectropion in one single patient. So in blepharophimosis, there is entropion of the medial margin and ectropion of the lateral margin of lid, lower eyelid. So you get both entropion, ectropion in one condition. Then when you talk about correcting the congenital ectropion, generally you need to do horizontal lid tightening as it is there in uriblepharon. In true congenital ectropion, there is shortening of anterior lamina, so you have to do skin grafting. So now we come to the major type of ectropion, that is senile ectropion or involutional ectropion. This results from imbalance between forces on anterior and posterior lamina. You all know about the anterior lamina of lid. Skin and orbicularis, they constitutes the anterior lamina, while tarsoconjunctiva in the upper part and lower lid retractor, that is capsulopalpable fascia in the lower half, they constitute the posterior lamina of lid. So both entropion and ectropion, they are part of same etiological process. There is tarsus instability and horizontal lid laxity in both. Grossly, when there is laxity of both the lamina, anterior lamina as well as posterior lamina, then whole lid get turned out and ectropion is resulted. When there is laxity of posterior lamina, but anterior lamina tone is almost normal, skin and orbicularis tone is almost normal, then you get the entropion. So this is the basic principle. Now, as we discussed, involutional ectropion is the most common variety. There are various tests to test the laxity of lid. I think Dr. Smita has discussed all of them. The lid snapback test is the paramount test. Then there are lateral distraction test also. In lateral distraction test, you pull lid laterally and the punctum can be drawn lateral to the medial canthus. Normally, you can only displace puncta around 1 millimeter from its normal position. But whenever lid is lax, there is gross horizontal laxity, punctum can be withdrawn more laterally. And the presentation is epiphora, conjunctival hypertrophy, keratinization, etc. So this is about the snapback test and its grading. In grade 0, that is the normal lid, it returns to normal when you leave the lid after pinching it up. In grade 1, it takes almost 2 to 3 seconds. In grade 2, around 5 seconds. In grade 3, more than 5 seconds. But it does return back to its normal position. While in grade 4, it never returns back to its normal position. You pull the lid down and it will remain everted. So this is grade 4 of snapback test. Then the lateral distraction test. So this we have already discussed. Normally the displacement should be 0 to 1 millimeter only, but when you pull laterally away from medial canthus, then the displacement is more than that. And then if it is beyond the lateral part of limbus, then it is very significant. So when we manage ectropion, there is this management consideration subtype. There are these subtypes. So one and the earliest or the mildest variety is the punctal ectropion. Then the medial ectropion, which is not associated with horizontal lid laxity. Medial ectropion along with horizontal lid laxity. And medial ectropion with medial canthal tendon laxity. And finally, ectropion involving whole lower lid. So this is grading of ectropion as per its severity, and the management depends on these subtypes. If this only punctal ectropion is there, then sometime we can do only the electrocautery. Cautery is done at the junction of conjunctiva and lower part of tarsus, and it is generally a kind of temporary measure only. So we do not follow alone electrocautery alone. Then the inverting suture repair, again this is a kind of temporary procedure only, and generally it is other procedures like lateral tarsal strip. So here double arm sutures are passed through the inferior border of tarsus and they emerge further down near the infraorbital rim, and then they are tied. So they take lid inside. They cause inversion of the lower eyelid. So when there is medial ectropion without laxity, medial spindle resection, also known as medial conjunctivoplasty, is done. A spindle-shaped conjunctiva is taken out here below the punctum, and you have to protect the punctum by passing Bowman's probe. Otherwise, you may injure the punctum inadvertently. So first punctum is protected by passing a Bowman's probe, then the spindle is excised and it is sutured with the help of Weichel suture. If ectropion is there with medial canthal laxity, then you have to obviously tighten the lid medially. So what is done is that incision is made between caruncle and plica. Then double arm 5O athubond sutures, they are passed through the lower margin of tarsus here and through the periosteum of posterior lacrimal cast, where the medial canthal ligament posterior part is attached. So suture is tight and tightened, and the medial aspect of lid is repositioned against the globe. So this is how medial ectropion with MCT laxity is managed. If medial ectropion is there with horizontal lid laxity, we are going down in the severity, then a lazy T procedure may be done. Here, along with medial spindle procedure, a medial wedge of lid is resected, and after repair it becomes a kind of lazy T. So inside, if you see this, then it will be like a lazy T. Unfortunately, can I have a better pointer? It's not working there. अरे ये आ नहीं रहा ना इसमें, प्रॉब्लम ये. Anyway, so here we remove a wedge of lid, full thickness wedge of lid. Then the margin is sutured as per the principles of marginal suture. I think Dr. Grover would be discussing them. And then it is combined, as I told you, with the this conjunctival spindle resection. So once you repair it, it becomes a lazy T-like thing, If ectropion is involving whole of the lower lid, then it depends, management depends on the severity of ectropion, presence of excessive skin, and the degree of laxity. So if there is no marked excess skin is there, then only the horizontal lid shortening may be tried. It is Byron-Smith type of surgery, wherein you remove a lid wedge and just suture it. When there is excessive skin, then a Kuntz-Zymowski procedure is done, where along with this wedge resection of lid, the incision is made on the lower lid, this skin is draped over the lower lid, and excessive skin is removed. So this is Kuntz-Zymowski type of procedure. We'll see the video also. So generally, but nowadays for all severe variety of entropion and ectropion both, involutional type, lateral tarsus strip is performed. So this is a wonderful procedure which gives correction in both. Basically, it is tightening the lid and correcting the horizontal lid laxity which is there in both senile entropion as well as ectropion. If you are correcting the ectropion, then you may need to supplement it with the inverting sutures also. And similarly, if you are correcting the entropion, then sometime you may need to supplement it with the everting sutures. So this is the most gratifying procedure, and we'll see a brief video of it. So a canthotomy is done along with cantholysis of the lateral lid margin. Then you just cut the anterior lamina and fashion a strip of tarsus plate. You can excise a bit of this strip if there is too much of laxity. Then you will have to remove the superior surface skin part also, otherwise there will be granulation tissue because you will be resuturing it back to the periosteum. So this extra wedge is removed. Now we are going and reaching up to the periosteum of lateral orbital margin, and we are going up superiorly. We will not be reinserting it at the lateral orbital margin, but we will be reinserting it 5 millimeter, around 4 to 5 millimeter above it, almost in line of pupil, so that it correct the future sag down property also. So you use a non-absorbable suture, double arm suture, in this strip, and this is the exposed tarsus plate, and you pass your sutures here. So this is a wonderful procedure, very simple procedure, and this corrects both entropion, senile entropion as well as ectropion. So once you are done with this, just tighten the sutures. And apply skin suture. So this is how this procedure is completed. I think the same kind of surgery once again, so we will not go into the detail of this surgery. This is Kuntz-Zymowski procedure. I think we are running short of time, so I will not go into the surgical detail of this particular procedure. So here we have combined lateral tarsus strip along with Kuntz-Zymowski procedure, because there is marked excess of skin here. So you need to combine these two procedures. And same is the surgery done in this particular case also. Now we touch upon the paralytic ectropion. This is seen in facial nerve palsy. And here epiphora is caused by a multiple causative factors, a combination of mechanism. One is failure of lacrimal pump, which is there in facial nerve palsy. Then there is increase in tear production also. Reflex tears, they get more secreted because of corneal exposure. And also failure of tear drainage because of canalicular kinking due to ectropion. So this is very obvious. So there are these three factors which results into the epiphora in paralytic ectropion. So what are the treatments options available here? As a temporary measure, you use certain lubricating drops, you can use botulinum toxin, and you can induce ptosis just to avoid the exposure keratopathy, or one can do the temporary tarsorrhaphy also. As a permanent treatment, permanent tarsorrhaphy along with medial canthoplasty if medial canthal tendon is intact. Also you can tighten the medial part of lid, and one can do the lateral canthal sling. What is lateral canthal sling? Here a sling is passed all over the lid, upper eyelid and lower eyelid both. So we are just encircling the palpable fissure, and we are passing this sling. This may be of silicone also and facial atta also, all around the lash margin, so that you can tighten up this facial nerve palsy lid. Then the cicatricial ectropion, here there is shortening because of scarring, and the way to correct in mild cases is jadplasty. So you make a vertical limb of jad over the scar line, and you just transpose the flap and resuture them. So this is how it is done. Incision is made over the scar line here. Then the flaps are made and they are just transposed. And by doing this, you release the scar line. So this is the final appearance on table, and you can see this notching has disappeared. Final post-op appearance. If there is too much of cicatrization, then you need skin grafting. In these kind of cases, we need skin grafting. Then the mechanical ectropion, if some tumor is there sitting on the lower lid, then obviously it will evade the lower lid by its sheer weight, and you need to remove the cause. So to conclude, every patient needs to be assessed for its type and severity, and a tailor-made approach is used according to the suitability. Thank you. Thank you for your patience hearing.
Any questions for Dr. Mukesh? Thank you, Mukesh. Brilliant coverage of the entire subject. The cicatricial, the principle was very clear. The shortening of anterior lamina, so it has to be made up either by rotation of the tissues or reorientation of the tissues, as in Z-plasty or VY-plasty, or by adding tissues, either partial thickness or full thickness by grafting. And involutional, he explained, if there is a shortage of the posterior lamina, if there is a lengthening of the posterior lamina, you shorten it by a lateral tarsal strip procedure. And if it is for the anterior lamina, then you do some kind of a procedure, Smith's modification of Kuhn-Zimnowski. Remember the lovely spelling of Zymanowski. Or any other skin shortening procedure. So now on to Santosh. You know him, don't you? So he's the flag bearer for Indian oculoplastics and Indian oncology globally, and he is respected the world over for his quality of work, both in oculoplastics, oncology, and you know what he has done for the Indian Journal of Ophthalmology and for the All India Ophthalmological Society in general. Santosh.
Thank you so much, sir. I'll be speaking on a very basic topic, but this is of importance to you both from the point of examination and also real life. This would be on evaluation of ptosis. So whenever you have a patient of ptosis, maybe it is congenital, maybe it is acquired, sitting in front of you, you are supposed to ask yourself these questions and answer these questions for yourself, so that you can better counsel the patient and determine what surgical modality would you undertake. What is the severity of ptosis? Are there any complicating factors such as, say, double elevator underaction, monocular elevation deficit, hypotropia, synkinesis, etc.? What surgery am I going to do for this patient? Is the surgery I'm planning going to be safe for the patient, or would I produce any complications? And what is the expected outcome? Would I completely correct the patient? Would I undercorrect the patient purposefully? Or what exactly am I planning for the patient? For that, you have to go through a very systematic clinical process of evaluation. History would include age of onset, if it is acquired. If it is congenital, obviously it is by birth. Otherwise, it could be acute, subacute, or chronic in terms of mode of onset. Acute ptosis would mean that the patient has generally a neurogenic etiology. Whereas if it is subacute, it could be inflammation or myogenic. Chronic generally indicates aponeurotic, acquired, or myogenic. So depending on the mode of onset, you can determine what could have been the possible etiology. Also, if it is improving, in the sense that if there has been an acute ptosis, but over a period of time it has started improving, indicating that it could be neurogenic ptosis. Also in myositis, it can improve over a period of time. As the myositis or inflammation reduces, then that would also give a history of improvement in ptosis. Now, laterality is also important for the patient to tell you whether it is unilateral, bilateral, and it has always been symmetrical or asymmetrical. Now, history would also include diurnal variation. Does the patient complain that ptosis is much less when the patient wakes up or after taking a period of rest, and it gets worsened over the day as the patient tires out? That indicates that it is possibly myasthenia gravis. Progression, I already mentioned. Improvement would indicate that the patient has had neurogenic ptosis, which is reversing or improving, or the patient has had inflammation that is improving. Worsening would indicate that the patient has a myogenic ptosis or an aponeurotic ptosis. Any history of trauma in the relevant area prior to surgery, medications, and systemic symptoms such as dysphagia, change in voice would indicate a systemic myopathic process. Family history becomes relevant in some patients, especially those who have blepharophimosis syndrome will have family history. It could even be autosomal dominant and recessive. Both variants are known. But even otherwise, patients with congenital simple ptosis can also have family history. Mother has unilateral ptosis, child has bilateral ptosis. Here both the father and the child have bilateral ptosis with blepharophimosis. If the history of onset is not clear, then you ask them to get all the old photographs and try to look at all the photographs critically and see when exactly did ptosis develop. This lady comes with a history of ptosis. When she was 3-year-old, there was no ptosis. When she was 5, there was no ptosis. When she was 18, possibly there is a hint of ptosis. At that time, she used RGP lenses for a period of time. She had unilateral higher myopia. After that, she discontinued the lenses. Possibly that's because of use of RGP lenses that she developed aponeurotic ptosis. As the patient is sitting in front of you and you're taking the history, you should also observe what kind of animation is the patient doing. Is the patient using the brow? Is the patient lifting the chin? Of course, that is very exaggerated way of lifting chin. But of course, you should observe all this, and if the ptosis is variable. Like as you speak to this patient, you observe that her ptosis is variable and she has synkinesis, right? Other causes for variable ptosis would be aberrant regeneration of third nerve palsy. If there is aberrant regeneration, there would be a flick of lid as the patient speaks to you. That is not synkinesis. If a patient has excellent levator action, again, patients can control their lid position. It becomes variable. In myasthenia gravis, of course, ptosis is variable in terms of worsening. As the patient speaks to you, lid may droop further. Look at the patient's face. If the patient does not have any expression at all, neither happy nor sad nor angry, has a fixed expression, that indicates a myopathic face. Crucial information, face we already discussed. Now palpebral fissure height has to be measured in all 3 gazes, primary, up and down. The importance of primary position is known. That gives an estimation of the amount of ptosis, just an estimation. When the patient looks up, palpebral fissure will be narrow on the ptotic side and normal on the opposite side. That does not give us much information. Whereas in down gaze, there is a lot of information that can be gleaned. Especially in patients who have congenital ptosis, LPS muscle is dystrophic. It is neither capable of contracting nor relaxing. So palpable fissure will be wider on the ipsilateral side when the patient looks down in congenital ptosis. Whereas in aponeurotic ptosis, the palpable fissure will be narrow when the patient looks down. That is the difference. There are 3 variants of acquired ptosis where palpable fissure will be wider in down gaze. Generally, we expect that palpable fissure is narrow in down gaze in acquired ptosis, but there are 3 variants. One is myositis. If there is SRLPS myositis, there is restriction of the lid. So obviously when the patient looks down, there will be wider palpable fissure in down gaze. Second, fracture of the roof of the orbit with tethering of SRLPS complex. Again, there would be widened palpable fissure in down gaze. Third would be metastasis. Any serous malignancy, prostate, breast, etc. going into the superior orbit, there will be tethering of the levator. It would be acquired ptosis, but when the patient looks down, there will be wider palpable fissure in down gaze. Now, palpable fissure in primary position will just give you an estimate of ptosis because you are measuring the entire palpable fissure. That means lower lid is also brought into picture. The moment you bring lower lid into picture, if the lower lid is symmetrical with the contralateral eye, then that is fine. But what if the lower lid is slightly retracted on the ptotic side or slightly in a higher position? So amount of ptosis will be variable. So you have to use MRD1 as a definitive indicator of the amount of ptosis. So if somebody is asked you, how do you measure the amount of ptosis? One simple straight answer would be MRD1. Even if it is bilateral. In bilateral, MRD1 normal is considered as 4.5 millimeter and you minus from it. Otherwise, it is the difference of MRD between one eye and the other eye. MRD2 indicates that the lower lid is in which position. Suppose this is MRD1, this would be margin reflex distance 2. So MRD2 is not essential for the measurement of ptosis, but it is only to estimate the relative position of the lower eyelid. Now MRD3 is theoretical, it is asked in the exam. It was described by Putterman, who used it to estimate the amount of levator resection in a patient with monocular elevation deficit. Normal MRD3 is considered to be about 7 millimeter. Minus that from the abnormal MRD. So if a patient has 3 millimeter MRD3, normal being 7, 7 minus 3 would be 4, 4 multiplied by 3, that is 12 would be the amount of levator resection that he would plan in a patient with monocular elevation deficit where squint surgery is not planned. So he used MRD3 as an estimation of levator resection, which is a very complex formula, but at the same time it is practically not used currently. So it may be useful for the exam. Now MLD is margin limbal distance. It is an indicator of levator action, LPS action. So MRD3 is no longer used. MLD is also no longer used. What is currently used is MRD1. Now that's just a pictorial representation of MRD2. So you can see that this is the normal position of the lower lid. If it is sagging down or if it is higher, then MRD2 varies. And this is MRD3. This is not margin reflex distance, this is margin ocular reflex, because when the patient looks down, this reflex will not be in the center of the pupil. It will be somewhere close to the lower limbus. That is MRD3. Now other crucial information, herrings. Herrings is something that has to be estimated. If a patient has what looks like unilateral ptosis, patient may actually have bilateral ptosis, especially in aponeurotic or myogenic ptosis. So how do you estimate the amount of herrings, abnormal or normal, in a particular patient? You lift the ptotic lid to limbus. Suppose ptosis is 4 millimeter, you lift that ptotic lid to the limbus, hold it in that position and look at what is happening to the other eyelid. Does it come down? Does it come down more than what it should? Generally, it comes down by 1 to 2 millimeter. Is it drooping more than that? That means that the patient has a very strong herrings. What does it mean to you? If you correct the ptotic lid, the other eye may start drooping, and you have to explain that to the patient and take that phenomena into account when you perform ptosis surgery. Now, amount of ptosis is simply quantified as 2, 3, 4. So severe, moderate and mild ptosis. Mild, moderate, severe ptosis, 2, 3, 4 you should remember. Levator action is estimated by maximal excursion of the upper eyelid in from extreme down gaze to extreme up gaze with the frontalis fixed. That means that you have to block the frontalis without elevating the brow or depressing the brow, right? The patient's head should be resting on a solid surface to do that, and ask the patient to look down, and from extreme down gaze to extreme up gaze, the excursion of the lid is levator action. It is quantified as poor, fair and good. There are two ways of doing it. 3 to 4 millimeter is supposed to be poor, 5 to 7 millimeter is fair, more than 7 millimeter is good. This is by Beard. And there are newer ways of classifying it, 0 to 4, 5 to 11, 12 to 15, and more than 15 is considered excellent. So there are two ways of doing it. You can remember both these ways. Now, frontalis action is important for you to measure in patients where tarsofrontal sling is planned. Generally, frontalis action is between 8 to 10 millimeter. That means the amount of excursion of the brow that is possible for a patient. So you can mark a dot at the center of the brow where the pupil is being bisected. So you drop a perpendicular from the brow, pupil bisecting, there you may mark a dot and ask the patient to elevate the brow. The amount of excursion is measured as frontalis action, which is supposed to be about 10 millimeter. Now there are other concepts such as margin crease distance, tarsal platform show and brow fat span. Margin crease distance is important in patients where you are doing surgery so that you match the margin crease, lid margin and the crease distance. This is the margin crease distance. So this is always estimated. In extreme down gaze, the lid crease disappears. So as the patient starts looking up, at the first point where this lid crease appears is measured as margin crease distance. So extreme down gaze, it disappears. As the patient starts looking up, the point where lid crease appears is measured as margin crease distance. Whereas tarsal platform show is more physiological, it is measured in primary position. That is the tarsal platform show. So tarsal platform show is also a way of measuring margin crease distance, but that includes the physiological concept that there is some amount of overhanging of the lid skin over the margin crease distance. So if this is the lid crease, some amount of skin overhangs when the patient looks in primary position, and what is seen, the amount of the lid tissue seen between the lash line and the overhanging margin is called tarsal platform show. This is the tarsal platform show. It can be measured in various positions in the pupillary axis, lateral limbus and extreme lateral for blepharoplasty, and brow fat span is from this point to the highest position of the brow, including the hairline. So basically brow fat span and tarsal platform show are important for blepharoplasty. Other concepts are vertical lid height. Vertical lid height is reduced in patients who have blepharophimosis, and also 18 millimeter of vertical lid height is important for you to leave in patients who are undergoing blepharoplasty. Now vertical tarsal height is important in patients where you are performing Fastenella Servet procedure. At least 8 millimeter of the tarsal height is important for the patient to have before you consider Fastenella Servet procedure. Skin quality is assessed if you are considering blepharoplasty. Lower lid retraction has to be noted. Lag of thalamus and orbicularis function have to be noted. Now the next step is about synkinesis. What is normal synkinesis or Marcus-Gunn phenomena? What is it? Synkinesis with which muscle? Lateral pterygoid and levator. So what happens when the patient moves the jaw in the opposite direction? Lateral or external pterygoid comes into action, and if the lid elevates during that process, then that is called Marcus-Gunn jaw winking phenomena. All other synkinesis are not Marcus-Gunn jaw winking phenomena. It could be with internal pterygoid, it could be with mylohyoid, digastric, buccinator, even temporalis. So unless you use all the muscles of mastication and facial expression, you would not have ruled out if the patient has synkinesis or not. So it's a good idea to go through the entire motion and then say that the patient does not have synkinesis. Then ocular motility has to be examined in all the gazes and recorded. And when the patient has strabismus, pay specific attention to pseudotosis. Now there are two variants of pseudotosis, one of which is because of lack of mechanical support. Like this patient has an ophthalmic socket and she is wearing a prosthetic eye. Because of volume disparity, there is some amount of loss of support to the lid, there is a higher lid crease, there is deeper supratarsal sulcus, and there is some amount of ptosis. That is pseudotosis because of lack of mechanical support to the eyelid. But if a patient has monocular elevation deficit, now this patient has severe ptosis in the left eye, and you see that the left eye is not moving up at all. This is double elevator underaction, currently called monocular elevation deficit. In such patients, you are supposed to evaluate with right eye fixing and left eye fixing. With the right eye fixing, you can see that the amount of ptosis is more, and you have already determined that her left eye is not moving up. But when you ask the patient to fix with the left eye, you can see that there is a difference in the amount of ptosis. At least 2 to 3 millimeter of ptosis had got corrected, because now she is fixing with the hypotropic left eye. So the real amount of ptosis now is this. What it means is that once the patient undergoes extraocular muscle surgery to correct hypotropia, this is the amount of ptosis that you will be left with, and you are supposed to correct only that, not this, right? So the difference between this and this would be the amount of pseudotosis that the patient has. So if a patient has MED or ocular motility restriction in vertical directions, then you are supposed to assess ptosis with both right eye fixing as well as left eye fixing. The next bit is about Bell's phenomena. Bell's phenomena, normally the Bell's is a protective reflex. The eyeball moves up and out. If it is moving up and in, that is called reverse, and if it is moving down, that is called inverse Bell's phenomena. If it is moving in different directions at different points in time, that is called perverse Bell's phenomena. Now, Bell's is quantified as good, fair and poor. Good is when you lift the lid to the limbus and ask the patient to forcefully close the eye. If at least 2/3 of the cornea disappears under the lifted lid, then that is called good Bell's. 2/3 to 1/3 is fair, and less than 1/3 is poor. That is standard way of quantifying Bell's. So first you say whether Bell's is normal, reverse or inverse. If it is inverse, obviously there is no good way of quantifying Bell's. If it is normal or reverse, you can quantify Bell's as good, fair and poor. Then you look at the eyelashes. Normally eyelashes are supposed to point up and out, right? But if the eyelashes are pointing horizontally or are pointing down, that means that the patient has lash ptosis. This is important for you to assess, because if you are doing a posterior approach ptosis surgery, lash ptosis will become worse. So you should be careful with that, and any patient who has pronounced lash ptosis, you might want to consider anterior approach surgery. Tear function and corneal sensation are bound to be assessed. Now, drug tests. Phenylephrine test can be done using 2.5, 5 or 10%. Classically, it was described with 10% actually. Then they started underdosing, and there are studies which have used 2.5% and 5% as well. 2 minutes and 2 millimeter, you should remember, is considered to be positive. So at the end of instillation of phenylephrine, it is always instilled at the upper limbus or the superior cul-de-sac. Ask the patient to close the lid, and after 2 minutes reassess, and if the elevation of the lid is more than 2 millimeter, then that is considered positive. There are some delayed responders. If a patient has no response at 2 minutes, then you're bound to wait for 5, 10 and even 30 minutes. About 80% of patients would respond at 2 minutes, and 20% of response may be delayed responders. So if you want to declare the test as negative, then you have to wait for at least 30 minutes. That is when you declare the test as negative. The indication of phenylephrine test is if you are considering the patient for mullerectomy. If the phenylephrine test is positive for 2 millimeter ptosis, you would excise 8.5 millimeter of Muller's. In patients with blepharophimosis, you do additional measurements. You do interpupillary distance and you do intermedial canthal distance. IPD divided by 2 would be the normal intermedial canthal distance. If it is more than that, you consider the patient as having telecanthus. Then you differentiate whether the patient has telecanthus or hypertellurism. That's a radiological sign. But of course, you can estimate where the medial orbital wall is. Intermedial orbital wall distance should be equal to interorbital distance generally. If it is more than that, you clinically classify this patient as hypertellurism, of course awaiting radiological confirmation. You also measure vertical lid height in blepharophimosis, lateral limbus to lateral canthal distance, medial limbus to medial canthal distance and horizontal palpable fissure. These additional measurements are important in patients with blepharophimosis. In acquired ptosis, we have involutional, myogenic, neurogenic and mechanical. Forgetting about the classification, Just in involutional ptosis, there are three mechanisms: disinsertion, dehiscence, and degeneration, which is fat infiltration. Now, in those patients, there are additional features. They tend to have bilateral, symmetrical, or asymmetrical ptosis. They have worsening of the ptosis in down gaze, which is a very characteristic phenomena. You see that this patient hardly has any palpable fissure in down gaze. They also have a eyelid crease. They have deep supratarsal sulcus, and despite all that, they have excellent levator action. One more thing that happens is that they have disparity of medial limbus to medial canthus, lateral limbus to lateral canthal distance, which is normally supposed to be 2:3. That becomes almost 1:1 because of lateral canthal tendon disinsertion. If this is a normal lateral canthal angle, that becomes rounded in patients who have aponeurotic ptosis. Consequently, the distance of the lateral limbus to lateral canthus becomes narrower. That is one additional feature. That is called canthal dehiscence. And since they have a thin lid, when the patient looks down, if a patient is fair complexion and if you have a bright light, then you actually see the uveal reflex shining through the lid, a darkish reflex that you see at the upper edge of the tarsus. Other tests for myasthenia would be fatigue, Cogan slit twitch, enhanced orbicular peaks. I don't have time to describe all that, but test for myasthenia, sleep test, of course, clinically you can't do. Eyes test is the standard, 80% sensitivity and 98% specificity, which means that if eyes test is positive, most likely the patient has myasthenia, 98% specificity. But if the patient is negative, then you cannot exclude myasthenia gravis. So if a patient has a clinical signs of myasthenia gravis, if eyes test is negative, you go on to one of the drug tests. Edrophonium is currently not available, so we use neostigmine, 1.5 milligram in adults, and the time that you declare neostigmine test as negative is again 30 minutes. Then you can go for repetitive nerve stimulus, etc. 20% decremental response. Just to show you the response in eyes test, this is a patient with bilateral myasthenia ptosis. You can see with eyes test, she almost has a lid retraction and improvement in extraocular movement after neostigmine test in the same patient. In patient with CPO, you do muscle biopsy to rule out red rag fibers. That is confirmatory on Gomori's trichrome stain. Last bit is about drug tests for patients who have Horner syndrome. They have myosis, anisocoria, and poor dilatation. So this is the path that we follow. If anisocoria is greater in dark, you estimate if there is dilatation lag, whether it is yes or no. You apply 1% apriclonidine. If only the affected pupil dilates, then that is Horner syndrome. Then you do 1% phenylephrine. Neither pupil dilate, then it is preganglionic Horner syndrome. And if the affected pupil dilates, then that is postganglionic Horner syndrome. No time to explain this. All right. So video, I'll put it in the handout. So finally, logical approach to ptosis helps. That will help you determine what surgery would you undertake for the patient. Thank you so much.
Thank you, Santosh. Thank you. I think he answered everything so beautifully, covered everything. Just till Mukesh takes over, you have to differentiate between congenital and acquired. Acquired, you know, the myogenic, neurogenic as being the commoner causes. Congenital, you evaluate whether it is unilateral or bilateral, what is the amount of ptosis, what is the levator action, whether there are any associations, and those will determine your choice of surgery. So now we'll go on to Mukesh again to tell us about the management based on these considerations.
Good morning, everyone. So Dr. Santosh Honawar has described all the evaluation part in great detail, and I would now be describing about the management part and highlighting the basic principles of management. All right, so we are having some issue here with this laptop, no issue. So there is no display in my laptop, fine. So this part, classification, Dr. Santosh has already described it. So what is the ideal age of surgery in any case of ptosis? Ideally, it is in congenital ptosis. We are talking about congenital ptosis now. So ideally, congenital ptosis should be operated at around 4 to 5 years of age. Why this age is chosen? because at this time we believe that tissue development has occurred in majority of the patient. And also if you delay surgery beyond this time, then there are chances that the child will develop psychological problem, and those problems may remain lifelong. So you should not be delaying surgery beyond the school going age. There is an exception to it. We operate case of ptosis early if there are chances of amblyopia. If ptosis is covering the pupil, then we have to operate the child early. And early means we can operate it at 2 months of age also, after 3 months of age, anytime it can be operated. Generally, it should not be delayed beyond 6 months of age, because at that time the retinal preference start building up. And also you will have to always refract patient of ptosis under cycloplegia, because many of the time there is anisometropic amblyopia associated with ptosis. So you have to rule out that also. So evaluation of ptosis, though it's been dealt beautifully by Dr. Honawar, but there are 4 points which are of great importance in management. So you have to really remember these 4 points in every case of ptosis. One is amount of ptosis, then the levator function, amount of levator function which a patient is having, and also the Bell's phenomena. If there is poor Bell's, then it is a kind of relative contraindication for any ptosis surgery. And also whether ptosis is simple or complicated. Complicated means when it is associated with other problems like Marcus-Gunn phenomena or elevator palsies. Then there is one mnemonic, bad sign for ptosis surgery. In bad, B stands for poor Bell's, A for corneal anesthesia, and D for dry eye. So if any of these 3 is present, one has to be very careful before operating the patient. Now, this part we have already discussed it in our previous lecture, so I will not go into these details. Now, what are the treatment options for any given patient of ptosis? If ptosis is mild, then there are options like Muller's muscle conjunctival resection or Fasanella servate resection or Levator resection. We will discuss all these 3 procedures one by one. If ptosis is moderate, when we label ptosis as moderate, anyone? If it is 3 millimeter. So if it is moderate, then the primary treatment modality is levator surgery, whether resection or plication. And if ptosis is severe and it is bilateral, then the procedure of choice is Frontalis sling always, there is no second doubt. If ptosis is unilateral and it is severe, then there are other options also. Sometime we may do levator resection if levator function is say around 4 millimeter or so. If it is less than 4 millimeter, then results of levator resections is not very good. So in these cases, we again do Frontalis sling. Now, surgical management for mild ptosis, as Dr. Santosh has described, I have told you there are 3 procedures available in our armamentarium for mild ptosis. One is MMCR, Muller's muscle conjunctival resection, second is Fasanella, and third is levator. When to choose Muller's muscle resection? If there is phenylephrine test positive, it means if Muller's muscle is functional. In some of the patient it is not functional, then if you do surgery on Muller's muscle, patient will not have any effect. Classical example of this is Horner syndrome. In Horner syndrome, Muller's muscle is not functional. So if you do Mullerectomy, there will not be any effect. So we do Fasanella servate resection as a procedure of choice for Horner syndrome. This we have already discussed. This was discussed by Dr. Santosh. So if ptosis is moderate, I have already told you levator procedures, they are the procedure of choice, and ptosis is severe, either Frontalis sling or levator resection or Whitnall sling may be done. Now, how Fasanella servate resection is done? Here we primarily resect out tarsus plate along with conjunctiva, and every 2 millimeter resection of tarsus plate will correct 1 millimeter of ptosis. So this is the most predictable ptosis surgery. But the limitation is that you cannot cut more than 4 to 5 millimeter of tarsus plate, because you have to leave at least 4 to 5 millimeter of residual tarsus plate in lid for its mechanical strength. So in Indian scenario, we have only around 7 to 9 millimeter of tarsus plate in our upper eyelid. So obviously we cannot resect out more than 4 millimeter of tarsus. So, a brief video, I don't think lid is everted. Now the problem is that cursor is not here. So one can use stay sutures, or one can use the clamp also, and then this tarsus plate would be resected out. So I think I'll omit out the further details. Now this is about conjunctiva mullarectomy. A Muller's muscle clamp Putterman's clamp is like this. So we grasp Muller's muscle along with conjunctiva from the internal surface, and then we resect it out. Again, we can have few steps. So we evert lid like this. We mark conjunctiva, and there is Muller's muscle inside the conjunctiva. So this is around 4 millimeter. So it will be double breasted. So in turn we will be resecting around 8 millimeter of Muller's muscle. Again sutures are passed, and then the clamp would be passed. So this is the clamp which is passed, and this clamped portion is resected out. So levator resection, as I told you, it is the preferred technique for most unilateral cases, procedure of choice for moderate ptosis, but can be done for mild ptosis and also for unilateral severe ptosis. Amount of resection is dependent on preoperative finding, that is amount of resection is dependent on preoperative finding, that is amount of ptosis and the levator function, and also on operation theater finding. We majorly rely on OT finding. OT findings means we leave lid at the intended position. And what is the intended position? I'll tell you. Horns, lateral and medial horn, they are extensively cut if we are dealing with a severe ptosis. And of course, Whitnall's ligament is the most important ligament for levator surgery. It is the junction between aponeurotic part and the muscular part of levator muscle. And we obviously cannot resect more than Whitnall's ligament, because then we will be encroaching into the muscular part. So we do not want to resect the muscular part. So length of levator aponeurosis is variable in all patients. It is not uniform. In Indian scenario, it is found between 18 millimeter to 30 millimeter. So obviously Whitnall's ligament, it is of great importance. So it is the basically end point of aponeurosis. Minimum part of levator aponeurosis which has to be resected for any effect is 12 millimeter. So if you resect less than 12 millimeter of levator aponeurosis, there will not be any effect. So you will have to play between 12 millimeter and the Whitnall's ligament, which is there at 18 millimeter, 20 millimeter, or 25 millimeter, based on the individuals. So when, as I told you, what is the intended operation theater lid position where we want to keep the lid? If levator action is poor in a given patient, then we leave the lid higher than the intended position, that is above the limbus. If levator function is fair, then we leave lid at limbus on 1 millimeter below the limbus. And if levator function is good, then we leave lid at its normal position, which is 2 millimeter below the upper limbus. So this is the general guideline which we follow. We do not go by the Putterman's method. What is the Putterman's method? Here MLD is taken, which is the distance between middle of upper lid margin to the 6 o'clock limbus in extreme up gauge. Normal MLD is 7 to 9 millimeter, and difference between MLD of two sides is multiplied by 3, and this will give you the amount of levator resection required for that particular patient. But this does not hold true in all patients, and we seldom go by this particular method. We go by the operation theater findings. So these are certain results of levator resection. So again, I'll show you just half a minute of this levator resection surgery. So lid crease is marked. We also mark the place for 3 sutures. I think I don't have time to show you this. Then the Frontalis sling. Indications are bilateral severe ptosis, procedure of choice, no other question. In unilateral severe ptosis with poor levator action, again this is the procedure which can give you result. Now what are the various materials which can be used? Autologous or the artificial. Autologous, best autologous is fasciolata, or we can use palmaris longus tendon, etc. Artificial material, best artificial material is silicone rod, though there are non-absorbable sutures which can be used. So nowadays silicone rod is employed more and more because it is potentially reversible. This is the real advantage. It gives you least lid lag and leg ophthalmos, readily available, shorter duration, almost equal efficacy than the fasciolata, and complication rate which is acceptable, though not nil. So, but there are certain complications of silicone rod. That's why fasciolata still have its own role. So fasciolata is very strong material, but supple material, more physiological. It definitely scores in tighter lids like blepharophimosis syndrome over silicone rod, and its elasticity is almost equal to silicone, and it virtually eliminates all the complications of silicone sling like extrusion, foreign body granuloma, infection, slippage. Here we are looking at a patient with granuloma and extrusion of silicone sling. So, but for fasciolata, you need to make extra thigh incision, you need to retrieve fasciolata. There is some difficulty in harvestation and strip making. And obviously, it is not possible in very young children because you don't have sufficient length of fasciolata developed in those children. So, for any Frontalis sling, there are various methodology. One is Crawford double triangle method, where you use 2 strip per eye or 2 silicone strip per eye or 2 fasciolata strip per eye, and they are passed in a double triangle manner like this. Then the other is Fox's pentagon, where 1 strip per eye is passed in a pentagon manner. So generally we are following nowadays Fox's pentagon method. For silicone sling, you should never reuse it, otherwise there are more chances of granuloma formation. You have to titrate the tightening. And very important point is you will have to make a long tunnel and leave cut end of silicone deep inside that tunnel to avoid the extrusion. So this is a very young child, I think 1-year-old child, and ptosis was covering pupil, so we are operating this child early, and again a silicone sling in a pentagon manner is passed. So pentagon incision is marked. So these 2 incisions above brow are in line with medial canthus and lateral canthus, and there is then 1 central incision, and 2 marks above the lash margin are generally on either side of limbus, but there are other finer points also. So once you have made these incisions, you can make them by knife or by the cautery. Then you pass your silicone rod. This is a very simple procedure, can be done by anyone. So that's why I am showing video of this particular procedure. So now it is important to undermine the skin and to make a long tunnel here, so that you can bury your ends of silicone rod inside here, and there are very minimal chances of extrusion. So this is how they are available. 2 needles are there at both the ends. You remove out the sleeve and pass. You can cut the sleeve in 2 halves, or you can utilize whole sleeve for one case. Then just pass your silicone rod in this track which we have made. So this is the final post-operative appearance. So generally we combine this sling with skin muscle excision also to have a good prominent lid crease and good fold. We do not want overhanging folds. So these are some of the pictures of sling. If you do unilateral sling, there are certain problems. There will be variable lift at various different time periods. There will be unilateral lid arching, cosmetic blemish, unilateral lid lag like this, which is more pronounced. So it is less physiological. So to avoid this, we do bilateral. We try to do bilateral sling surgery also on the healthy lid. We try to convince patient that there will not be any harm to the healthy lid by doing surgery bilaterally, but patient will be better cosmetically. So most patients, they allow us for this. I don't think I have a time for facial at a sling surgery video. So nowadays we are retrieving facial aorta through a very small incision manually. So these I think we have already discussed. So I'll not go into these details. So then a word about the complicated ptosis. Elevator palsy, you have to differentiate true ptosis with pseudotosis, as Dr. Honauer has told. Just cover the other eye, you can see ptosis has disappeared. So this was a pseudotosis because of elevator palsy. Then the Marcus Gunn ptosis. The best result in Marcus Gunn ptosis is bilateral levator excision with sling. Then only you can obviate the Marcus Gunn phenomena. So you just resect out and you just excise out the levator aponeurosis and then pass the sling. So then only the Marcus Gunn phenomena is eliminated. So this is the best procedure. If patient allows you, do it bilaterally on both the lid. If patient does not allow you, then you will have to obviously do unilaterally. If Marcus Gunn phenomena is insignificant, then we can deal ptosis as any other ptosis by doing levator resection. But you have to be really cautious because Marcus Gunn may increase after the surgery, after the levator surgery, because you are strengthening the levator. So these are the photograph pre-operative and post-operative Marcus Gunn surgery after bilateral levator excision and sling. You can see Marcus Gunn has gone. So this is blepharophimosis syndrome. Generally there is
Beautiful music, Mukesh.
So generally there is two-stage protocol in blepharophimosis. In one stage we correct telecanthus and also the lateral canthoplasty is done. In second stage we do frontalis sling. It can be done as a single stage protocol also, wherein telecanthus along with the lateral canthoplasty and ptosis, everything is corrected in one go, but results are suboptimal because you are doing horizontal as well as vertical stretching both in one stage, so results will be suboptimal obviously. Acquired ptosis, Horner syndrome, we have already touched it. So as I told you, any surgery on Muller's muscle will not be helpful in Horner syndrome because it is paralytic. Ptosis is mild, so the procedure of choice is Fasinella servate. In third nerve palsy, you will have to first do the strabismus surgery. If there is some amount of Bell's phenomena, then only ptosis surgery is done, or a suboptimal lid lift can be planned because there are high risk of exposure keratopathy in these patients post-surgery. Myasthenia gravis, this part Dr. Santosh has already dealt. CPEO, again in this particular condition, there is movement restriction all over along with ptosis. So there will be poor Bell's and you will have to be very, very careful before doing any surgery. Obviously, we want under correction after surgery also. Aponeurotic ptosis or senile ptosis, you will have to identify the defect in aponeurosis and reattach it or plicate it. So this part Dr. Santosh has already discussed, and I don't think I have time to go through this. So to conclude ptosis management, there are various options which are available, but we have to take a tailored approach for every case according to the suitability, and obviously realistic results and side effects should be explained to the patient. Now there are few of the questions, 3-4 questions for you. For Marcus gun phenomena, just to check whether you were listening to my presentation or not. So what is the treatment of choice? Third, it is levator resection plus frontalis sling. So it is not resection, it is excision. Resection means you are resecting the aponeurosis and reattaching it to the tarsus plate. So if you do resection, if you reattach levator aponeurosis to the tarsus plate, Marcus gun will increase postoperatively. So you are excisating. You are just throwing out the aponeurotic part. So the right choice is 4. Now for Horner syndrome, what is the procedure of choice? Passanella servate resection, obviously, because as I told you, mullerectomy will not be successful. Most important landmark for levator aponeurosis? Wittnall's ligament. Ptosis is an infant. What is the procedure of choice? Infant. Infant is less than 1 year. Facial atta is not fully developed till 4 years of age. So in infant, you need to do artificial material sling, silicone sling. Thank you for your patience here.
Thank you, Mukesh. Brilliant exposition where you have classified the ptosis very well and identified the right procedures and explained the principles. Any questions? None needed. Thank you, Mukesh.
So now it's my pleasure to introduce Dr. Ashok Grover, our chairperson. He is teacher of teachers. Virtually one generation of oculoplasty surgeons, they have learned from him directly or indirectly. We are truly blessed to have him here between us. He has occupied virtually every big society at its helm. He was president of All India Ophthalmological Society, Asia Pacific Oculoplastic Society, and Indian Society, and many other societies. It's always a pleasure listening to you, sir. We welcome you here today.
Thank you. Thank you, Mukesh, for those very kind words. And Rolika, I have a bottle today. So if I'm nervous and my throat is parched, so I'll be speaking to you on eyelid repair and reconstruction, a systematic approach. Thank you, Santosh, for having entrusted me with this subject. Switch it on, please. So we'll be going about it and discussing how these defects occur, how to evaluate them, and how to go about deciding our line of management and how to carry them out. So eyelid defects may either be congenital, which is unusual. Congenital colobomas are not so common, and the acquired defects are much more common. So so we look at the aspects of what are the requirements, what are the indications where we carry out a management, what are the basic principles. We look at evaluation, and then we look at management for those defects which are partial thickness or non-marginal. Then we look at the full thickness defects, how to manage them. Then we look at the use of flaps and plasties within those previous headings. And then we look at how particularly to concentrate on making sure that we reconstruct back the lateral and the medial canthus. So the congenital defects are relatively rare, as we said. They can be unilateral or they can be bilateral. Unilateral ones usually are milder, usually present at the junction of inner third and outer third, and the bilateral ones are more often severe, as you see in this. Do you have a brighter one? Okay, I'll use the mouse. So bilateral one, as you see in the center below, are often associated with a variant of a pathology where you have skin going on to cornea, and these are often associated with exposure keratopathy. So these may require urgent management at an earlier date if there is an exposure keratopathy. Others you can wait for a while. The most common cause for acquired eyelid defects is the surgical resection of eyelid tumors. When we manage our tumors, which are the basal cell carcinomas, the squamous carcinomas, and more commonly in our country, sebaceous carcinomas. Traumatic defects are common, burns, irradiation, and due to previous complicated surgery. Earlier we used to get those colobomas after entropion corrections. So when we look at the reconstruction, we have to think of the eyelid as two basic laminae. The front one constituted by skin, orbicularis primarily, and the posterior one constituted by the conjunctiva and the tarsus, tarsal plate, molars, and of course the levator muscle. So when we do a reconstruction involving a full thickness, we must reconstruct both laminae. In others, you may need to do just one lamina. When we do both laminae, generally the principle is that at least one lamina you need to have with intact vascular supply, because only then the other lamina, which you reconstruct either as a free graft or something, will be able to take up its vascular supply. So when you are planning, you need a good thorough evaluation, as in every other case. You need to see whether upper lid is involved or lower lid is involved. Functionally, the two are different. Upper is much more important for the integrity of the globe because of its protection and because of the lubrication that it carries out, and you have to have that consideration when you do your repair. You need to see whether it is partial thickness or full thickness defect. We already spoke about it. Then those that are full thickness, you have to look at whether it involves the margin or not. Then size of the defect, which will again determine what kind of repair you would carry out. We'll look at that in more detail later. And the shape of the defect. Many shapes are not so suitable for reconstruction, and we may need to convert them to a more friendly shape before we carry out a reconstruction. So management of eyelid defects, let's now look at the non-marginal ones, full thickness ones of different size, and the canthal defects. So in the non-marginal partial thickness eyelid defects, generally the principle is that you would convert these into an elliptical shape in order to excise them and close them without tension, which is the basic concept. So if you cut them like this, along the lines of tension, the Langer's line that you would remember from your surgery days, general surgery days in MBBS, and close them without any tension. In the upper lid, you prefer them to be parallel to the eyelid margin like this, and in the lower lid, you generally try and avoid any horizontal incisions because they're very sensitive to outturning of the margin. So any horizontal shortening done here would lead to an outturning. So you try and convert a defect like this into a vertical defect and close it vertically to avoid outturning. But if the defect is larger, then you don't want to have any tension, particularly in the lower lid, because that would cause an ectropion. So you may use a flap or a free graft of skin like this. So let's look at an example of a partial thickness defect closure. So this is a so-called kissing nevus, which develops in equal part in both the upper and the lower lids. Here we've been able to excise only the skin and replace it with a full thickness skin graft. So that's why you could preserve the canthus so well. Here we have a defect like this where a flap like this could be mobilized and used to close the lid, because in the lower lid we could not afford to close this vertically and cause an ectropion. Now let's go on to the marginal defects which involve eyelid margin. So up to 1/4, and in older subjects even larger, 30 to 40%, particularly if combined with lateral canthotomy, which means there is an incision at the lateral canthus, and cantholysis, which implies that the crus of the lateral canthal tendon of the corresponding lid is also excised, which means in the lower lid you would take your scissors down between the conjunctiva and the skin and go between the two laminae and cut the tarsus here, the tarsal support here. So you would do a cantholysis also, release this lid so that the tension is gone and the closure can be done directly. So canthotomy and cantholysis can be a good addition where you want to do a direct closure. So let's look at the principles. So we're doing closure by, what happened? Stop moving. So it is done by 3 sets of vertical mattress sutures at the margin. The first one is placed at the gray line. Let's see if it works. Too large a file. So first set of sutures is passed at the gray line or just behind the gray line in the firm tarsus, passed as a vertical mattress suture, which implies that it goes vertically down at about 3 millimeters from the cut edge, goes 3 millimeters into the wound, goes to the opposite side, comes out again at 3 millimeters here, and then goes back from this side 1 millimeter from the cut edge, 1 millimeter depth, comes out here at 1, goes in again here 1 millimeter depth, comes out here. So this is the first suture, which is the gray line suture, and then you pass corresponding sutures closer to the posterior margin as a vertical mattress suture and closer to the anterior margin as a vertical mattress suture. So all 3 would cause a good apposition, ensuring anterior end is closed well, posterior end is closed well, and you have a good apposition with a little vertical pout which would flatten out with the healing. Next, you close the tarsus with 1 or 2 sutures of 5-0 vicryl, which would ensure apposition of the posterior lamina, and then you close with a 6-0 suture, nylon or silk. Stuck. It will move, hopefully. We live on hope. So the marginal repair is the most crucial technique that you need to know for your entropion repair, ectropion repair, for lid reconstructions, for trauma repair. So this is something that you must learn well. So the same principle has been applied here. This is a small basal cell carcinoma, 4 millimeter margin on either side, pentagonal excision. Whenever you do an excision, it has to be perpendicular to the margin like this, vertically on the tarsus, and then you convert it into a pentagon, which is the best shape for an excision, and then you can carry out a direct repair and you would not even know that there has been a defect. If the defect is larger than that, then you need several other techniques. We'll talk about Tenzel's lateral semicircular flap, which is essentially a rotation of the anterior lamina from outside the lateral canthus. We'll look at that. You can use various kinds of skin flaps. As an example, we'll talk about these two. Then we have lid sharing techniques where we are doing a reconstruction by using at least one lamina or both laminae from the opposite eyelid. Say for the lower lid from the upper lid, and for the upper lid from the lower lid. Generally, you would tend to compromise the upper lid less often. You'd be happier using the lower lid for the upper lid because the upper lid is more vital rather than the other way around. But we do carry out those procedures very well and without any complications. Then there is this full thickness rotation flap of Mustade, which we'll briefly mention, not used as often. So let's look at the Tenzel's repair. So this is a congenital coloboma. So there are two things that we are doing here. One is to have raw edges, otherwise healing will not occur. And second, converting it into our pet pentagonal shape, as you know. So this is being very little excision on the sides, and then we have this pentagonal shape, and we are drawing this flap, which for the upper lid will go down like this and come here. For the lower lid will come up like this and go here, up to about the lateral orbital margin. Now we're doing a lateral canthotomy and cantholysis that we spoke about. Then we are undermining the skin muscle in order to mobilize that to cover the defect in the upper lid. We must fully make it free. And then we are looking at the residual conjunctiva that we have, and we are going to do a marginal repair. So this video works. You can see how we passed a vertical mattress suture, first at the gray line, then posteriorly, then anteriorly. Leave all these threads long and tie them in the anterior most so that they will not rub against the globe. Tarsus closed with partial thickness bites so that they don't cause irritation on the conjunctival side, and then the skin closure. Now we have to reconstitute the lateral canthus in its original position, making sure we maintain this angulation, which is so vital for the proper aesthetic appearance. And therefore the fixation to tarsus will also be important for the lateral canthus. And then we subcutaneous closure and skin closure, and make sure that the fornix has not become shallowed. So if it has, then we create a fornix forming suture by double arm suture, pass through the fornix and tied over a bolster, which here is a polythene tube. So this explains several of the principles that we use in reconstruction. Here we've been able to mobilize this from the anterior lamina from outside. So this is the principle. So an example is this patient with trauma where there is abnormal canthal apposition that was carried out. So there is canthus is attached here. So we'll detach that. And then there is this defect. So we will do a Tenzel's. This is upper lid, so rotation like this. And then we carry it out with the same principles we spoke about, marginal repair, mobilizing this anterior lamina here and closing this defect. So you are able to get a good margin with lashes all along, and you have a good looking lid. Now, we'll talk about tarsoconjunctival flaps also, but let's first look at skin flaps. Now, skin flaps can be mobilized from a number of locations, wherever there is extra skin that can be utilized. So, what is the advantage of flaps over grafts? That they come with a blood supply, and therefore you can use a free graft for the other lamina. So, this is the big advantage. So, if you take it from the upper lid, this is a Tippier's flap, which we are utilizing for an anterior lamina defect here, and a Freak's flap where we are going above the brow and taking a flap here. There are several which you can take from this aspect here, flap which is shaped like a triangle. You can take it from here. You can utilize other flaps also, but generally you can't take tissue from the lower lid. That is the basic principle. We'll talk about flaps which we can take from the midline here, the glabellar and the midline forehead flaps. So all those flaps can be used for skin or anterior lamina. So let's look at an example. So this is a basal cell carcinoma in the right lower lid. By the time we excise it, it is a reasonably large defect of about 10 millimeters or so. Can't be closed with the direct suturing. So we are using tarsoconjunctival flap from the upper lid. We have to always, as Mukesh emphasized, leave behind about 4 millimeters for the lid to survive. The rest of this can be mobilized as a flap, which has reconstituted the anterior lamina. But for the posterior lamina and for the anterior lamina, we have used the trippier flap from here, mobilized it down here, and we have a closure both of the anterior and posterior lamina. 4 weeks later, we have opened up the tarsoconjunctiva, and we have a well-formed lid here and a well-maintained lateral canthus, as you can see here. Now let's look at the lid sharing. Why would you do a lid sharing? One important thing is eyelid tissue is a better match than any other. If you want to take tarsoconjunctiva or skin, no other tissue can provide a better match. Both laminae can be repaired by lid sharing, and it is a very versatile flap. Like we look at the tarsoconjunctival flap, you can use it for a defect at the lateral canthus. You can mobilize it like this and use it at the medial canthus. You can use it for the lower lid from the upper lid. You can use it from the lower lid for the upper lid. So it is a very, very versatile thing and gives you both the support of the tarsus, if you are able to get it, and the inner lamina, the conjunctival lining, which is the best lining for the globe. But there are situations when you need to avoid it. In infants and young children, you would close the eye for 4 to 6 weeks, which may be causing an occlusion amblyopia, so that consideration is important. And tissue laxity is often not adequate. If you've had a previous surgery on the opposite eyelid, there would be scarring, you would not be able to use it. And as we emphasize, you always need to be cautious. When you're using the more vital upper lid for lower eyelid, you should be a fairly proficient person who would give a good result. So let's look at the use of tarsoconjunctival flap. We already gave an example there. Here you have an upper lid defect. So we have mobilized, after leaving these 4 millimeters, a large flap which is covering the lateral canthus also. We have reconstituted the lateral canthus with that, and we've taken it up to join with the rest of the conjunctiva that was left after the excision. So this is also called the Hughes flap when we use the tarsoconjunctival flap from the lower lid. So let's look at this sebaceous carcinoma here. Here again I'm showing this video because it highlights several principles of excision. The no-touch technique, where you will not touch the tumor zone much, so you have taken about 4 millimeter clear margin on both sides. Don't think of what you are excising, think of what is necessary to excise. And remove that, achieve a hemostasis, send these corners for your report of frozen section, which showed that there was additional involvement, additional excision done. Now we are marking the tarsoconjunctival flap from the lower lid. You can see we've saved about 3 to 4 millimeters at the margin to retain the marginal plexus here, and then we are mobilizing the rest of the tarsoconjunctiva by 2 vertical incisions, which are then being anchored to the remaining part of the tarsoconjunctiva, closing the posterior lamina, doing a lateral canthal anchoring also, suturing to the tarsoconjunctiva on the 2 sides as well. Can do a direct suturing, or as you will see on one side, a tongue in groove to ensure that conjunctiva goes between the 2 laminae. You can use that kind of suturing. Anything will do, provided it is a strong enough thing. You've taken enough not to create any tension. So once you have done that closure of the posterior lamina, then you have to think of anterior lamina. One option is a free skin graft, which you can take from post-auricular area or supraclavicular, most often post-auricular. But here, because the patient is old, we had enough skin available in the upper lid. It was lax enough, so we have mobilized it as a skin flap from the upper lid itself, closed it, and then tarsoconjunctival flap can be opened in 4 weeks' time. Important thing, remember in opening is that take a little bit of extra tissue because it will come back a little. Take conjunctiva extra because you would like to rotate, flip that over and put it anteriorly. Your margin must be constituted by conjunctiva rather than skin be allowed to come down to cause a keratitis. And then reconstitute the lateral canthus well. You have a well closed lid. You need to have a good anchoring on the lateral canthus as well. So this is at the end of the surgery. Post-operatively, eye closes well and you have a margin which is lined by conjunctiva. So those objectives are achieved. This is what I was trying to point out. Margin should be by conjunctiva. So let's look at another example here, a basal cell carcinoma which we already spoke about. Here after the excision, we are trying to see whether we can marsupialize the rest of the lacrimal tissue that is left, the canaliculus, so that it functions in some way, or you can intubate it, and then the tarsoconjunctival flap mobilized from the upper lid to cover the upper lid and anchored at the canthus, and then the flap that we spoke about. Okay, so Cutler-Beard procedure is the one procedure that you all are aware of. Many of you have seen it. Here we are sharing both the lamini. So we have a defect here. This is the classical Cutler-Beard with a zone 4 mm all around. Make sure that on frozen section the edges are free, or wait for histopathology before you do reconstruction. If you don't have a frozen section, you can wait for 3 days or something till you get a report from your pathology department to say that your edges are free. Now when you're making the flap, principle is again leave behind 3 to 4 mm because you must retain the marginal plexus in this bucket handle that you are leaving. It's also called the bucket handle procedure, so that there is vascular supply here and it will survive. Then you give an incision like this. Now this dimension is the size of this defect minus 1/4 or something, because that much you can get a direct closure. You can mobilize tissues. And then you create a flap, both of the internal lamina, which is closed like we did in the tarsoconjunctival flap, and the skin flap, which is then closed here like this. And you have this appearance at the end of the surgery. Close this as well. And then after it has healed, 6 weeks or so for the stretching of the tissues to take place, then you do an excision, leaving behind excess conjunctiva, remove the surplus tissue from here, and then you carry out a closure. Residual tissue goes back to the lower lid, close the conjunctiva, close the outer layer, and you have a good reconstruction. Done in a child who already had exposure keratopathy, so corneal closure was not a consideration, and we could do a good repair like this. For the lower lid, you can do an inverse Cutler-Beard, but a little more cautiously. So same 2 flaps mobilized from the upper lid for the lower lid defect, and a good closure. So what was the difference with the Mustardase flap? Here you are not taking the laminae like you have mobilized by leaving a bit of tissue at the margin, but all the tissue including the margin. So here we are outlining a flap which will go up as a full thickness lid, including the margin to go into this defect. So you can see this is closed like this, and then it is opened up after 4 to 6 weeks. So we've understood most of the principles. We have looked at how you can do a direct closure. You have seen how you can mobilize the anterior lamina by flaps from areas where you can spare it, or you have seen how you can mobilize the internal lamina, how you can share the 2 eyelids. Okay. Then we'll look at if you have even larger defects, what do you do? Now you need flaps either from the forehead as a large temporal flap, or from the midline either from the glabellar region or from the forehead region. And you then need to combine it with posterior lamellar grafts. You may use tarsoconjunctiva from the opposite upper lid. That you know that you can spare that 4 millimeters, above 4 millimeters, you can spare tarsoconjunctiva, you can take that as a free graft, or you can use mucocartilaginous grafts like from nasal septum. Plus these two, skin muscle lamina, tarsoconjunctival lamina, you can also rotate the cheek as a whole. Now this is something which is used less often now. Classical mustard is cheek rotation flap, you need to know about it. So for the inner lamina, this is a tarsoconjunctival, free tarsoconjunctival graft that you can take, or you can take a nasal mucocartilaginous graft. So this was the classical cheek rotation flap for a huge defect like this. You had to convert it into a vertical defect like this, as we have done here, and then rotate the whole cheek around like this with a huge flap like this. And take it here, reconstitute the lateral canthus. You have a vertical line of suturing here to do, but you need to have the inner lamina strengthened by a graft which we have taken from the nasal mucocartilage. Let's look at this example where we have used a flap with retained vascular supply based on superficial temporal artery from the temporal side. So a defect which you want to repair from the lateral side, this is an option. This is much bulkier than your normal eyelid, but then it does the job in a situation which is very difficult. So superficial temporal artery blazed flap like this, a sebaceous, huge sebaceous carcinoma, a defect which involves almost both the canthi. So we have very few options, and we've used a tarsoconjunctival flap from the lower lid, and for the outer lamina, a superficial temporal artery based flap, and closed it like this. So which can then be opened and you get a good reconstruction. Now this was a lady who had a basal cell carcinoma for 10 years. She said, I'll never get a surgery done. So eventually when it became so big, she said, okay, give me some therapy. So I advised her biologics that are available. But that's the best way of convincing a patient about surgery, because then she checked the cost of the biologics and it was about 15 lakhs. So she said, I might as well give you 30,000-40,000 and get a reconstruction done. So, but then this was an impossible task. The entire lower lid was involved, entire medial canthus was involved, and upper lid was involved. So we had to do some jugglery from somewhere. So after this excision, we had this defect all over. Then we took a midline forehead flap, which we thought we'll use for both upper and lower lids. We divided and used it for both upper and lower lids, but there was still some raw area. We used some graft here. Then we used the nasal mucocartilaginous graft for the upper lid as well. And this is how she ended up on the table. This is how, when we opened it up, and early post-op, this is how she looked with bulky tissues. Much better after 3 months. We have advised her to get this improved upon, the ptosis improved upon, but she is reluctant so far. So let's now look at the canthal defect. So we now know where to take the tissue from, either from the outer side or from the inner side if the defects are very large. Okay. Now the lateral canthal defects. Now the basic principle here is that whatever residual tissue you have, you will need to attach it to the lateral periorbita or periosteum by starting from periorbita and coming out on outside of the orbital rim on the periosteum, so that you get a good anchorage at the Whitnall's ligament, Whitnall's tubercle or Whitnall's point. So that's where you do a direct attachment, and if you are short, then you can create a periosteal flap from here and use that to anchor it, because you need a firm anchorage in order to reconstitute the lateral canthus. And then of course you can use all the other means to close the lid. So let's look at the principle here. This is a traumatic lateral canthal avulsion. So what we'll do is we'll pass a double arm suture. Here we are using a Prolene. Prolene is a permanent suture, so it gives a permanent anchorage. So you need a double arm suture. If you have a double arm suture, fine. Otherwise, use a needle on the other end. Firm bite through the tarsus and then anchorage here, starting the bite behind the rim so that it is in periorbita and comes out at the lateral. It comes out in front of the margin. And then we are using a needle for the opposite side and taking a bite through the tarsus and then anchoring it again at the periorbita periosteum. And then you can get a good closure. But if in more difficult cases, you may do a lateral orbital rim hole with a drill and use a wire or a proline suture. So an example is this basal cell carcinoma involving the lateral canthus. This is the defect. Tarsoconjunctival graft for the inner lamina, and I have done the lateral canthal anchorage, and this is the post-operative appearance, where we've been able to get a good repair of the lateral canthus and a good angulation as well. So medial canthus, the principle was partially explained by Mukesh. You need to fixate the medial tarsus to periosteum near the posterior lacrimal crest. So you have to expose through the conjunctiva the posterior, the sac, you go behind the sac where the posterior lacrimal crest is and fixate the medial tarsus to that point. And then you can do whatever else. But there is this laissez-faire, whatever the French pronunciation is, spontaneous granulation, which implies that you leave a raw area at the medial canthus behind and it will granulate and heal on its own. What is it called? Laissez-faire or whatever. Okay. So then you have all the other techniques that you can use, but that is the essential principle of medial canthal fixation. So here, talking about it, tightening of the medial canthus. So we give a carancular incision, expose the area behind the sac. We've taken a bite with a proline suture here, and then we'll take the bite through the whatever structure is to be anchored, and then tighten it so that it tightens in that strong, firm periosteal bite. Where that is not possible, you then use those micro plates of titanium with 2 holes or a T-plate where you can fixate that plate with screws on the posterior crest and do that. So this is the tightening. So other ways are the transnasal wiring is something that you can do if you want to fixate the medial canthus, or low profile mini plates which are seen here, which are fixated with screws. So this is an example of a medial canthal avulsion where we have fixated the tarsal plate very firmly to the posterior lacrimal crest, and then we have used this advancement skin flap to close the anterior lamina. So this is at the end of the surgery. So if you consider the defects as partial thickness, full thickness, you think of full thickness ones as small, medium, large. Think of reconstructing the inner lamina with one technique, push the second lamina with the other technique. Whatever tissue you can get, which we have discussed in various ways, you can reconstruct anything and give a particular attention to lateral and medial canthus. Eyelid repair, customized based on properties of the eyelid defect. Partial defects repaired by simple closure, flaps or grafts. Full thickness defects require repair of both laminae, and precise reconstruction of lateral and medial canthus is critical. So to conclude, a versatile combination of techniques with sound knowledge and adherence to basic principles of oculoplastic surgery is the key to success in eyelid repair. Thank you, and visit Antarctica one day, the best place in the world to be.
Thank you, sir. Do we have any question for Dr. Grover? Sir, you have presented a plethora of cases and technique in this half an hour, and that speaks volume about the work which you have done in so many years. It was really wonderful to be a witness to your presentation. So now it's my pleasure to call our next speaker. She is Dr. Vivitja Grover. She is a young dynamic oculoplastic surgeon doing very good work, and she will be speaking today on evaluation of lacrimal system. So we all look forward to hear Dr. Vivitja.
So before I hand it over to Rituja, I'm trying to get permission for you guys to carry your coffee in. Okay, so just give me some time, but just don't get up all in bulk. Please try to divide yourself as much as possible. And if I get the permission also, they will allow just the disposable, but you have to be responsible enough to go and throw it back. Okay, so just give me some time.
Just trying to simplify things.
So good morning everyone, and it's nice to see everyone in a position where I was 5 years ago, furiously taking notes and taking pictures and of course doing a Delhi darshan. And thank you to Dr. Santosh for entrusting me with this topic for y'all. So what do we do when a patient has watering? Before that, I'd like to cover the anatomy a little bit so that you can be a little more oriented just for about 5 minutes before the 15 minutes of lacrimal system evaluation. This is a diagram that all of you must draw in your exam, and me being artistically challenged, if I can draw this, you can draw this as well. So the basic thing is there's 2 mm between the punctum till the proximal part of the canaliculus, then 8 mm of the rest of the canaliculus, 3 to 5 mm of the fundus of the sac, 10 mm of the body of the sac, and 12 mm of the intraosseous nasolacrimal duct, which ends at the inferior meatus by the valve of Hasner, and the middle turbinate with the middle meatus, which is where you create the opening when you do a DCR surgery. So the lacrimal gland, of course, is there in a fossa in the frontal bone, and the lacrimal lake is where the tears pool up before it goes into the punctum. And of course, the punctum lies on a small fibrous lacrimal papilla, the inner epithelium of which is non-keratinized, and it is stratified squamous epithelium. So just a little deviation from this, you should know that the anatomy isn't always very regular. There are certain differences. Either they can form, the canaliculi can form a common canaliculus, or it can just be a point where it emanates from the sac, or it can enter the sac at 2 different points. So these are the various differences that can happen in the population. And the nasolacrimal sac, it is lying in the maxillary bone along with the lacrimal bone, so the anterior and the posterior lacrimal crest. And the rest of the tissues, how is it related to the sac? So the medial canthal tendon, the anterior and posterior limb sort of encase the sac, and the different parts of the orbicularis muscle, that is the pretarsal and the preseptal orbicularis. And part of the pretarsal orbicularis forms the Horner's muscle, which is important with respect to the tear flow. So the other muscle which is important here is the muscle of Riolan, which is another part of the orbicularis, which forms the gray line, as Dr. Grover mentioned earlier. So this Horner muscle, what it does is basically when the eyelid is open, it makes sure that the canaliculus is sort of dilated as well as the sac. So it sucks the tears from the lacrimal pool. And when the eyes are closed, the canaliculi sort of initially dilate and then squeeze out into the sac. So this is how the tear flow keeps happening. The nasolacrimal duct, of course, the direction is downwards, posteriorly, and slightly lateral, which has to be followed especially when you're doing a probing. Now coming to the watering. So you can have watering because of excess production, but you can have a normal tear drainage. But what we are focusing on is the normal tear production with an impaired drainage. So it's important to take a good history. This is probably the most important thing, because history and the initial external examination can sort of clinch the diagnosis in most situations. And there is a component called functional epiphora, which I will be explaining in a bit. So the onset, the frequency of watering. So this history is very important. is there a constant overflowing over the cheek or is it intermittent watering? So this can sort of give you an indication if there is a blockage in the system or if there's an allergy. Associated history, that is discharge. So mucoid discharge goes towards lacrimal obstruction or any other infections. Ropey discharge towards allergy. Nasal symptoms, of course, children who have rhinitis or just the common cold, they can have severe watering. And foreign body sensations because of any foreign bodies. So is there any previous attack of adnexal inflammation? This is very important to decide the type of surgery you do. Any sinus disease or ENT pathology, any surgeries done in the past. Again, this will decide your future management. And of course, diseases such as thyroid eye disease. So the patient pictured here is having watering because of thyroid eye disease. It's important to differentiate this from other causes. So you'll do an external examination and a nasal examination. Along with that, there are certain tests, excretory tests more importantly, and lacrimal imaging. So functional epiphora is basically because of the lacrimal pump which is not working properly. So this can happen like in this patient who has facial nerve palsy. So lid laxity, any other malpositions, incomplete blink, floppy eyelid because of obstructive sleep apnea, all of these can cause, and it's important that you go ahead and do this examination once, which was again mentioned by Dr. Mukesh, basically to get to know whether it's because of the eyelid or you need to examine the patient further. So can anybody tell me what this patient could have? And Dr. Smriti has definitely covered this in her initial presentation. So this child has some amount of discharge here. So on initial glance, it can look like possibly congenital nasolacrimal duct obstruction. But you can see here this extra roll of orbicularis, which is causing the lashes to rub on the eye. So can anybody say what this could be? Yeah, so that's epiblepharon. And it's important to go ahead and examine the, other than the adnexa, the remaining parts of the eyelid as well. So the most favorite thing that PGs like to do, after which the findings sort of get masked when the consultant sees the patient, is Roplas. So that is regurgitation on pressure over the lacrimal sac. You basically press at the just medial to the medial canthus, and you can see the discharge which comes out. Most likely there is an obstruction. And in your Roplas, if you get a negative Roplas but a sac remains distended, you can have an encysted mucocele, which means the discharge is sort of stuck there. If there is no regurgitation but the sac empties into the nose, you could have an atonic sac. Or if there is some blood tinged fluid, you should worry about a lacrimal sac tumor or possibly a stone, that is a dacrylith. Now the tear film height is something which we need to look at. Usually people with a raised tear film height, they could have some dryness, some meibomian gland dysfunction or dry eye, but it could be an indicator of nasolacrimal duct obstruction as well. You can see it with or without fluorescein staining. And of course other conditions which cause watering because of pain, such as hordeolum, and of course the meibomian gland dysfunction, entropion, papillae allergy causing watering, corneal pathologies, blepharitis, trichiasis, dystichiasis, nodular episcleritis, and concretions. So all of these need to be ruled out. Coming to some punctal causes, so punctal agenesis of course will cause watering if present above and below, and infections causing stenosis, punctal ectropion. Supernumerary puncta, you might wonder why it causes watering, but it's because the rest of the system might be poorly developed. And canalicular causes, it can be congenital because of absence or fistula. However, there is a situation like this where you get pouting puncta and some amount of discharge with inflammation in this area, and that is canaliculitis. Sac inflammation you can have because of nasolacrimal duct obstruction or tumors pressing on it, and of course congenital nasolacrimal duct obstruction, and there's something called primary acquired nasolacrimal duct obstruction or PANDO, which is basically acquired not because of any major cause, but just because of predisposing factors such as age, female gender, swimming pool exposure, ischemic heart disease. It has various associations, and secondary acquired lacrimal duct obstruction because of infections, tumors, Stevens-Johnson syndrome, radiation exposure, etc. So coming to the diagnostic tests, we have the fluorescein dye disappearance test, syringing probing, and the Jones tests. So the fluorescein dye disappearance test is a fairly physiological test because you're not pushing fluid anywhere, you're just letting it sit in the fornix, and it has a high specificity and positive predictive value. So it does quite well for children, especially who will not cooperate for a probing or a syringing initially when there's no obvious matting of lashes or obvious raised tear film height. So you wait 5 minutes after putting the fluorescein in the dye, and if it's normal, a small film like the normal tear film height remains. If it's grossly abnormal, the dye tends to overflow and run down the cheek. Jones test is done to differentiate between epiphora and functional epiphora, like I mentioned earlier. So in the Jones test 1, you instill the dye, and after 5 minutes, you keep a bud in the inferior meatus. If it is positive, it means that there is no blockade. So you can get the dye which you can see here in the inferior meatus. However, if there is a blockage in the nasolacrimal duct or if there is a canalicular obstruction, you will get a negative one. So this is a structural one. If you get a negative Jones test, you can do a Jones test 2, wherein you irrigate it with clear saline, like how you would do a syringing, and you can get the bud out there. If there is a fluorescein stained solution, it means that there is a functional obstruction. So there is no actual obstruction. When you're pushing fluid, it is going down. And if you get clear fluid, again, it means that there is a complete anatomical blockage there. So this is what I mean. When you do the syringing, it is not coming to the nose. Coming to syringing, it's not a physiological test because it occurs at a higher hydrostatic pressure, but it is most useful with respect to anatomical obstructions. So you have to anesthetize the eye with a topical anesthetic, get a 23 gauge cannula, do a punctum dilation, and you can do a probing as well. However, you should not do it in acute dacrocystitis. That has to be treated with antibiotics or incision and drainage. So once you dilate the punctum, try to dilate it only vertically, and the lower eyelid is sort of pulled downwards and laterally so that you make the canaliculus straight and advance the tip into the canaliculus. You can use sterile water, saline. I like to use a little bit of dilute betadine because once it comes in the throat, the patient is able to tell for sure whether they've had it or not. So in a patent system, you will get it coming into the nose and the throat properly. If there's a partial obstruction, you might get a little bit of fluid regurgitation back from the opposite punctum, with the patient saying that they can feel some amount of fluid in their throat. In complete obstruction, of course, it goes back fully. In a common canalicular block, you will get the fluid going back into the upper lid again through the upper punctum. So it comes back fairly quickly. The patient won't get any fluid in the mouth, and it will be a clear fluid. And lower canaliculus, it will sort of regurgitate back from the same side. So regurgitation through the opposite punctum, it can be common canalicular block or nasolacrimal duct obstruction, but if it's mucoid, it's most likely nasolacrimal duct obstruction. If there's patent with some amount, partial like I mentioned, patent but the patient is still symptomatic, it could be an atonic sac, which means the sac is not pumping the fluid well. Clear fluid in the same punctum, of course, in individual canalicular block. And in one punctum, you're getting the regurgitation, but there is mucoid discharge as well, then it could be a nasolacrimal duct obstruction with upper canalicular block. Probing is basically indicated once you find an obstruction. It's basically to confirm the level of the obstruction. So this is another concept that when you put the probe inside, if it goes all the way through the sac to hit the bone, this is called a hard stop. A soft stop is when it goes partially, but it gets obstructed by whatever obstruction is there in the canaliculus or the common canaliculus. You can get a false soft stop, like I mentioned, in the anatomical variations that you can have. So probing is done with the Bowman's probe, it comes in these sizes 0.000, which is 0.4 millimeters, going up to around 5, 6, so that is 1.2, 1.3 millimeters in diameter. And it's also used as a treatment modality for congenital nasolacrimal duct obstruction. So whenever you're reporting a finding of syringing, this is the most important thing. Is it clear or mucoid discharge? Is there a hard or a soft stop? And is it from the same or the opposite punctum? Again, nasal examination, not something which we can easily do in our OPD, but if you have an endoscope, it would be ideal to look for any masses, polyps, any mucosal inflammation, turbinate hypertrophy, or any adhesions. So this is the appearance of the inner part of the nose at the area of the middle turbinate. So this is the area, this is called the axilla of the middle turbinate, and this is where the incision for your endonasal DCR starts. This is the uncinate process, which is the posterior extent, and this is the agar nasi, which is the largest ethmoidal air cell, and this is the septum. So this is the area where the lacrimal sac normally would be. And once you identify these structures, then it would be easier for you to decide whether or not there's a pathology or not. So you can see the middle turbinate here, the axilla, the uncinate process behind, and the inferior turbinate here. So behind the inferior turbinate is where the nasolacrimal duct ends, the valve of Hasner is, and sometimes you need to do inferior turbinate infracture at the time of probing in children in order to facilitate flow of fluid. Imaging, this is a bit theoretical. Basically, you just need to know the names. There's dacryocystography, which is basically infusion of a radio-opaque dye, and you basically image it with a X-ray or a CT scan, and it gives you an outline of the flow. So here you can see this radio-opaque dye is not flowing well, whereas here it is flowing well. Digital subtraction, it's the same thing, but it's under fluoroscopic guidance, and all the other tissues are subtracted. So you're only able to see the sac and the NLD area. This is a nuclear imaging test, so it uses technetium, and it is sort of a little more physiological test. It's imaged continuously by a gamma camera. The CT DCG, same thing as DCG, but with a CT. MRI, which is much better delineated. And this new thing is dacryoendoscopy. So it's an endoscopy which is introduced into the punctum, and you can find various obstructions or foreign bodies, lost punctal plugs, etc. with this. So coming to a couple of things that I would want you to be able to identify. So this child has a swelling at the medial canthus since birth. So what can you see here? First of all, what color is this? Bluish. Okay, so this is a dacryocele. Okay, it can be associated with other issues in the nose. It can cause sort of breathing difficulties in patients. So this is something which has to be identified, and it can be treated very easily with probing. I had put it earlier also, this photo. So can anyone? So this is just an acute dacryocystitis in a child. Anybody knows the treatment? Although Dr. Ruchi will be covering it. Anyone knows the treatment? Antibiotics, yes. And if you had to do an incision drainage in this small child, you'll have to put the child under general anesthesia. Okay, so can you see this discharge coming out of this canaliculus? Can anyone identify what this could be? Louder? Okay, so if you start treating a canaliculitis by snipping the puncta and curetting all the material out, this is how it looks. This could either be the sulfur granules, which are the actinomycetes, or any other bacteria, streptococcus, staphylococcus, or it could be dacrylithiasis, that is stones. Can anyone figure out what has happened here? Louder? Okay, so there is a lid tear But the lid tear is at what point? Like what part is it also involving? Yeah, so the punctum as well as the canaliculus is involved. So this won't be like a regular apposition that you do. It won't be a regular repair of a lid laceration. You will also have to put some sort of stenting along with this repair. So like a mini Monaca. Okay, this might be a little different for you to identify, but I'll tell you what it is. Some patients have a bit of watering because of anterior placement of the medial canthal tendon. So this beak-like appearance can happen. That is called Centurion syndrome. And finally, can anyone identify this? Yeah, so that's a congenital lacrimal fistula. Sometimes you just need to excise the fistula, but if there's an associated obstruction, you'll have to do a DCR along with it. So thank you for listening patiently, and feel free to email me if you have any doubts.
Very nice presentation, Dr. Rituja. And she has very nicely summed up the examination part very beautifully. One point I think I wish to highlight here is that one must always choose appropriate size cannula while doing syringing, and you should not be using broken needle cannulas. Like those cannulas, they have got sharp edges, and you may yourself damage the canalicular system by doing syringing through them. Other common tendency is to use 26 gauge cannula for syringing. That also should be avoided because that can create false passage formation. They are too thin, and also there may be some fluid coming out through the side of those thinner cannulas. So ideally 23 gauge cannula or even thicker than that should be used, and those should be custom made cannulas.
Thank you, Rituja. That was a wonderful exposition. Explained everything so beautifully, just as clear as her surgery. The one thing that I wanted to say was that 90% of your diagnosis you can make by simple examination. Look at the sac area, look at the puncta. And number two, with syringing, with a probe, with a scale and a forceps with you. So if you have a straight cannula with doing syringing, observation of where the fluid is regurgitating from and where the obstruction is, soft stop, hard stop, what distance, done through upper and lower, hold with the forceps at the punctum as far as it has passed, measure it on a scale, you have 90% of the diagnosis that you normally need. So that's the wonderful part. And great to have Dr. Ruchi in. Professor Ruchi is head of Oculoplastics and professor at the premium institution of Guru Nanak Eye Center at Maulana Azad Medical College, which I've had the privilege of being a student from and as faculty also from. And Professor Ruchi has not just a great knowledge, a great surgical hand, but a wonderful initiative at bringing out newer techniques, winner of the Rangachari Award, and some of the most beautiful videos, and a very good teacher. So wonderful to have her with us.
So good morning everyone, and thanks to Dr. Grover, Dr. Megesh and Dr. Hunawar who has invited me here, and Rolika for all the logistics of reaching. So and of course I'm really surprised to see such dedicated set of students who are actually making notes throughout. I really appreciate that. So I'll try, my presentation would be, I would be happy if you just look at the videos and try and understand things. I've written very less on the slides. You're free to ask me anything. And Rituja has very nicely covered the ways to identify the, because most of the lacrimal surgeries we would be dealing with relieving the blockages. So she has very nicely showed how to actually identify the blockage in the clinic itself, and all the advanced investigations that are required to come to a final diagnosis. So just in children mostly, I will not be showing the probing syringing because all of you must be seeing it in your hospitals. So the commonest surgical maneuvers which we required in children would be mostly for the congenital fistulas, which are very easy to handle with just passing a probe, excising the lining, and sometimes they may need to be combined with DCR if there is a blockage, as already told to you. Then most of the management, again, as I said, would be with the massage till about 9 months, then probings and ballooned acryoplasty. DCRs would usually be done after 3 years of age. And let's go to the types of DCRs, the types of blockages, how you can relieve them. So first, to begin with, we'll start with the external DCR. And other than that, nowadays the endoscopic DCR has become very popular with good results, almost equal results. And again, the endoscopic DCR could be a laser DCR that could be performed through the canaliculus, or the laser can pass through the nose. Now, just to recapitulate your anatomy a little, whenever you are doing DCR, I think in Indian scenario, most of us would be doing it under local anesthesia in adults. In children, of course, a general anesthesia is used, but a lot of surgical endoscopic DCR people prefer to use a general anesthesia. Why? Because there's there's a lot of bleeding occurring when you are doing an endoscopic DCR, and because of that posterior trickle, the patient gags. So actually, it is much easier to perform it under general anesthesia, but we are again doing it under local anesthesia also. So if you are doing external DCR, the main nerves to be blocked are, of course, the infratrochlear branch of V1, V2. Itna to batao. V1. So infratrochlear would be V1. Then the dorsal nasal, again V1. What about infraorbital? V2. So that you should know, that you should not forget to block this also. Then of course the anatomy a little, just the anterior lacrimal crest part, we have to just know the anatomy of the medial orbital wall, because this is the area where we'll be dealing. So the anterior lacrimal crest, the posterior lacrimal crest, this is the frontal process of maxilla, and then behind it will be the lacrimal bone, and then the ethmoid, and then there will be the body of sphenoid. So whenever you're doing an external DCR, you are breaking the bone over here, that is the weakest point between the maxilla, and that's the lacrimal bone. But one has to take care, because I'll show you the video on the endoscopy how you recognize these landmarks. So just a short video here. So after the anesthesia, now the first incision, you can either give it 3 millimeter from the medial canthus, or it can be 11 millimeter. Why not between? What, at how much millimeter? 8 millimeter. So that you have to remember. Then the medial canthal ligament, either you can cut it, and because the fundus of the sac is behind it, or you can just let it be there, and you can actually dissect the sac all towards the fundus. Now this is the periosteum being incised, and the lacrimal sac is elevated from the bed, and then an osteotomy is created. Now remember that the periosteum has to be dissected as far as possible till it becomes really adherent to the anterior lacrimal crest, the frontal process of maxilla, and then you raise a mucosal flap. All of you must be doing this procedure. So the only point to remember is that when you are making these flaps, don't make very sagging flaps. You must be either trimmed, or you should just pass a suture so that they don't go and sit on the opening you have created. And also you must clean up the bony pieces and small remnants, because lot of blockages later on occur, because these bone small pieces, they act as a nidus for formation of granulation tissue. Also one has to remember that you open up the sac completely, otherwise if you just leave the fundus of the sac, or your opening bony osteotomy is a little too high, sometimes what happens is later on you may get a sump syndrome. So the position has to be correct. Now there may be a situation where you have a trauma and your landmarks like the medial canthal ligament may be lost, and you have to, there's a lot of fibrosis, and you may not have, things may not be as simple as they usually are. So here you see, after making the periosteal incision also, the sac is not getting lifted, and there is no sign of any medial canthal ligament here. So this is the inflated sac, and this is the sac which is being opened vertically, and you can see a lot of fluid is coming out of the sac now. So after an interior flap is fashioned, you must try and identify the opening of the common canaliculars. So this is the posterior flap along with a lot of fibrotic tissue that was removed, and this is the anterior lacrimal sac being dissected, and it was now this movement is because this is the chisel and a hammer. So if you're not able to identify your usual area where you normally put a curate and just bake the bone, you can use a chisel and a hammer, which comes in very handy in these post-traumatic cases at times. Because of the fracture, sometimes the remodeling occurs, and the usual areas where you have a weaker bone are lost. So, and this is again the usual sac flap which you create. Now, depending on whether you have a good, sometimes there may be a situation where your lacrimal sac flap is not adequate. So, you can actually make a longer mucosal flap, and suppose by chance while cutting you injure the lacrimal, the mucosal flap, what you can do is you can actually make a osteotomy, increase the size of the osteotomy towards the nose, and fashion the nasal mucosal flap from beneath it and pull it down. So that is how you can work it out. And in this patient, of course, the telecanthus repair also had to be done. So this is another technique where you have a post-traumatic case, and I use a burr. Usually use a burr, which is very handy for decompression surgeries. So this is a very fast way of just creating a bony osteotomy. Only precaution you have to take is that this incision has to be larger, the skin has to be retracted. You see there are multiple cat paws retractor here in this field. So you have to be careful, because you may injure, if it's a small skin incision, you may injure the skin, you may burn it. So, and continuously irrigating it so that there is no adjacent trauma to the structures. So rest of course the process is the same. So nowadays we have, of course, we are working on how to use it in routine cases also, but it comes in very handy for this purpose. So this is a endoscopic surgical DCR. Now just see the difference in the blocking technique. Here we are, this is intracath which has been used, and this is the axilla of the middle turbinate till where the mucosa was anesthetized. And before that, the packing is very important. I'll just stop the video here. The nasal packing, as I said, if bleeding starts in endoscopic DCR, you have to abandon it actually in between. So what is most important, where I struggled because I learned it on my own, was that you take 4% Silocaine, put 2 ampules of adrenaline in it, do a good packing at least 15 minutes prior, and just leave it. And do it yourself, don't leave it to any junior, because if it is not packed, your surgery will have to be stopped in between. So a good packing, and after that, once the patient is comfortable, then this is the anesthesia which is given under endoscopic visualization. You inject it first at the root of the middle turbinate and at the area where you want to create an osteotomy. So I'll just start the video again because some of the steps were missed. Okay, so now see again, this is the first this thing, and this is a 15 number blade with which a flap has been raised, and in between you can see the middle turbinate. After that, you reflect this flap upwards, and then this is the frontal process of maxilla. The landmarks are same, only thing is you have to identify them from here. The frontal process of maxilla, sometimes this is when you are not able to the frontal process of maxilla becomes quite thick superiorly, so you may need again a burr to create the osteotomy. And once that bone is broken, again you can switch back to your punches, the routine punches. These are of course the nasal punches which I am using, and you enlarge the osteotomy. And in between, again, if there is some amount of bleeding, you need to just pack and wait for a while. Now after you have created an adequate osteotomy, this is the sac which you can see, and again a vertical incision is given. This sac is now opened in a form of book. Remember, here we are not going to suture anything, so you just open it and just reflect it in a form of a book. And this is the syringing being performed, and after that, the mucosal flaps, they are approximated with the nasal flaps, and you just put in a gel form and leave it, and this gel form tends to absorb itself, and that's the end of it. Now Rituja was talking about, acute dacrocystitis. Now, classically, what we read in the textbooks is that in acute dacrocystitis, no probing, no syringing, no DCR, no surgery. But, now things are changing, and the problems why you don't do an external DCR in acute dacrocystitis, anybody, why don't we do it? What's the problem? Anybody? You can get up and speak. You don't know? The infection may spread. Okay. So, and? It will be very painful to the patient. Okay. And it will bleed much more. Okay, great. And what about the success rates? What will happen? A fistula might form after. Okay. So, thanks. Please sit down. So, what is happening is you have infection over there. Now, the infection may be just superficial when you begin with. But once you start creating the planes, what tends to happen is that infection may track down and it may end up with an orbital cellulitis. So that is problem number 1. Problem number 2 would be, of course, it's going to be very painful to the patient, lot of bleeding, and at times there is so much edema that you are not able to identify the landmarks. There would be a huge abscess sitting over there. Okay. Then once you create a opening, the problem is that for incision and drainage, you create a opening that becomes a fistula later on. So that is another set of problems. So what happened was that if we, just leave this approach and go endoscopically, you can actually get away with the origin of this infection is basically there is a blockage, there is stagnation of fluid that is getting infected, and that is causing, so this is a kind of a cascade which will not be relieved till the blockage is relieved. So if you do an IND, the stagnation remains, and if you see actually, there is lot of resistance to the usual set of antibiotics which we are prescribing. So I think the favorite for all of us would be an augmentin. So we are all prescribing amoxi with clavulanic acid, but there is lot of resistance. So what we started thinking was that we need to find out a way, and there was, endoscopic DCR again has been documented that it can be done in acute cases, and I'll just show you a series of cases which we did, and now we are routinely doing it. So this is just to show how a laser DCR, diode laser DCR can be done. So this is again, enlarging the track with a probe, and then after that this is the probe. This is the laser probe which is placed, and this is passed. And remember that this has to hit the bone and then you should fire, otherwise you burn the canaliculus. So this is again the endoscopic view. This is the middle terminate which we can see here, and this is the laser being fired, and the site of the opening is again, of course, at the root of the middle terminate. But unlike the the external DCR where usual osteotomy sizes are about 15 millimeter or more, here the osteotomy size we usually like to keep about 10 millimeter. So, and that usually works. So after the initial firing with the laser, that would create an opening of about 4 millimeter. The further enlargement can be done with a Blakesley's forceps. Using a laser to create an osteotomy of about 8 millimeter, we realized lot of heat was generated and that burned the canaliculus. So to prevent that, we started using these forceps. These are the Blakesley's forceps for enlarging the osteotomy, and the same procedure I'll just show you. Now we use this procedure, we realized that by using a laser probe we could relieve the stagnation, and in the first sitting we just made a very small opening, and after doing a small laser, creating a small laser opening and antibiotics, the patient the recovery was so fast that after 10 days you can actually go ahead and do either complete it as a laser DCR augmented with the Blakesley's forceps, or you can go ahead and do a surgical DCR. So vis-a-vis just giving antibiotics or doing an IND, we found this a better technique, and of course it is published now. The problem with laser DCR, as I said, was in initial learning phases we were not aware of it, that this laser energy creates a lot of heat generation, and if at any side the probe is cracked somewhere, it can cause dissipation of heat, and these are not only the canalicular burns, they can have you can have a formation of a nasocutaneous fistula, which of course became all right, but one has to be really careful about these things. Now, whether to intubate or not to intubate with endoscopic DCRs, this applies to laser DCR or maybe surgical endoscopic DCR. A lot of surgeons, they like to intubate even in primary nasolacrimal duct obstructions. We found that there was no additional benefit of intubating in every case, only in complicated cases where we actually intubate in external DCR also. There it is, or you are not sure what you are doing. So sometimes when you're in a learning phase and you are messed up with your mucosa and everything, then it is better to intubate, otherwise there is no need to intubate. Now coming to the canalicular obstructions, this is a classification by Dr. Javed Ali, and the first proximal obstruction would be the first 3 mm, mid-level would be between 4 and 6, and distal would be more than 6. So this is the classification I'll be using in my subsequent slides. So the management strategies would vary, of course. If it's a punctum, then it is different, but mostly in the canalicular blocks, there would be initial, again, when you say block, you need to differentiate between stenosis and obstructions, where stenosis may be opened by a probe, but when it's a long-standing obstruction, if you try and break it, it'll again get fibrosed. So the chances of your success would be very low. So these are the different methods which are used to treat canalicular blocks, just going one by one to each of them. So if it's a punctal stenosis, classically a lot of us have read SNP procedures, and we were doing SNP procedures, but by and large I have given it up now. We just enlarge it and we are all putting mini Minoka stents or of course perforated punctal plugs. So this has come in really handy, and it's a very fast procedure. Now, as I said, if you have to relieve an obstruction which may not open just by probing, then you need to have trephines, and this is a scissors trephine which is used to break the scar tissue, and this has to be followed up by an intubation wherever you are putting. So this is a general thing which is used. Now let's see some patients. Now this is a post-traumatic case once again, and you can see a granuloma sitting right at the medial canthus. So the first thing is to assess how much of your canaliculus is left. So this is a distal canaliculus, and I could pass my stents. So now I don't have a lacrimal sac for forming my flaps. So what I do is I fashion my nasal mucosal flap a bit larger so that I can pull it up and suture it to my pericanalicular tissue. So these are little modifications which you have to do depending on the kind of patient you are treating. So this is the pericanalicular tissue, you just pull up the flap and suture it there. Is the time over? 1 minute. Okay, so I'll just show you, this is a conjunctival DCR. I need 3-4 minutes. So this is a conjunctival DCR. So this is, you make the flaps as you do it in external DCR, but the osteotomy size needs to be smaller here. So about 6 mm osteotomy, 4 to 6 mm is sufficient. You don't need a very large osteotomy. And then you partially excise the caruncle. This is a probe being passed to see the length of the tube which you would require. And this is a straight glass tube which I am using. Otherwise you can have a first top glass tube where you don't have to fix it up like this. So this straight glass tube, it tends to pull out. So this is a mirror tuck technique which I have used. I'll show you the video later. And this is another technique of DCR with retrograde intubation. And in this technique, what we do is, this is the comic canaliculus which is being identified, and after that a probe bent at 80 degree, it is passed retrogradely towards the canaliculus, and the new opening is created on the canaliculus. You can see it this way, and this is the pseudopunctum. So you can just remember, you don't need to do all these things, but you can just remember this is another modality which is being explored and being used for proximal blocks, and these do well if the blocks are till about 5 to 6 mm, beyond which it doesn't do well. This is what we found, and after that of course the silicone intubation is done in the usual manner. So the pseudopunctum is created, and this is after the pseudopunctum, after I think this was followed for 6 months, and you can see it's a nicely sitting pseudopunctum. And this is a technique for, this is a mirror tuck technique which you can read up in the IGO. I'll just show you the technique, that it's just that you can use the way the mirrors are put, you can create a mesh on the opening of the tube, and you can just hold the tube in position, and at the end of the conjunctival DCR you must put in fluid and check whether it is gravitating down, otherwise that means your tube is not properly placed. So this is just to show you how it is done. Rest of it of course you can read in the journal. And this is the the 1 year follow-up pictures. They really do well with this technique. You can see a beautiful opening created. And again, when you're using a laser with a conjunctival DCR, you need to be careful, because we have had patients with collection of the infection in the sac. So in external conjunctival DCR, you're opening up the flaps, but in laser conjunctival DCR, since the sac remains inside, it may get infected, and this is what happened. Now this is the last video, which is I think this most of you would require when you're sitting in an emergency, is how to put in a mini Munoka stent in a patient with lacerated lid with injury to the canaliculus. So what is to be done is to identify the opening of the medial opening of the canaliculus, and this is the mini Munoka stent, and you need to cut it and form it a bevel in a form of a bevel, so that it goes in easily, and you just slip it in, and it just there is a knuckle at the top which has to go and fit into the punctum. So don't try and dilate the punctum too much, so that once you pass it, the knuckle goes and sits in comfortably. So, and to identify the medial end, you can just inject something from the upper punctum. It may be just fluid, air, or sometimes betadine. Especially in patients with trauma, you tend to flush whatever dirt is there. So I like to inject betadine to identify. And then in a high magnification, once you pass in the tube, you have to suture the two ends of the canaliculus with the atovicryl, and of course the tarsus and the lid and all that. So just to summarize, in children, DCR is to be done in older age, of course more than 3 years. In adults, external endoscopic laser, whatever you want to do, if you are good at it, you can do any of these. They all give good results. Endoscopic route is preferred in acute dacrocystitis. In proximal and mid canalicular blocks, initial intervention would be of course trephination, and you can just pass the probe, and you can just do an intubation. It doesn't work, you can trefine it, put it into and put the tube, and these tubes are need to be kept for 4 weeks. You don't need to keep them for years together. There is earlier on people used to keep it for long 18 months or so. It causes a lot of biofilm accumulation, and that can cause infection and failures later on. Then of course CDCR and DCR with retrograde intubation are other modalities. Problems with CDCR again are tube related complications, exposure, extrusion and all that. And but yeah, if done well it works. But nowadays a lot of people again have given up CDCR, and people are switching to botulinum injection in lacrimal gland, which is easy but expensive, and repeated injections are required. Thank you so much.
Thank you, Ruchi. That was a wonderful concept giving to them with videos. I think the most difficult part about lacrimal surgery is having a visual concept. So you've seen some wonderful videos which make you understand the concepts of how to manage obstructions at different levels, including the most important, dacrocystorhinostomy. So any questions that you would like to ask Dr. Ruchi?
Any questions? Yeah. Atonic sac. Yeah, I would go for DCR. If I feel that it is not functioning, I would go for, even if it is patent.
Agreed.
Anything else? Thank you so much.
Thank you, Ruchi. Wonderful. And thank you, Rolika. Thank you, Santosh, for having crafted this lovely session. I've really enjoyed and learned a lot. I hope you've learned something too. And thanks to Mukesh, and joy to hand over to Smriti and capable hands of Fairuz.
Thank you so much, sir. Thank you for chairing the session on oculoplasty. Now, after covering a little bit of reconstruction and plasty, let's move on to the oncology session. So this session is, I know that you don't see much of oncology in your centers, and I know that you have like probably least idea about this segment. So it's kind of important for you to take a look at it, a glimpse at it, because including me, many of you did not have, in the postgraduate part, did not have any idea about how the management works and how the counseling of these patients is and how the whole process goes on. So this session will be chaired by Dr. Feroz and Dr. Smriti Bansal ma'am. So I request both of you to please come on stage. And Dr. Feroz is not just an oculoplasty and oncology surgeon in India. She also works internationally, and she is not just a surgeon and she's not just a surgeon, but also an entrepreneur who has been able to put up a center of her own called Horus Eye Air Specialty Center in Bangalore. So kudos to ma'am. And over to you, ma'am.
Hi, Rolika, thank you. Thank you so much for the kind introduction, and very good morning to everyone. Hi, Dr. Smriti. Yeah. So yes, we are going on to the ocular oncology session here today. Very excited to see the intelligent bunch sitting here. I hope it will be useful for you. One, in terms of knowledge, as far as examination preparation is concerned, and also some amount of awareness regarding this, very niche specialty and certain rare tumors and also common tumors that we are going to discuss today. Smriti, do you have something to tell to the students this morning?
So oncology is difficult, no doubt in that. And the team over here, who will be teaching you, they are the pioneers in them. Dr. Santosh, everyone knows, he deals with any kind of ocular tumor. So learn from them. We all are learning from you, sir. So over to Dr. Santosh.
Thank you so much. I'll be starting off with tumors of the ocular surface, then we'll go on to eyelids, intraocular structures, and finally pathology. So starting with the classification, this is the very, I would say, structural classification of ocular surface tumors, starting from choristoma, which is of course not a tumor, but it is in the list. Epithelial, melanocytic, vascular, fibrous, lymphoid, and secondary tumors. Starting with choristoma, there are 4 variants. Dermoid, of course, this is called limbal dermoid, and if a patient has cosmetic deformity which he wants to get rid of, or if astigmatism is more than 3 diopters, or if the child is having symptoms because of hair growth over the lesion and keratinization, then you tend to excise it. Whenever you excise it, you should always assess the depth of the lesion, and if there is hydration of the stroma ahead of the lesion, that means that it is a deeper seated dermoid into posterior stroma, so you should have a tectonic graft ready. That's a variant of limbal dermoid called corneal dermoid. When more than half of cornea is involved and the epibulbar component is minimal, that's called a corneal dermoid. It is also associated with anterior segment dysgenesis. Vision is something that may not be possible in these children, but of course a penetrating keratoplasty and ocular surface reconstruction would give cosmesis. The next variant of choristoma is a dermolipoma. Dermolipoma is hidden in the supratemporal fornix, often is noted when a child grows into teenager, when it starts enlarging in size. You're generally worried about the palpebral lobe of the lacrimal gland and the lateral rectus in a lipodermoid if you want to excise it. But these 2 structures are generally not damaged if your incision is ahead of the lacrimal gland, hidden in the supratemporal aspect, and also your plane of dissection is anterior to tenons, because this lesion is anterior to tenons. Unless you open the tenons, you will not even see the lateral rectus muscle. Only when you go to the lateral canthal area where tenons would be perforated, there you excise it, in the sense that you truncate it and let the rest of it disappear or retract into the anterior orbit. So that was dermolipoma. As opposed to dermolipoma, if you have an adult individual with bilateral lesions which are slightly more pinkish than a dermolipoma, then that is orbital fat prolapse, bilateral. But if it is unilateral, you should also rule out lymphoproliferative lesions of the lacrimal gland, palpebral lobe of the lacrimal gland, and tumors of the palpebral lobe of the lacrimal gland. The differentiation is in terms of the crevice, where dermolipoma gently merges with the ocular surface, whereas this kind of a crevice indicates that it is subconjunctival. So dermolipoma is anterior to tenons, whereas orbital fat prolapse is subconjunctival. So when you excise orbital fat prolapse, you may encounter lateral rectus, so you should be careful with it. Now, not to say that dermolipoma occurs only supratemporally. This is one example where it is infranasal. Another variant of choristoma is a broad-based choristoma. You can see that it is more broad-based and the base is more wide. This is called osseous choristoma. This is nothing but cartilage with ossification, which is a part of the anterior scleral lamellae. Next variant of choristoma is a glandular choristoma, which waxes and wanes in size with formation of clear cysts. This was a lacrimal gland choristoma in the superior limbus. And the last variant of choristoma is called the complex choristoma, and this is dangerous because this is associated with systemic manifestations. This is called nevus sebaceous of Yadison, where the patient has bilateral or unilateral complex choristoma with subtle coloboma of the eyelid. You can see coloboma of the eyelid, cutaneous appendages and subcutaneous nodule. Along with that, the child will have nevi on face, chest and abdomen, bald patches on the scalp. That is nevus sebaceous of Yadison. Going on to epithelial tumors, we have a bunch of them, but the most common is papilloma. Papilloma is a tumor that is induced by human papilloma virus infection. Typical configuration is like that. It is a broad top with a central vascular core from which there is radiating blood vessels and a small pedicle which is attached to the base, that is conjunctiva. So whenever you excise it, you have to excise it right at the junction and do cryotherapy to that area so that it does not recur. That is the way you want to excise it. These are aggressive variants of papilloma which may actually clinically look like squamous cell carcinoma. Who can say that this is not squamous cell carcinoma? Only histopathology will tell you. So it can be very aggressive, it can be pigmented, and this is one variant of aggressive papilloma which could respond only to interferon. One more aggressive papilloma in a Mongolian patient who was referred with intranasal extension as well, and he responded after excision of the intranasal component, dacrocystectomy and debulking of the conjunctival component to interferon. So interferon is a useful adjuvant therapy in patients who have refractory papilloma. Now, as I said, papilloma is like this, pedunculated. But what if its configuration is inverted, where the tip is small and the base is broad? That's called inverted papilloma, and that happens in immunocompromised individuals, and that has a tendency to have squamous cell carcinoma as a component. Next epithelial tumor is ocular surface squamous neoplasia, which is a spectrum including dysplasia, mild, moderate, severe dysplasia, carcinoma in situ and invasive squamous cell carcinoma. The entire spectrum is called ocular surface squamous neoplasia. It is the most common conjunctival malignancy in Asian Indians. Depending on the clinical appearance, it can be classified as gelatinous, papilliform, velvety, leukoplakic, and there are also nodular and diffuse variants. This is nodular and that is diffuse. That is based only on morphology. Sometimes it can be pigmented. In Asian Indians, it has a tendency to have secondary melanocytosis, so it may look like a nevus or even a conjunctival melanoma. This is the morphological variants of OSSN, and there are some masquerades of OSSN. So this is a tumor that has many faces. So when a cat doesn't look like a cat, it's difficult to say it is a cat. So we have to have very specific clinical considerations when you want to diagnose OSSN, because the rate of misdiagnosis is really high. Only 1/3 of patients with OSSN are diagnosed as such. Rest of them are diagnosed as simulating conditions, thus leading to inappropriate management. So here are the 3 clinical criteria for diagnosis of OSSN. When you have a patient who has keratin, that white specks are nothing but keratin, then that is one of the characteristics of OSSN. Not very highly sensitive, but highly specific. When you add abnormal vascular pattern to keratin, abnormal vascular pattern would be in terms of feeder vessel and blood vessels within the lesion that are called intrinsic vasculature, that adds to sensitivity and specificity. And the third test is pink staining, rose Bengal staining. When you have keratin, abnormal vasculature and also rose Bengal staining, then you are as good as the pathologist. With histopathology as the gold standard in this study, 97% sensitivity and 98% specificity with these 3 put together, taken as a unit. So what this slide tells you is that if you have a patient who has what looks like pterygium, pinguicula, conjunctival, inflammation, scar, whatever, but if it has keratin, abnormal vascularity and also stains with rose Bengal, then you have to treat that lesion with respect and excise it with due 4 mm margins, do everything else that is required for OSSN. If you still have any doubt at all, then you can take the help of anterior segment imaging, such as anterior segment OCT. A triad of signs are seen here. One is, this is normal corneal epithelium, which is grayish and about 65-70 micron thick. When corneal epithelium becomes hyperplastic, that means it increases in thickness, hyperreflective when it turns white, and also abruptly truncates with a snout-like ending, that is called a clinical or OCT triad of diagnosis of OSS. And this was described by Carol Karp, and it's a very useful triad of signs that are used in simulating clinical conditions. OCT can also be used to judge the depth of the lesion. Whenever you want to excise a tumor, base of course is sometimes difficult to comment on slit lamp evaluation. If you do OCT, it can actually mimic histopathology in terms of depth of the base. Useful would be to use imaging in patients where there is a corneal OSSN, where we could know that the entire thickness of the stroma is involved based only on imaging. This is the normal corneal stroma, and that is the splayed stroma somewhere here that needed penetrating keratoplasty. The fallacy of OCT is that if there is exuberant keratin, then there is posterior shadowing like that. So it's difficult to determine the base of the lesion. Now, syndromic associations of OSSN are xeroderma pigmentosum, where these patients are young age, tend to have multifocal lesions which are recurrent. In patients who are immunocompromised because of HIV seropositivity or any iatrogenic immunocompromised status such as post-organ transplant immunocompromised status, they can also have multifocal OSSN. And the third is palmoplantar keratoderma, which is like this, where a patient has this skin lesions and nail bed lesions. It's also called Papillon-Lefebvre syndrome, where these children tend to have bilateral ocular surface chemous neoplasia. Now going on to melanocytic tumors, again a bunch of lesions that are seen in melanocytic nevus lesions. Nevus, primary acquired melanosis, and malignant melanoma are the most common. If you have 4 patients like this, each with a pigmented lesion, sometimes it's confusing to say which one is a nevus and which one is not a nevus. So we use what is called a clinical checklist. Interpalpebral vulva location, variable pigmentation, that means that they range from tan brown to chocolate dark brown. No corneal epithelial invasion, they stop crisply short at the limbus. No episcleral fixation, which you can judge by moving the lesion with a wet cotton tube applicator under slit lamp. No intrinsic vascularity, feeder vessels are excusable, and the most important sign would be the presence of cysts. Nevi are spongy, so they have either microcysts or macrocysts. Presence of these, which are confirmed on slit lamp and on imaging, indicate that the lesion that you're looking at is indeed a nevus. Nevi need not be taken off unless the patient is cosmetically concerned or it is so close to the limbus that it is forming a delin. Then you excise a nevus, otherwise it can be left alone. Generally, these patients want excision because of cosmetic concerns. This is a patient where we could use imaging very effectively. This is an 11-year-old child of physician parents who are very aggressive about this recent lesion that they have noted. It has some intrinsic vasculature and a feeder vessel. It is crossing the limbus just a bit, and it is amelanotic. So how do we know what it is unless we excise it? When we did imaging, we find microcysts indicating that it is amelanotic conjunctival nevus. So imaging can help you diagnose amelanotic lesions as well. Now going on to change of nevus into a melanoma. So this is a nevus that this patient always had, lot of cysts, and when it turns solid, that means that it is transformed into a melanoma. The risk is very low, 1 in 300 in Caucasians, 1 in 100 in Asian Indians, a low risk. But whenever you have such a situation, you can do imaging as well. This is a patient, my own patient, who had disappeared for about 8 years. He always had a nevus that we had documented. Now there is a new growth from the nevus, which is much darker and more vascular. And this patient had 2 components. One had cystic component and another had solid component. The solid component was melanoma, the cystic component was still a nevus, and that is the zone of transformation of a nevus into a melanoma. So nevi do transform into melanoma, and you should be aware of it. And that's a very classic conjunctival melanoma where it is much darker in terms of pigmentation. Corneal epithelial invasion is present. Vascularity is very aggressive, coming from all directions to feed this hungry tumor. And you can see intrinsic vascularity because the entire tumor has turned fleshy pink because of its aggressive vascularity. That's a conjunctival melanoma. It can be like this as well. There are morphological variants where the nodular variant is present and also episcleral invasion is present in this patient. Other pigmented lesions are complexion associated melanosis or CAM, also called racial melanosis. We being Asian Indians, all of us will have some amount of conjunctival pigmentation, and it is more if we are actinically exposed, if we work too much in the sunlight outdoors, then our conjunctiva may be more pigmented. If you use a lot of cosmetics around the eye, then we may have depository pigmentation as well. But this tends to be bilateral. Bilateral with some amount of symmetry indicates that it is complexion associated melanosis, where you don't have to worry unless you want cosmesis that can be given to you by either cryoing it or locally excising it. But whenever there is asymmetry like this patient has gross asymmetry, right eye is more heavily pigmented than the left eye, then it is primary acquired melanosis. In primary acquired melanosis, we go by the location of the lesion and also inspect the entire ocular surface to see if there are any attendant lesion, like this patient has a palpable conjunctival lesion, and also the size of the lesion. Depending on whether PAM has atypia or not, the risk of melanoma varies from about 10 to 30%. Now, transformation of PAM into melanoma is judged by the number of clock hours that are involved. So, for every clock hour extent of the lesion, the risk changes. So, for about 1 clock hour, you observe it. If it is like 2 clock hours, you still observe it. But if it's more than 2 clock hours and if it has this peppery kind of configuration, then you treat it. Treatment could be either with excision or mitomycin C. This is a patient where there is fornical PAM and there is a melanoma. So PAM has to be taken with lot of seriousness. Coming on to vascular tumors, there are a bunch of vascular tumors starting from AV malformation to exuberant granulation. These patients are quite common, patients who have this epibulbar lesions. Before you start treating them, if a patient has any of this, then you have to do Valsalva maneuver to see if the patient has orbital varices or not. If a patient does not have orbital varices, then you have to do a contrast enhanced MRI to see if there is any orbital component. If it is isolated and it has minimal epibulbar component like this, then you can either cryo it, do limited excision, or cauterize it with reasonable results. It won't completely go away. If you have an adult patient like this where there is a vascular lesion close to the limbus with large vascular channels well circumscribed, then that is adult onset capillary hemangioma of the conjunctiva. If you have a patient who comes to you with recurrent subconjunctival hemorrhage, and if you ruled out that the patient does not have any hematological issues or high blood pressure, not on anticoagulants, then this could be one of the lesions that are underlying a subconjunctival hemorrhage. When the hemorrhage resolves, you will find that there is lymphangiectasia or small lymphangioma. Sometimes it could be in the form of a curvilinear lesion like this. That is also lymphangiectasia. If the patient has subconjunctival hemorrhage recurrent, then you can excise it. And that is a lymphangioma. Lymphangioma looks more aggressive, can be located in the fornix with anterior orbital extension, sometimes maybe as aggressive as this. This patient underwent, somebody tried to do a biopsy from this location with a lot of bleeding, so they abandoned biopsy. And finally, we could take care of this by vaporization. Vaporization is a technique where we use radiofrequency electrode to vaporize the lesion and reconstruct the ocular surface by using amniotic membrane transplantation. Bleomycin and picibanil also alternatives. If you have another aggressive looking conjunctival lesion with discharge, this patient has forgotten that he has undergone a surgery earlier 30 years ago. That was a retinal detachment surgery. Now 30 years later he has developed this lesion. This is pyogenic granuloma. So aggressive pink looking lesion with discharge, when you excise it, you find that there could be a suture or a protruding buccal or an implant lying just at the base. As opposed to this is a much broader configuration of a vascular subconjunctival lesion, which is increasing by days in this immunocompromised individual, HIV positive individual, and that is Kaposi's sarcoma. So vascular lesions are many and you should characterize it. Going on to fibrous myxomatous tumors, this is a patient where there is an orange colored lesion in the plica with spontaneous hemorrhage. So this is a patient who has conjunctival amyloidosis. Conjunctival amyloidosis does not generally have systemic connotations. This is again a patient with palpable conjunctival amyloidosis. The clinical characterization is that it is translucent, very strongly pink, and when you evert the conjunctiva, it starts bleeding. So spontaneous hemorrhage is a characteristic of conjunctival amyloid. You can simply debulk it and cryo it and leave it alone. Lymphoid tumors are 3 types: benign reactive lymphoid hyperplasia, atypical lymphoid hyperplasia, and lymphoma. Now the color is the same, size may be different. So all these lymphoproliferative lesions have this fleshy pink or salmon pink color. Just by looking at the color, you cannot diagnose it as one of the types of lymphoproliferative lesions. This is a much larger lesion, but it turned out to be a atypical lymphoid hyperplasia. So these are the 4 different variants of conjunctival lymphoproliferative lesions. Unless you do biopsy, you will not be able to differentiate one from the other. So biopsy is the key to confirmation of diagnosis and followed by systemic evaluation. How much time do I have? How much time?
So you go ahead.
Okay.
Yeah, you go ahead.
So quickly about the management. In management, we have topical therapy, surgery and radiation. So in topical therapy, we have either chemotherapeutic agents, mitomycin or 5-fluorouracil, and in immunotherapy is interferon. Now, if you just want to know how we use immunotherapy, there are 3 modes by which we use. Immunotherapy is for complete tumor control. Immunoreduction is to reduce the size of the lesion before you treat it. That means you do a limited surgery. Immunomodulation is used to modulate the ocular surface immunity so that these tumors don't come back. That's in high risk patients. One of the clear indications for topical therapy would be corneal OSSN. This patient had undergone biopsy in this location by a cornea specialist before he sent the patient over to me, and that's the exact area where there is scar after rest of the lesion regressed with topical therapy. So scar formation would be a possibility in patients who have corneal OSSN, and that's why you should use topical therapy. If it's a small tumor, again topical therapy works. If a tumor extends to about 6 clock hours in the limbus, then because of limbal stem cell deficiency, you may not be interested in doing a primary surgery. There again topical therapy works. Or if it's a diffuse flat tumor like that, as opposed to a nodular variant, again topical therapy works beautifully well in these patients. Topical interferon is an indication in all these patients. Also in patients who have developed OSSN at the graft-host junction, patients with xeroderma can have this kind of an issue. Again, if you were to excise this, the graft may be compromised. So topical therapy works very well in these patients as well. When you have a diffuse tumor, you bring in injection interferon. Not all patients work as beautifully as this patient did, but it's a good option for patients. Otherwise, you would only have orbital exentration as the option. One more patient with diffuse conjunctival OSSN responded to injection interferon. Immunoreduction is a principle where this large tumor can be reduced to a much smaller size by doing topical therapy initially, and finally you excise only this part of the lesion. Immunomodulation, of course, for xeroderma pigmentosa patients. And whenever we have planned surgery, then we have to be very detailed with our clinical evaluation and also imaging, and then you do the surgery. Skip the video basically, but surgery is very effective in patients with ocular surface tumors. Even in patients with conjunctival melanoma, of course, there is scarring, but surgery has excellent prognosis. This is again a patient with conjunctival melanoma where surgery has been performed. But there are some patients who are beyond surgery, patients who have, say, scleral invasion like this. We would earlier do extended enucleation, etc., because they were untreatable or potentially untreatable. Now we use plaque brachytherapy for them. We do flush excision, and for the base we do plaque brachytherapy with good success. Plaque can also be done as a primary measure in patients who already have a corneal stromal melt, where if you were to do surgery, there might be corneal perforation. So we can do a primary plaque brachytherapy. Even in melanoma with scleral component, you can bring in primary plaque brachytherapy. Patients who have intraocular extension, you can see ciliary processes there with full thickness scleral invasion, but eye with 6/6 and 6 vision, there we again excise and do a rotational plaque brachytherapy with reasonably good success. Latest is about target therapy, where either you can do local target therapy using rituximab in patients who have lymphoproliferative lesions, or for conjunctival melanoma based on the mutational spectrum, you can do target therapy. Pembrolizumab, nivolumab are some of the drugs. This is my own patient where he had regional lymph node metastasis for which nivolumab was given. 3 months later, his conjunctival lesions have all disappeared. So target therapy is something that is useful for metastatic lesions and also for primary lesions. With all that I mentioned, the risk of recurrence of ocular surface tumors can be brought down to less than 5%. Or less than 2% lymph node extension if you were to use a protocol. So in conclusion, I would say that ocular surface tumors have a very wide and a very interesting spectrum. They're actually staring at you begging for a diagnosis in a clinic. And if you identify the key features in any of these tumors, you should be able to diagnose them. Treatment is very fair and simple. In fact, it's much easier than performing cataract surgery. But you have to do by the protocol and take special precautions so that these tumors don't come back. Thank you so much.
Thank you so much, sir. And this has been an excellent spectrum, and Dr. Santosh Hunavar is a guru of gurus. So we have 1 minute. Like, if you have any questions to sir, please come up and ask. And no questions are silly, okay? You can ask whatever you want.
There is no biopsy required in conjunctival tumors unless you're planning a destructive procedure. If you're planning, say, enucleation or extended enucleation or orbital exentration, then you have to do a biopsy for medico-legal considerations. Otherwise, if you want to do a biopsy, it better be excisional biopsy, right? There's no role for an incisional biopsy in a conjunctival lesion unless you are very confused about the diagnosis and you can't take the next step without knowing what it is. Then there is a role for incisional biopsy. Otherwise, it's excisional. There is very minimal role for impression cytology because that gives you any very superficial cells and that will not help you characterize the lesion in its entirety. So that's what. I think Kaustubh will touch upon all these aspects. He has a lecture.
Any other questions? No? You understood everything. Really? Okay. Good bunch of students then.
Okay. Thank you.
Thank you, sir. Thank you so very much.
So now we'll be inviting Dr. Feroz. She is an entrepreneur and having her own flourishing practice in Bangalore. She did her basic fellowship under Dr. Santosh and then she went ahead under and did her training under Dr. Shields. She also went across the borders to extend oncology services. Correct me if I'm wrong, ma'am. She went to China in pre-pandemic era. And her topic, tumors of eyelid. So in tumors of eyelid, a basic thing is that you have to remove the tumor along with the aesthetic thing which you need to reconstruct in the eyelid. So I think Dr. Feroz is the pioneer in both the things. She can remove the tumor and give aesthetic appearance to the patient. Over to you, ma'am.
Thank you, Smriti. Thanks for the introduction and very good morning to all of you. I'm Fairoz. So we'll keep it interactive, okay? We want more of audience interaction. We'll discuss about cases so that it's interesting and most of you don't sleep today, all right? And well, these are my affiliations. So why is it so important, eyelid lesions? Is ocular oncology important for your exam? Is it important for you to know things? Yes, it is. All right, so I have just taken this picture. Very interesting question. This is a DNB question. A 60-year-old lady presents with progressively increasing upper eyelid mass. Discuss differential diagnosis and management. It's an exam question. See how important oncology is. So just give me two differential diagnoses here. Sebaceous gland carcinoma, two. Basal cell carcinoma. Hi, I can see few familiar faces here. Great, all right. Okay, yes, so it's so very important. And you know the mark is like 10 marks. All right, so you have to really know about these things. Now, yes, eyelid is really important again. So from my PG days onwards, eyelid anatomy and LPS has been a favorite question all throughout in the question paper. So yes, eyelid is also very, very important. All right. Now, I just want to highlight this anatomy thing whenever we talk about any lesions in the eyelid, be it neoplasia, be it inflammation, it all depends upon where it arises from. And all these tumors, there are multiple tumors, there are a spectrum of tumors, everything actually has an anatomic origin. So mostly how we generally classify is in the anterior lamella and the posterior lamella tumors, something that arises from the skin, the orbicularis, something that arises from the tarsus. So which are the malignant tumors that arises from the anterior lamella? Aishwarya? I know the names. Hi, yes, anterior lamellar tumors. Something that arises from the skin. Sebaceous anterior lamella, really? Okay, now where does the sebaceous arise from? Anurag. Anurag? Anurag, don't hide. Saurabh, Anurag, yes, hi. Where does the sebaceous gland carcinoma arise from? Posterior lamella from the meibomian gland. So meibomian glands are situated in the posterior lamella, right? Yeah, tarsus. Tarsus is posterior lamella. So what are the tumors that arises from the anterior lamella, Aishwarya? Basal cell carcinoma, squamous cell carcinoma, right? Basal cells are there in the skin, squamous cells are there in the skin. Melanocytic skin lesions are also there in the skin. So that is how you generally classify. Now there are tumors, there are so many other structures in the eyelid. What are the other structures? You have cilia. You have so many glands, you know. Yes. You cannot answer. You come later with the pathology and etiology. All right. So all these tumors can arise from various, from the glands of Moll's, from the meibomian glands, from the sweat glands, from the cilia, blah, 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 blah. So that is how you have to actually classify, especially when you see a lesion in your clinic. All right. Now, these are the spectrum that we see. It includes benign. It includes benign looking malignant. It can be malignant looking benign or even malignant lesions. Does anyone want to take a quick diagnosis like spotters here? Ashwita. I know her. What is this one, Ashwita? This one? Yeah? Does it have a appearance of, okay, now tell me whether it's benign or malignant. Benign. Cool. Okay, it doesn't have much of a malignant feature here. Okay, it is very papillomatous. What is it? Papilloma. All right, this one, benign or malignant? Benign. Cyst? Cyst. Perfect. This one, posterior lamella. Yeah? Yellowish. Yes. What's your name? Yes. Sakshi. What is it, Sakshi? Granuloma may be a differential diagnosis, but granulomas are usually reddish in color. Another thing that you have to keep in your mind is colors. Okay, depending upon the colors, actually, you can diagnose. Right? Red is vascular, granulomas are red. Yellow is what? Sebaceous. Yellow is sebaceous. All right? Yeah. Okay. This one, brown. Melanin. Nevus doesn't look malignant though, right? Yeah. This one, papilloma actually, okay? Very bad lesion here. It's eating up the tissues. Malignancy, right? Yeah. Rodent ulcers, yes. Basal cell carcinoma, this is sebaceous in fact. This is rodent, usually in the middle, right? Yeah. This one, very nice. Strawberry. I like it. Hemangioma is a differential diagnosis, okay? But there is something called Merkel cell carcinoma. It's only one case that I've seen, okay? Very vascular lesion and lethalist of the eyelid malignancy. Okay, this one, easy. Capillary hemangioma, eating up again. Yeah, it is actually a squamous cell carcinoma. Okay, so these are the spectrums, okay? Now, we'll go case-wise. So this was actually a 65-year-old lady who came into the clinic, recently seen. I saw her in 2022, later part of 2022. And she said that she's feeling some thickness in the eyelid. Well, I can't see anything over here. She said a doctor treated me and probably she was treated for a chalazion. Okay, yeah, I can't see anything. Then I told her, why don't you look down? You know, is there anything lumpy, bumpy in the upper eyelid? No lumpy bumpiness. Can you see anything here? Not really, but if you really look over here, there is a little bit of elevation over here. So it's so very important in eyelid lesions. It's just not the eyelid skin outside that you examine. Avert it, right? Very, very important. Okay, so I just averted it. And she's a very intelligent lady, all right? So she can actually feel. She keeps sitting and thinking that there is something going on over here. And this is what's seen over there. A yellowish plaquette lesion over here. Okay? Does it look like a chalazion for you? It doesn't look like chalazion. Chalazion doesn't have this vascularity. So whenever a lesion has vascularity, there are two types of vascularity. One is intrinsic vascularity and the other one is like large feeder vessels, all right? These are the two things that you look for. And it's kind of diffuse. Chalazion doesn't look like this, isn't it? Yeah. So, and it was very, very thickened, yellowish. And what is very notable over here is the thickening of the posterior lid margin. The posterior lid margin is thickening. That means something is invading the glands over there. Okay. So dot diagnosis was sebaceous gland carcinoma. Now this was like so there are certain features that you have to look into. One, feeder vessels. You have to look for lash losses. Once there is invasion into the posterior lid margin and the lashes are going to be lost. So whenever there is a lash loss, you have to keep it in mind that it could be sebaceous gland carcinoma. And why am I putting this as a first case today? Because this is the most common eyelid malignancy in our part of the world. Okay, in the Western world it is mainly basal cell carcinoma. All right, yeah. So, what I did was, obviously in any cancer, as Dr. Smriti has also pointed out, according to the ocular oncology principles, we have to excise it. And we usually excise it with margins, clear margin. So I went ahead excising it, and this was the clinically, appearing margin of the lesion. And then we go actually 4 millimeters around to get a clear margin. Okay, we call it clear margin. I got a frozen section positive. We always do a frozen section positivity. There is something else called the Mohs surgery, where also you go for a clear margin. These are the two options that we have. I'm not a Mohs surgeon. Most of us are not Mohs surgeons. So what we do is margins, and then we do a frozen section. Kaustubh gets everything. Within 30 minutes, he tells us whether it's positive or negative. Despite having a very, very clear margin, the frozen section margin came positive in this area. So why I wanted to highlight this here is, even in your medical colleges, wherever you set up your practice, even if you're a general ophthalmology comprehensive, don't take it lightly. Okay, despite taking a 4 millimeter margin, because of the invasiveness of the lesion, it still came positive. So what do I do next? I still take a margin. I take a margin again, send him back to the pathologist, and then until I get a negative margin, I don't reconstruct. Okay, so that is how so carefully we take care of this. And well, so this is how the reconstruction happened, despite the fact that she had a large lesion. And an ocular oncologist, being an oculoplastic surgeon, as Smriti said, we take care of the cosmesis also. But cosmesis for me is secondary. My oncology principles are very, very primary. I would say primary, secondary, and tertiary for me. Then comes the oculoplasty. So what I did was a Tenzel's flap. A flap were raised laterally, and then the margins were joined, depending upon how much the defect is. Okay, and this is how she looks. So PET scan I have written over here. So that is basically to look for. So yeah, okay, as for the systemic metastasis. So in lethal malignant eyelid lesions, we do this so that we make sure that there is no malignancy, whether there is regional metastasis or systemic metastasis. So this was yet another patient. As you can see here, a little bit of lumpiness in the lower lid over here, eversion. Okay, a small lesion sitting here. It's already actually growing towards the lid margin. Very small, a good pickup by a comprehensive ophthalmologist, and this also came out to be a sebaceous gland carcinoma. Now this, what is it? Cyst? Bluish in color, no? Very bluish, yeah. Cyst. Yes? Why? Ashwita. Feeder vessel is there. So something which is very odd is it looks a stick, but then it has a feeder vessel sitting there. So again, suspicious. This also came out as a sebaceous gland carcinoma. Okay. Now this one. This was a lady, okay, who has had 3 times incision and curettage done in the upper eyelid. Rapid, the lesion coming up. So when this happens in an older lady where incision and curettage has been done for chalazion, it's recurring, you are actually suspicious about it. But it doesn't have like too much of a features of a malignancy. Still, I am doubtful. So what do? I don't throw away the incision and curettage material. Okay? It's doubtful. So even when you do an INC, take the material, send it for histopathology. Lucky for her, happy for me, this still came out to be a chalazion. But whenever you are in doubt with recurrent incision and curettage, always make a point that you send it for histopathology. Okay, yeah. This is an epidermal cyst, a very fast growing cyst. The tarsus is absolutely fine, but there is an elevated nodule over here. It came out to be an epidermal cyst. Now this lady had a lesion, she was having irritation in the lateral canthus, has been treated by a comprehensive ophthalmologist for a long time with lubricants, and they said it's a blepharitis. Okay, yes, blepharitis, posterior blepharitis, anterior blepharitis, you all know about it. But usually blepharitis is bilateral, right? Unilateral, focal is again something which is very, very suspicious, okay? This is how it looks like. Not looking good, right? Lots of lash loss, the posterior lid margin is eaten up, and this is how it was, okay? So what we do is we again have a suspicion of sebaceous. What type? Pagetoid spread. Amazing. You guys are so good. I didn't know this when I was a PG, yeah? Seriously. Excellent bunch of people here. This was a pagetoid intraepithelial variant of a sebaceous gland carcinoma. So you have to look into a caution in these particular situations. So then it's not excision. What we do is we do a map biopsy. So we eat up Kaustubh's head. We send around 17 samples to him, okay? All from the surface, 2 into 2 millimeter sample, including the caruncle. This goes to him, and then he tells us which are positive and which are negative. Depending upon that, we take a decision what is the management in these patients. So sebaceous gland carcinoma again can arise from different glands, not only meibomian glands, okay? It can arise from the margin, glands of Zeiss, it can arise from the caruncle. Caruncle is a very special area. I'm sure Kaustubh is going to touch about it. Why is it so special? Anatomically, pathologically. Yeah? Saurabh is there? Saurabh? Yes. Why is Canthal area so important? Nasolacrimal drainage in the Canthal area? Well, we have a puncta there. Anatomically, how is it different from conjunctiva? Vestigial remnant. So there are many structures there. Okay, you have skin, you have glands, right? You have hair follicles. So any tumor can arise from the caruncle. Squamous cell carcinoma, sebaceous gland carcinoma, follicular tumors, sweat gland tumors. Any tumors can arise from the caruncle, and that's how important caruncle is. So sebaceous gland carcinoma can arise from the caruncle also. Thank you, Saurabh. Okay, and another important thing, if your examiner asks you what is so important about sebaceous gland carcinoma, it's a very well-known masquerader. Okay, these are the different ways that it can present. We have already touched upon it. Basal cell carcinoma, I'm going to deal with the malignant ones first, and then we'll go to the benign. So basal cell carcinoma has various forms. Although it's not a masquerader, it can be superficial, it can be nodular, micronodular, morphiform, cystic, infiltrative, pigmented, and something called the fibroepithelioma of Pincus. Now, it can be systemically associated also. Okay, sebaceous gland carcinoma systemic association. Anyone? You're getting a chocolate, like a big bar of chocolate. No, Kaustubh, not you. Neha, that's guess. No Neha here? There has to be a Neha here. No? Amit? Amit is there. No? Okay, who else? Really, you're asking the question? Okay, so I'm not giving you the... So, Google, okay, what is the association? You have to answer him. All right, so the systemic association of basal cell carcinoma is Gollen-Gott syndrome, Basic syndrome, and xeroderma pigmentosa. I'm sure you have seen a lot of cases of xeroderma pigmentosa in your practice. So they can have basal cell carcinoma, they can have squamous cell carcinoma for the conjunctiva, etc. So this is again what you call it as the rodent ulcer, okay, in the medial canthus. This is the most common location. So frozen section, second frozen section, third frozen section, actually we got the margins negative in this case, okay, and with the reconstruction over here. Extensive reconstruction in basal cell carcinoma. Sometimes it's so very infiltrative. Okay, we had to really literally take a cheek flap over here. Now, surgical excision without margin clearance. This was a lady with basal cell carcinoma. Sometimes we cheat in basal cell carcinoma regarding the margins because it's not lethal, but still it can recur if you don't take it. This is 3 months recurrence of a basal cell carcinoma where she had to undergo again an excision. Now, this was a case where pigmented lesion of the eyelid. This was a malignancy, pigmented malignancy. One, of course, basal cell carcinoma. Another one, melanoma. Okay, this was a case of a malignant melanoma. In fact, I had to literally take almost 7 millimeters on either margins because which is very, very important. A Tenzel's again, and this was how she looked after 3 years. Okay, yeah. Good enough. Now, this is surgery. I'm going to come back later if I have time, okay? Not too important. Okay, we'll come back if I have time. Now, this was a patient again presenting. Did I give away the diagnosis? I gave away, sorry. Anyway, so this was arising from the sweat glands. So, sweat glands also we can't take it too lightly. Okay, we do see these rare tumors. This came out to be a syringoadenocarcinoma arising from the sweat glands. Again, the giveaway is the large vascularity, although it looks benign, cystic, etc., and that is how we excise. So this is also cystic over here. Okay, what we do is like we actually take a torch and look for transparency. What are the cystic lesions of the eyelid that you know? Cystadenoma, ecrine hydrocystadenoma, apocrine hydrocystadenoma, cyst of Moll. These are the cystic lesions. So this actually came out to be a syringoadenoma of the eyelid. Now this lady has the cystic lesion for a long time sitting in her eyelid. In fact, someone actually needled it. That's what she said. You know, some ophthalmologists needled it and there was a liquid which came out, but then it again started growing for a long time. Does it look like a cyst of Moll? Ecrine hydrocystadenoma, apocrine? What? Looks good or bad? Bad. Vessels, right? Okay, I'm happy that you identified that. So this came out to be an endocrine mucin producing sweat gland carcinoma. Yes, you had diagnosed it for me, Kaustubh. Okay, so it's very rare. In fact, this has an association with breast carcinoma also. She had a family history of breast carcinoma, but well, we evaluated her and everything was perfectly fine. So malignant eyelid tumors are done. Okay, now lethal eyelid tumors. So you need to know malignant. Among them is the Merkel cell in the chronology. Then comes malignant melanoma and then comes sebaceous gland carcinoma. Now this is a patient who presented with this lesion over here, kind of a crater. Quick spotter. We are coming to the... Any diagnosis? The gentleman who's sitting, the last bencher, looks really fit. You do a lot of exercise. I can see that. And I'm sure you study also very well. What is the diagnosis? No? He said no. He don't know. What is it? Please sit down. Please sit down. No? Nodular. Basal cell? Basal cell carcinoma, differential diagnosis. Anything else? I thought basal cell carcinoma. Okay, I send it to Kaustubh, boom. It came out as a nodular hydroadenoma, benign. Okay, so there are even malignancies. I actually went and did a margin, etc., okay, because I thought it really looks like basal cell carcinoma. So sometimes you're also wrong. So this is a keratoacanthoma. Okay, keratoacanthoma has a very typical crater-like appearance. Okay, and keratoacanthoma, you have to know, is a low-grade what? Low-grade what? Malignancy, yes. Specifically, squamous cell carcinoma. Okay, yeah. A low-grade. Thank you, ma'am. Okay, so this is how it was excised again. So this patient was referred to me as this old, Aji eyelid tumor. Large one, no? Yellow in color. Yeah, looking good? Looking good? Sebaceous? Sebaceous? No? Okay. It's actually arising from the conjunctiva. Okay, it's hanging out. All right. So, well, this was a pyogenic granuloma. Pyogenic granuloma is a misnomer, guys. Okay, it's an exacerbated granulation tissue. Okay, it's neither a granuloma or neither it is pyogenic. She was super happy when it came out because someone told it's a cancer. She was super duper happy and she's my favorite patient. Okay, so benign eyelid tumors, nevus, epidermal cyst, we have discussed most of it. And what is this? Kissing nevus. Okay, so we have a particular surgery, very interesting name. It's called epithelial stripping of the kissing nevus. Interesting, right? So the only thing that we do is like we strip the epithelia. So this is an epithelial tumor. You don't have to go to the stroma. So you just actually do an epithelial stripping and there is second intention healing that happens. So there is no suturing over here, nothing. I just removed it. Okay, yeah. All right. So this is what? Nevus again? Yes. Really? Do you want to think of anything else? Stuck on appearance? This is like our dermatology in MBBS level. Not even PG, huh? What? Actinic? That's okay. I mean, I would have told it wrong when I was a PG. Don't worry. Anything else? This is an MBBS level dermatology thing, huh? Malignancy? Malignant melanoma, where is the feeder vessel? We spoke about it. It looking so neat and nice and black in color. What? Such a large what? Well, what? Is there a name called what for this? No. Kaustubh says no. Anything else? They can have these stuck-on appearance on the neck and all. Hmm? No? Really? Rolika? Really? You're getting admitted for fellowship right away after Dr. Santosh Honavar's fellowship with me. Okay. Seborrheic keratosis. Okay, a large, this is called stuck-on appearance. It's like stuck on there, okay? It's a seborrheic keratosis. You can get it smaller versions, bigger versions. So what I did was, it was a large lesion, I have to excise it. She needed a skin graft, okay? And well, I love doing blepharoplasties, right? So I gave her an offer. Well, the deal is, I'm going to give you a nice blepharoplasty in the opposite eye. Let me take out some skin, okay? And put that skin on the other eyelid. And that's exactly what I did. And she did a nice cosmetic surgery of the other eye also. Cyst, yeah, sebaceous cyst. Very easy, okay? Excised. Okay, now this one, hemangioma. Okay, very interesting, like congenital children. Rolika, just tell me if I'm overshooting and how much time I have, okay? So what I did in this thing is, what you need to know about capillary hemangioma, it can be a short note also because there are so many newer things happening, is oral propranolol, okay, is the treatment. So this baby was like 28 day old when I saw the baby, and oral propranolol, and also I gave topical timolol maleate on the surface to reduce. So beta blockers is the treatment of choice at this point of time. 24-year-old lady with complaints of lower lid swelling, left eye, noticeable since 5 years, associated with aching pain over here. Okay, what do you think it is? What is the color? Bluish, no? So it has to be vascular, isn't it? So, yeah. Okay, so basically it was a varix that she had, okay? Injection bleomycin, 2 more minutes, okay, I'm done. And 1 session and it has gone. Now this lady was sent to me with lower eyelid bag, possible, cosmetic surgery, yes, okay, sorry? Tell me. Fat prolapse, right, cosmetic surgery. So I was like, okay, let me do some aesthetic, do I have to do? And that's why the patient was referred to me. But when I saw her, it was not looking. So fat prolapse, it is softer. We know it was not soft. It was firm, okay? And then I went ahead doing a imaging over here. So lesion extending to the orbit, okay? Well, voila. It came out to be a small lymphocytic lymphoma, CLL. The patient is actually no more. Okay, yeah. So such things can also come to you in your... Now, sentinel lymph node biopsy, just have to know about it. There is something like this. It's usually done in Merkel cell, malignant melanoma of the eyelid, the lethal tumors, and the sebaceous gland carcinoma, in order to know the regional lymph node drainage area. So this is the indication of it. Okay, there are papers on it. You can read it. Another advance is the Wismodegib, hedgehog pathway inhibitor, basal cell carcinoma. Okay, this can be asked for you. Maybe in a viva or anything, you have to know about it. So this is how I have not used it in my practice, but in the West, they use it a lot for these large basal cell carcinoma. Now the newer ones, Dr. Santosh already touched upon it regarding malignant melanoma, epidermal growth factor receptor, targeted therapy for squamous cell carcinoma. Okay, second line of treatment. Well, there are papers, I have not personally used it. Checkpoint inhibitors. These are for melanomas. Okay, so these are all the newer things. So you should know molecular targeted therapies are available for malignant eyelid lesions. Okay, spotter. Only 2 spotters and we are done. I have only 1 minute. Kaustubh is looking at me. I'm ignoring him. Yeah, spotter, quickly. Since childhood, he has been walking with this. Then it's not malignancy, no? It has to be something benign. Okay? Flu? Neurofibroma, yeah? Close. All right. So he has a mechanical ectropion also because of that. So ectropion was corrected, the lesion was excised, and that's how it is. Potter. Molluscum contagiosum. Sir, you are giving the answer. Really? Okay, so it's so very important to identify and treat appropriately. You should know these things exist and you should not go wrong. Try not to go wrong most of the time, and timely referral is so very important. And sticking on to oncological principles is again very, very important, apart from the cosmesis. All right, we are done. Thank you so very much for your patient listening. Yeah. Sir, I promised you that I wouldn't overshoot with my excitement, and I did. Thank you so much.
Thank you very much, ma'am. Hope you all will be able to diagnose as the diagnosis is written on the face. So, ma'am has justified it. All cases you will be seeing in your OPDs, just make a diagnosis and do an appropriate management. I would like to invite again, sir, for intraocular tumors. Sir, over to you.
Okay. Moving on from something that where diagnosis is written on the face, now we have to actually make efforts to do the diagnosis, that is intraocular tumors. You have to actually look into the eye to see them. They're not staring at you, but you have to stare at them. So you have to have, again, some clinical clues to diagnose them. So always ideal to go by the color because there's a huge spectrum of them. Ciliary body and iris tumors are rather simple. Like this patient has lumpy, bumpy appearance. You can see this, the anterior chamber is sectorally shallow with what looks like a globular lesion pressing the iris periphery forward. There clinically you can't diagnose until you do a imaging. So imaging will tell you whether there is a cyst or a solid lesion. This is called a peripheral cyst or iridociliary cyst, which is generally in the periphery. As opposed to that, an exactly similar patient may have a solid lesion, which is a melanoma. So unless you do imaging, it's difficult to say. Based on the location of the cyst, one was the peripheral iridociliary cyst. The second one is a mid-zonal cyst. Mid-zonal cyst on mid-dilatation of the pupil cannot be seen as bilobed or single-lobal lesion, and that is how imaging looks. And the third one is a pupillary cyst. This is again a mid-zonal cyst, whereas this is pupillary cyst, where there are a lot of saccular lesions at the pupillary margin. This has association with Ehlers-Danlos syndrome and dissecting aneurysm of the aorta. So if you have a pupillary cyst, then that is somewhat dangerous, and a free-floating cyst. So these are 4 variants of iris cyst. That is iris pigment epithelial cyst. Now this is a stromal cyst. Stromal cyst generally is acquired, follows injury or any kind of intraocular surgery where iris may have been damaged. So this is a traumatic iris stromal cyst. A child with a hypodermic needle injury 5 years ago now manifesting with a traumatic iris stromal cyst. The next spectrum is of melanomas. Now melanomas can be 2 variants in the iris, 2 typical variants. One is nodular, that's a nodular melanoma, and as diffuse melanoma where the pupil is dragged towards the lesion. Diffuse melanoma is somewhat in the periphery or mid-periphery where the pupil gets dragged towards the lesion, whereas nodular is, as you say, is well circumscribed. The third variant is a diffuse melanoma. Now diffuse melanoma can masquerade as unilateral secondary glaucoma. This patient has undergone a trabeculectomy, that is the ostium, and behind the PI you see a black lesion. There is correctopia, ectropion prompting the diagnosis of IC syndrome, which it was not. And this patient, after enucleation, you can realize that that is the scleral flap, under that there is tumor, and that is the bleb in which there is tumor. So secondary glaucomas can be misdiagnosed as secondary glaucomas without paying attention to imaging. Suppose he had undergone imaging, then this lesion could surely have been picked up. So whenever we have a confounding pigmented lesion in the iris, we always look at the pupil. Pupil gives us the clue. If the pupil is nice, round and central, then irrespective of the pigmented lesion, you don't diagnose it as malignant. So this is a pigmented lesion here, but the pupil is nice, round and central. There is no NVI, that is a melanocytoma. So pupil does not get affected by a benign lesion, whereas if there is correctopia, ectropion, NVI, then that is likely to be a malignant lesion. So this is a melanocytoma, which is nothing but a magnocellular nevus. It is pregnant with pigment, and these pigments get shed in the anterior chamber. They block the trabecular meshwork, and that causes glaucoma. Nevus, iris nevus, again pupil does not get distorted. It is like a button sitting on the iris without any distortion. Whereas this is a melanoma, that's called a fibrillary variant of melanoma, where there is irregular margins. That's called a tapioca melanoma, where there is nodular excrescences in the iris, and that's a ring melanoma of the iris and trabecular meshwork. So these are rare variants of melanoma. Now, melanoma that is hidden and very difficult to diagnose and generally gets diagnosed very late in its manifestation is a ciliary body melanoma, because it's a hidden melanoma. The only clinical sign that you may find in such patients is called a sentinel vessel, which is a single large dilated episcleral vessel which is tortuous and somewhat dips into the sclera about a millimeter or millimeter half from the limbus. And in patients where you suspect it, you have to dilate the patient fully, ask the patient to look in the entirely opposite direction, in the direction where you suspect the lesion, and look at it from the totally different direction from the slit lamp, and you may just see a tip of it. Sometimes the extraocular extension may be the first manifestation. So you have to do imaging if you are suspecting a ciliary body melanoma. And the management options are local resection for a tumor which is like 3 clock hours. We locally resect it like this patient, or do plaque brachytherapy, or do proton beam radiation. Now, there are some situations where tumors can present like uveitis. This patient has hypopion, but he has a white eye. He does not have circumcorneal congestion or ciliary congestion at all. A white-eyed hypopion, you should suspect that the patient may have lymphoma, metastasis, etc. So, in a younger child with white eye hypopion, you suspect retinoblastoma, or if the hypopion has a level to it, then it is retinoblastoma. Hypopion is translucent balls of cells like this, then it could be medulloepithelium of the ciliary body, which can also present with loss of zonules in the area where the tumor is present, and a retrolental membrane. Going on to hyphema, this is a child who has recurrent small hyphema which resolves spontaneously. What do you think it is? Recurrent hyphema in a child which resolves spontaneously with or without treatment. And during a quiescent phase, you find this placoid yellow lesion obscuring iris details. Yeah.
Skin lesions.
Yeah, skin I can show.
Yeah.
What is it?
This is like
Shout it out. Somebody said it. I heard. Juvenile xanthogranuloma. Absolutely
awesome.
right. So JXG causes hyphema, and that's a yellowish lesion. Now, yellow-white tumors, now we're going into the fundus. If you have a yellow-white tumor in the fundus and the child has facial lesions such as, say, nodules on the face or periangle hemangioma, ash leaf sign, then you're suspecting tuberous sclerosis. So this is astrocytic hamartoma in a patient, where if you look at the calcification, it is like fish egg kind of calcification. So you see globules of lesions which are peripherally calcified. That is one variant of it. Whereas if you have a child like this where there is solid calcification, then you should either suspect retinoblastoma, or this was an older individual where his child had retinoblastoma, this patient had retinocytoma. So retinocytoma and retinoblastoma can also be yellowish white. The next variant of astrocytoma is like absolutely avascular lesion sitting on the retina, again like a button, obscuring the blood vessels. So in the area where it is present, blood vessels are obscured. This is acalcific astrocytoma. So astrocytoma can be calcified or acalcified. If it is calcified, it is globules of calcification. If it is acalcified, it obscures the layers of the retina and sits on top of it. Now when a lesion assumes a slightly pinkish architecture, and it is almost always in the posterior pole, unilateral, placoid, and we do B scan, we find shadowing. Then what is it likely to? Choroidal osteoma. Choroidal osteoma is a posterior polar lesion, pinkish white, and when you do B scan, you find a choroidal shadowing or shadowing artifact because of the solid osseous lesion. Now, choroidal osteoma, if you want to do OCT, you find that there is overlying retinal pigment epithelial detachment sometimes, smooth choroidal elevation, and intrinsic horizontal lamellae within the lesion. That is very characteristic of choroidal osteoma. It can have secondary bleeding because of CNVM. It can also be multifocal. This patient also developed a CNVM because of which there is exudation. Otherwise, it's going to be a silent lesion. It can also be bilateral. This is a patient with bilateral choroidal osteoma. Now, a peripheral lesion which looks like calcific can be idiopathic sclerochoroidal calcification, which is an innocuous lesion. Now, going on to lesion with retinal exudates. There are three main lesions which form retinal exudates remote from the site of the lesion. These patients have macular exudation, because of which they have lost vision, but the lesion is somewhere else. So, can you guess looking at these three pictures? When there is a finger-like projection pointing towards the fovea, you should not be misguided, but you should look in the opposite direction. So what is it likely to be? Let's talk about the first case. You can see this finger-like projections pointing towards the fovea, but you should look in the opposite direction.
Dilated vessels, sir?
Yes, dilated vessels. So when you look in the opposite direction, follow the dilated vessels, you find the lesion lying in the periphery, and that is retinal capillary hemangioblastoma. It's currently called hemangioblastoma. Earlier it used to be called retinal capillary hemangioma. Now it is just like the cerebral hemangioblastoma. It's also a hemangioblastoma seen as a part of von Hippel-Lindau disease. So it's a systemic disorder. So when you cryo this or treat it appropriately, exudate also disappears. So finger-like projections of these exudation should always give you suspicion that you are looking at a patient with retinal capillary hemangioblastoma. One more example, you find this architecture constantly. No patient would be without this finger-like kind of projection pointing towards the fovea, and you find a retinal capillary hemangioblastoma. Now the next set of lesions, of course, treatment of choice would be photocoagulation, where you identify the feeder vessel first and then photocoagulate the feeder vessel. You don't photocoagulate the draining vessel first. If you do that, the patient will have hemorrhage and exudative retinal detachment. Otherwise, you can treat it with transpupillary thermotherapy or even photodynamic therapy or brachytherapy with good success. The most important to know about retinal capillary hemangioma is its association with VHL disease, where these patients tend to have cerebellar hemangioblastoma, renal cell carcinoma, pheochromocytoma, pancreatic tumors, etc. But the most important killer disease would be cerebellar hemangioblastoma and renal cell carcinoma and pheochromocytoma. So these patients would need systemic screening with MRI brain and high resolution CT scan of the chest and abdomen. Or short of it, if a patient has a single retinal capillary hemangioblastoma, you simply do a VHL gene test, because some patients may not have syndromic variant. If they have VHL gene positive, then they need lifelong screening. If they have gene negative, then they don't need lifelong screening for systemic lesions. Cumulative probability also increases. That means that ophthalmologists generally have the first chance to see these patients, because if you see this red graph is retinal capillary hemangioblastoma, and that is the first to manifest. These patients come to you with blurring of vision, and if you don't do systemic evaluation at that stage, they went on to become adults and develop cerebellar hemangioblastoma and renal cell carcinoma, because of which they die. So it is a lesion that can actually be picked up by an ophthalmologist, and you're supposed to do screening in these patients. Now the second lesion that I showed was this fleshy pink lesion in the periphery. This is called vasoproliferative retinal tumor. This is not a tumor, this is exuberant granulation secondary to some insult to the retina, which could be infective in etiology or inflammation in etiology, and these patients present with posterior polar exudation. And the next one is Coats disease. In Coats disease, the quality of exudation will be refractile. Refractile in the sense they shine through. This is nothing but cholesterol, saponified cholesterol deposition in the posterior pole. And if you look at the periphery, you find peripheral retinal telangiectasia. Going on with the same stream, if you find this bunch of abnormal vasculature in the posterior pole, then that is cavernous hemangioma of the retina. It is also associated with phacomatosis. Or if you find a bunch of dilated vessels like this with or without conjunctival component, then that is retinal arteriovenous malformation, also called Weber-Mason syndrome. These patients also have an intracranial component. Going on to dirty yellow lesions. Now if you take a peek at the fundus in a patient who has blurring of vision, and if you find this dirty yellow colored lesion, there are very few differential diagnoses, one of which would be choroidal granuloma. The second would be a retinal choroidal lymphoproliferative lesion such as choroidal lymphoma. Third would be metastasis. Now this is a patient where there is choroidal lymphoma. This is a dirty yellow lesion with limited subretinal fluid. In lymphoma, because it is a chronic lesion, there is retinal pigment epithelial changes overlying the lesion, and the amount of fluid that you found, subretinal fluid, will be minimal. So that is how you clinically diagnose choroidal lymphoma. And when you do imaging such as OCT, you find undulating seasick tumor surface. So this is the keyword that you're supposed to use. If you find a seasick tumor surface, then that is choroidal lymphoma. Now, the second variant of lymphoma, choroidal lymphoma, is a secondary lymphoma. It is associated with visceral lymphoma. The second variant of lymphoma that you find in the eye, it's called primary intraocular lymphoma, or PIOL, which is associated with CNS lymphoma. This is masquerade because it may present with vitreous haze like this. This is vitreous haze. This looks like vitritis, or a cloud like this, which simulates aurora borealis, or the northern lights phenomena. You can look it up. It's a very interesting phenomena. So this is how it looks. It's called aurora borealis sign, or clumps of seeds in the vitreous. And if you look at the retina, you find retinal and sub-RPE infiltrates. And the second keyword that is associated with this lymphoma is leopard spot pattern, because there is alternating retinal pigment epithelial atrophy and hypertrophy, looking like a leopard skin appearance. And again, on OCT, you find seasick appearance. So these are the three keywords that are associated with intraocular lymphoma. If you write all these three keywords, you should get good marks. And the treatment of choice, of course, is to do systemic evaluation, find out if they have CNS lymphoma. If they don't have CNS lymphoma, then you simply treat the eye with intravitreal injections of methotrexate or rituximab, and these lesions over a period of time go away, or do low dose radiation. Now going on to the next set of dirty yellow lesions with lot of exudative retinal detachment and very minimal retinal pigment epithelial changes. That means they are acute or subacute. That is choroidal metastasis. In men, the source of metastasis would be lung, generally most common, followed by any other organ. In women, it is the breast that is most common. If the patient is already on treatment, you might find a flatter lesion. If the patient has already been subjected to chemotherapy, then it may develop these RPE changes. So depending on at what time have you seen the patient, the morphology depends. This is the fresh case where no prior treatment has been given. This is a patient who has been already treated with radiation. It's a flat lesion. This is a patient who has been treated with chemotherapy, where it actually looks like a chronic lesion with RPE changes. All these are metastases. This is a patient where there is very classic metastasis. Metastasis is not generally unilateral unifocal, but can be multifocal, bilateral. You can see creamy whitish yellow lesions, dirty yellow lesions in both the eyes. This is bilateral choroidal metastasis from a CA breast in a elderly lady. Choroidal metastasis has lumpy bumpy tumor surface or shaggy photoreceptors on OCT. These are some of the times asked in the examination. And choroidal metastasis carries its color with it, color of the primary lesion. This was a cutaneous melanoma metastasizing to the choroid, carrying its black color. Some of the choroidal metastasis can be orange colored, that is a vascular primary. Papillary carcinoma of the thyroid, carcinoid, and what else? What is the third lesion that has orange colored, Rolika? Orange colored metastasis? Papillary carcinoma of the thyroid, then carcinoid, renal cell carcinoma. Okay, these are the three orange colored metastases. So you'll have to do your extension, Rolika, fellowship. But what you should...
taking her.
You take her, please. Yeah. Beat her and make her good. Choroidal metastasis is the most common malignant intraocular tumor. So this is what it is. It is not a primary tumor, but if you look at all the intraocular tumors, it is the most common malignant intraocular tumor in a child as well as in an adult. I mean, putting all together. Now going on to orange colored lesion, we began with orange colored choroidal metastasis, but other orange colored lesions could be plasmacytoma. But the most common benign intraocular tumor is choroidal hemangioma. Whether it is picked up or not picked up, but it remains to be the most common benign choroidal intraocular tumor. It is subtle orange in color, generally located in the posterior pole, produces subretinal fluid causing metamorphopsia and increasing hyperopia. So if a patient complains of frequent change of glasses, hyperopic correction, and also blurring of vision, micropsia, macropsia, metamorphopsia, then you should suspect choroidal hemangioma. it is often misdiagnosed as what? CSR. CSR is one of the common misdiagnoses of choroidal hemangioma, but because it can be so subtle. Unless the pigmentation is dark, if a dark individual, it stands out very bright orange, but in a fair individual, it can be hidden. It has a smooth surface with expanded choroidal vascular spaces, and only if the hyperopia is more than 3 diopters and patient is not correctable to 6/6 vision, if a patient has symptoms such as micropsia, macropsia, metamorphopsia, or blurring of vision because of SRF, then you treat it. And the treatment of choice is not photocoagulation because it causes a lot of scarring, but with low fluence photodynamic therapy. But unfortunately now PDT having gone away, we don't have any other choice but to do a transpupillary thermotherapy, for which we use indocyanine green as a induction agent, and also plaque brachytherapy is a good option. Now this I already mentioned. Going on to pigmented choroidal lesions or retinal lesions. If you have a child presenting to you with this kind of a lesion, this is called combined hematoma. Combined hematoma causes a lot of desmoplastic activity. So you have this blood vessel dragged towards the lesion in combined hematoma, whereas a crisp dark lesion which is in the layer of retina, not choroid, with some lucent areas, is congenital hypertrophy of retinal pigment epithelium, also called CHRPE. Now CHRPE is of 2 variants. One is congenital hypertrophy of retinal pigment epithelium, which has syndromic association, that is with polyposis coli or Gardner syndrome, or this is the routine CHRPE unilateral unifocal with lot of lucent spots. CHRPE was earlier considered to be stationary. Now we know that it can actually grow over a period of time. It can become bigger, it can become slightly elevated, producing RPE adenoma, or it can even become malignant, producing RPE adenocarcinoma. So it's no longer a quiet lesion, it can evolve into something different. Now what do you think is this? Quiet lesion located always on the optic disc, melanocytoma. Innocuous lesion does not bother much unless it grows big in size, then it causes a enlarged blind spot, or if it produces SRF, that means that it has CNVM attendant with it. Very rarely does it cause a central retinal artery or venous occlusion. Because of axial progression along the optic nerve, it constricts both the blood vessels and can produce blindness, sudden onset blindness. Now, what do you think is this? A silent choroidal pigmented lesion with lot of drusen indicating chronicity. Choroidal nevus. Choroidal nevus is a silent looking choroidal lesion, pigmented choroidal lesion. In fact, it is the most common benign pigmented choroidal lesion, most common, and it's almost always seen in Caucasian individuals, but Asians are not immune to develop it. Choroidal nevus does not have subretinal fluid. It presents like a placoid mass in the outer choroid compressing the choriocapillaries. You can see choriocapillaries nicely there, and in the area where the lesion is, choriocapillaries are compressed, and that is how it presents on OCT scan. Now, the most important aspect is to differentiate choroidal nevus from a melanoma. So when you have a pigmented choroidal lesion with orange color, that is lipofuscin and subretinal fluid, then your diagnosis of melanoma becomes real. Choroidal nevus does not have subretinal fluid, does not have lipofuscin pigment, so that is how you differentiate. And of course, when you see a gross lesion like this with cholested kind of an appearance, this is break through the Brooks membrane, that is the base of the choroidal melanoma, then the diagnosis is very certain. But if you have situations like this, indeterminate choroidal lesions, or so-called where there is lesions where there is confusion, where the tumor size is hardly 2 millimeter, and this patient happens to be a gastroenterologist, he does not believe the diagnosis that you give that he has a small choroidal melanoma, he waits on for about 6 months and it really grows. So this is a choroidal melanoma. Every tumor has to begin small, and this is also begun small. And if you have any confusion at all, then you should go by this mnemonic to find small ocular melanoma using helpful hints daily. This is by the Shields, where T stands for thickness more than 2 millimeter on B scan. Fluid is SRF, subretinal fluid. Symptoms of loss of vision or metamorphopsia. Orange pigment, which is lipofuscin. Margin close to the optic disc less than 3 millimeter. hollowness on ultrasound, halo around the lesion, and absence of drusen. Drusen are typical of a nevus. Drusen are absent in a melanoma. So if you find any of these features, then you should have a high index of suspicion for choroidal melanoma. Then if you still have any doubt, then you can do OCT and then see these shaggy photoreceptors. And also if you do autofluorescence, you find that hyperautofluorescence of orange colored lipofuscin pigment. All these orange colored pigment become much larger in appearance on autofluorescence. And if you do FFA, you find there is double circulation both from the choroidal as well as the retinal vasculature. And when you do OCTA, you find that there is mild macular ischemia. It is the most common primary malignant intraocular tumor, and the treatment is guided by COMP study. COMP study was the first randomized clinical trial in any malignant tumor for that matter. So this is called collaborative ocular melanoma study, which classified melanoma into small, medium and large. And the study comprised of 3 arms. In the first arm, they gave pre-enucleation external beam radiation for large melanomas, and then they enucleated. They find that no advantage. So if you have a large melanoma, you simply go ahead with enucleation, and that is the treatment of choice. If you have a medium-sized melanoma, then whether you do enucleation or brachytherapy, it does not have any implication on life prognosis. Patient will have metastasis in a certain percentage of patients that cannot be avoided. So results are comparable. So if you have a medium-sized melanoma, then you want to save the eye and vision by doing brachytherapy. The third arm was small melanoma. They said observe, which is no longer the case. We don't observe them anymore because patients with small melanoma can still die. It is now known that patients who have 3 mm diameter melanoma, 1.5 mm in thickness, can also start developing metastasis. So in small melanoma, we do transpupillary thermotherapy. We treat the entire lesion on its surface, and these lesions go away very nicely for small melanoma. For medium-sized melanoma, we do plaque brachytherapy. This is either by using 2 isotopes, either ruthenium or iodine. Ruthenium comes as a compact plaque. Iodine is used in the form of seeds which are affixed to the plaque. And either which way you can treat it, use it to treat any of the lesions located in any part of the fundus. This was a mid-peripheral lesion gone away following plaque brachytherapy. This is again very close to the optic disc, again gone with plaque brachytherapy. This is juxtapapillary lesion gone with plaque brachytherapy. But of course, you have left a bit of optic atrophy, which is unavoidable. For patients who have a high melanoma like this with a small base, you can do partial lamellar sclerouvectomy as well. But for larger tumors, enucleation is the treatment of choice. What is new about choroidal melanoma is the identification of class 1 and class 2 melanoma. Now it is classified as A, B, C, D as well, depending on the mutation. Chromosome 3 loss, 8q gain, 1p loss and 6q loss make it class 1 melanoma, which has a higher chance of developing systemic metastasis. So identification of the class of melanoma becomes important when you want to give systemic adjuvant therapy. So last bit is about these patients who have nevus of aorta with episcleral melanocytosis, etc., where you really have to look at their palate and hairline for pigmentation indicating esophageal melanosis and meningeal melanosis. And when you look at their fundus, you find asymmetry of pigmentation. These patients, apart from monitoring them for glaucoma, you should also monitor them for development of choroidal lesions of this sort and ciliary body or iris lesions of this sort, which could be melanomas. So they do have a tendency, higher chance of developing into melanoma. So in conclusion, I would say that we looked at a lot of masquerades of intraocular tumors, and what is important is to go by the color and try to recognize them. So how much time do I have? Rolika? Ho gaya time? Time is over? Okay. So we'll do retinoblastoma some other time then. Yeah, no problem.
Thank you so much, sir. Do we have time, Rolika, or we do after Kaustubh maybe?
We'll do some.
Yeah, all right, yeah.
No, it's okay, after Kaustubh.
So, well, so it's a pleasure and an honor to invite the next speaker, Dr. Kaustubh Mole. And he is a very renowned ocular oncology pathologist that India has. Happy to have you, Kaustubh. So more than introducing him as a pathologist, for inspiring you guys today morning, he's an Iron Man. You know what Iron Man is, right? Yeah, claps, please. So we have an Iron Man who's an ocular oncology pathologist who's going to take us through the pathology things. And Kaustubh has been inspiration for all of us. Like me getting into fitness was basically seeing Kaustubh. And he's excellent in his work. He'll make it really interesting for you. Over to you, Kaustubh.
Thank you, Feroz. Okay. Before we begin, pathology scares everyone. So let me tell you right at the onset, I am not going to get into pathology. We are only going to discuss pathology from an exam point of view. And second, see, if you have seen, all these stalwarts who came and delivered lectures or who are going to deliver lectures, they all know their pathology very well. And why does it need to be that way? One, you need to interpret the report that the pathologist gives you and then decide the management. And second, if a pathologist goes wrong, you need to go back to him and tell him that, him or her, that, this is what I want. So can you please go and look at it? Believe me, 80% of the cases that I get, Dr. Santosh, Dr. Feroz, all these stalwarts, there's not a slightest chance that I don't expect a call from them. Every case, Kaustubh, what is this? Kaustubh, why is this not there? Why is this there? So you have to communicate with your pathologist, and to do that, you need to know your pathology well.
And we don't exist without a pathologist.
Absolutely. I didn't want to say that. Okay. But before going into pathology, can all of you look at this picture and tell me which of these three lines is longer than the other two? The middle one?
No,
No?
it's the same.
Who says they are same?
The arrow is changed. So
I don't see hands coming up.
The middle one looks longer because the arrow direction is changed.
Okay. Does anyone want to contradict that statement? Okay, take a look at this. They're all of the same length. So this is an optical illusion.
Right.
It's called a Muller-Lyer illusion picture. Now, you know that these lines measure the same. In fact, they are of the same length. But if you go back at the picture again, you will still see the middle line as being longer, in spite of you knowing it. So, our thinking processes have two systems, the fast one and the slow one. The fast one is an intuitive thinking or an impulsive thinking. And the slower one is a more rational one. So when you interpret pathology or you're going to interpret the next slides that I'm showing, please don't be impulsive, use your system too. Okay. Now, tell me, what is this? What are these structures that you see? Anyone? Yes? Okay. Someone said it, please be loud. Acanthamoeba, very nice. So the picture on the right, what do you think is the technique used over here to make a diagnosis? You see something glowing, right? Yes, who said that? Calcofluoride, very nice, and it's immunofluorescence. Now, if you want to demonstrate acanthamoeba, are there any two more stains that you can use? Very good, periodic acid skiff. And one more. GMS, Gomorrhe's methenamine silver. So these are two more stains.
This bunch is really intelligent.
Yes, it is, definitely.
Yeah. Very nice.
Okay, so this was the picture with which this man presented. Now, if I would have shown this, you would have made a diagnosis. So if you look at these cysts, like I said, there's a lot of inflammation, and there are acanthamoeba sitting over there. Now, let's look at this picture. What stain do you think this is? Let's say, this is a corneal tissue, and he presented with some burning, some redness, some watering. What stain do you think this is? Sorry? Zn stain? No, it is not. Yes, Gram stain. So in a Gram stain, if you see blue organisms, what is it? Positive or negative? Yes. And if you see red ones, they are negative. Let's just say there's a corneal tissue, and your pathologist sees this. What do you think this is? You see there are these, Yes, hyphae. So these are fungi. So what is the picture on your left? What stain is it? Green color background with black organisms. Gomur is methenamine silver. And the pink one on the bottom right, it's PAS, periodic acid skiff. Okay. Now, this was the clinical picture. This is what you said was Zn stain. And you see those long organisms, they are acid-fast bacilli. Now, acid-fast stain or Zn stain can be used to demonstrate 2-3 organisms. One is tubercle bacilli. There are 2 more organisms. And? No. Yes. Someone said it just now. Yes, 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 yes. Just be a little loud. Very good. Mycobacterium leprae. Okay, now this was another man who presented with corneal infiltrates. However, if you look at the bottom right, you know, what is this? What is this line? The pink line that you see. Decimates membrane. So if you see, the infiltrate is in the posterior half. So which are those 2 conditions where you see infiltrates in the posterior cornea? 2 conditions, very typical. Viral keratitis.
Viral endothelitis.
And?
Viral endothelitis.
Okay, now a Zn stain was done on this specimen, and this is what you saw. Positive organisms. No, they are not nocardia. This is a higher mag. They are microsporidia. Okay, so another condition which has got posterior infiltrates. Oh, no. I'm not going to ask you which movie this picture is from. No. Okay, now the reason why I've put in this picture is, you know, these days, especially post-COVID era, everyone wants to get fit. You know, everyone wants to have a six-pack or you want to have a slim waist. So we all hit the gym. Now, a recent survey conducted in urban population of India showed that weight loss was among the top 2 goals in 61% of the people. How many of you people go to the gym? Okay? Yeah, I know Feroz. Feroz is like ultra fit. Okay, so we go to the gym. You know, we want to get, you know, especially the crowd that goes to the gym, you know, it's maximum on New Year's. Everyone wants goals, or it's birthdays or anniversaries. Around these dates, everyone wants to hit the gym. But when we go to the gym, when we start our fitness journey, there are some myths, you can say, you know, we tag along with, and we forget, you know, the science behind it. So in the slides later on, I'm going to talk about 3 myths and what is the reality behind them. So, not now. Let's get back to pathology, else Rolika will say, please focus on pathology. Okay. What specimen is this? Enucleated eyeball. So now my question to you is, in an enucleation, which part of the eyeball is sampled first? Very good. Optic nerve. And we take a transverse section. The resected end of the optic nerve has to be sampled before anything else. Okay. Now, after we sample the optic nerve, we need to cut the eyeball. Now, to cut the eyeball, there are multiple ways to cut it. You can either go oblique, you can go horizontal, you can go vertical. But every section has to be a pupillo-optic section. So how do we decide which plane of the eyeball do we cut? Is there any way that a pathologist can know that, you know, let's just say a tumor is more peripheral or it's more anterior. How does a pathologist know that, you know, I'm supposed to take an oblique section or a horizontal section? We do a test, which I just showed you a picture. Transillumination test. Yes, so we do a transillumination test. Now, if you see the bottom right, at the top half, you see a dark shadow. That's where we know the tumor is. So in this case, I'm going to take a transverse section. Okay, now I cut the eyeball. This is what I saw. What do you think it is? Tumor, not tumor?
Tumor. Age of the
okay,
patient?
See, retinoblastoma, wonderful. That was a diagnosis, yes. Okay, it's a retinoblastoma. So that's what Dr. Santosh is going to talk about later. Now, retinoblastoma is a tumor of the retina. I don't need to get into that. It's a blue tumor. And this is what it is typically characterized by. What are these? Rosettes. You see those all flower-like things? They are rosettes. Now, which are the two types of rosettes that you see in retinoblastoma? Flexa intestina and homerite. Very good. You know your pathology. Very good. Okay, now let's just say, pathologist. Let me. I have made a diagnosis. You send me an eyeball. I tell you this is a retinoblastoma. What will you do next? Okay, you would want to know the optic nerve involvement. Very good. If I am a pathologist and I tell you it's a retinoblastoma and give this report to sir, he will throw me out. He'll say, I already know that. You don't need to tell me that. So, what is important in a report of retinoblastoma is to know something called as high-risk factors. So, what are the high-risk factors? 1, 2, 3, 4, 5, 6. Nolika? Tell me. Anterior chamber involvement. Yes. Okay. Optic nerve involvement. Okay. So, you look at choroidal invasion, whether it's massive or focal. Anything more than 3 millimeter in any dimension, whether it's the width, whether it's the length or whatever, anything more than 3 millimeters, or if the choroidal invasion is in its full thickness, either of these two conditions, then we call it massive choroidal invasion. Then you need to look at the retrolaminar optic nerve spread. That means the tumor has to go beyond the lamina cribrosa into the retrolaminar optic nerve. Only then it is going to be a high-risk factor. The third thing you want to know is whether the tumor has gone beyond the eyeball into the periocular soft tissue. That's extraocular spread. Then involvement of the anterior chamber. And the last one is scleral involvement. Let's look at this picture. What do you see? You see something around the ciliary body, right? Okay. Now, when I cut the eyeball, this is what I saw. There was this white fleshy tumor sitting near the ciliary body. Now, when I looked at under the microscope, the tumor was involving the ciliary body, the iris, the anterior chamber, the angle, and also clinging onto the posterior corneal surface. So that's involvement of the anterior chamber. It's a high-risk factor. Let's look at this picture. What do you see? This is a cut section of the eyeball. If you see there's a tumor posteriorly, and it is involving the choroid. And that's full thickness choroidal invasion. Again, a high-risk factor. What do you see here? Look at the imaging first. It'll be easier. Compare the two eyes. Thickened optic nerve, right? So optic nerve invasion, yes. Now, if you look at this picture, you see an optic nerve, and there's a tumor in the vitreous space. Now, the optic nerve is clear. If you look at this picture, you see the tumor going through the head, through the lamina cribrosa, into the retrolaminar optic nerve, so that becomes your high-risk factor. Now, if you remember the first picture that I showed you of the eyeball, the resected of optic nerve being cut, it's a transverse section. So you see blue over here in that transverse thing. So it's parenchymal involvement of the optic nerve. Now, the picture on the bottom right, the parenchyma is not involved, but the meninges around it are involved. So that's again a high-risk factor. This is intrascleral tumor spread, and this is tumor present on either sides of the sclera. So the tumor has gone into the extraocular space. Okay, what do you think this is? No, this is not retinoblastoma. Okay, you want a hint? Think about Tom and Jerry. Yes. Swiss cheese. So which tumor has Swiss cheese appearance? Adenoid cystic carcinoma, isn't it? Yeah. So what is adenoid cystic carcinoma famous for? In the wrong way. Yes? Perineural tumor spread, very good. Can you see the nerve in between, and there's a tumor going around it? So it's classical characteristic of adenoid cystic carcinoma, perineural tumor spread. Okay, now all of us have smartwatches. I know someone over here who does and who flaunts it. Okay. So we all have smartwatches. There was this guy who came to me a few days ago and he said, Kaustubh, what? I walk 10,000 steps every day. Okay, but I'm not shedding any weight. What do I do? A lot of us do this, you know, even I have done this, 10,000 steps. So what do you think? Is this a myth or is it a fact? Does 10,000 steps help you lose weight or it doesn't? Or do you have to walk less? Do you have to walk more?
Walk more.
Okay, now 10,000 steps or 10,000 count is just a number. For some people it can be 5,000, for some people it can be 15,000. But just merely walking 10,000 steps is not going to help you. You need to regulate your diet. You can't walk 10,000 steps and go to McDonald's. You can't do that. So just remember, a good workout will never undo a bad diet. Okay, let's look back to pathology. Let's look at this picture. What do you think the specimen is? You see a, okay, conjunctiva, very good. Anything else that it could be? Why? Because it has epithelium. Which other tissue has epithelium? Cornea, right. Why can't it be cornea? Okay, what if I tell you it's a dark specimen? Can it be possible? 2 layers. You see the stroma and you see the epithelium. Okay. To know what the tissue is, let's look at the bottom right picture. It's the same tissue, okay? It's not a different tissue. It's just a different stain. So what staining is this? Yes, Mason's trichrome. So why do you do a Mason's trichrome? Anything else? Cornea, Mason's trichrome. Corneal dystrophy. Which corneal dystrophy? Granular corneal dystrophy. Wonderful. So this was a case of granular corneal dystrophy, right? And this is what the clinical picture looked like. Okay. Now, in the same specimen, if you see this picture, what would you see? If you look at the top right, or the top right, what do you see in the stroma? It's a little bluish. It's hazy. There's no particular deposit as such, but it's just overall hazy, right? Now, the bottom left is a stain. It's a special stain, which is giving a blue color to those deposits. Yes, Alcian blue stain. And if you see Alcian blue positive deposits, it is macular corneal dystrophy. Very good. What if you see this? Sir just showed this picture a while ago. Yes, amyloid, because, and what appearance is this called? Apple green birefringence. Do you see it under a regular microscope or do you see it under polarized? Very good. Okay, now let's jump on to the next category. Now there are 3 pictures over here. They are pictures of specimens that were sent to me. Now the one on the bottom, on the top right, what do you see over here? Okay, before we get on to the details of the specimen, let me just ask you one thing. If you need to send a specimen to a lab or to a pathologist, what is the kind of preservative that we will use? Are you going to send it in saline? Are you going to send it in water? Or what are you going to use? What kind of formalin? Yes. 10%? 50%? Auction. Highest bidder. It's 10% neutral buffered formalin. Okay, neutral, you need to check the pH. It has to be 7. It has to be a 10% formalin. The commercially available formalin is 40%. So you need to dilute it. Okay, so you make a diagram. The diagram is made on what? Is it a regular paper? No, it's not nitrocellulose. Nitrocellulose is what you use for impression cytology. For this, you use a Whatman filter paper type number 1. Right? So you make a nice diagram, you put the specimen on it, you allow the specimen to dry. Once the specimen dries off, then you put it in a polythene bag that is containing formalin, and then you transport it to the lab after labeling the specimen.
Kaustubh, can I just interrupt you?
Yes, yes, please do.
The type, how important is the type of the water?
It is very important because if the formalin concentration changes or the time in the formalin changes, then the other filter papers are likely to get fragmented and crumbled.
Okay, okay. So it's type 1 Whatman filter paper.
Yes. Okay. So if you send a specimen like this, what is the condition that you'll probably send specimens like this for? Basically lesions of the ocular surface, right? So it can be a nevus, it can be a OSSN, it can be anything. Now, if you send a specimen like this, this specimen, then the pathologist will have his job easier to sample the margins because they need to sample the margins since you need to know whether the margins are involved or not. The other way to do is you send the lesion separately, you sample out the margins separately, and then you send them like this was done over here, right? So you send them again on a filter paper. Now, take a look at this slide. What is the kind of specimen do you think I have shown? Very good, it's an exentration specimen. Now, if you see over here, there's a lesion, right? What do you think it is? Neoplastic, non-neoplastic? Neoplastic. Benign, malignant? Right. So it is, if you notice, it's arising in the limbus, and it is going all the way into the orbital soft tissue. So it's probably a squamous cell carcinoma that with orbital involvement. Take a look at this picture. What do you see? See this? What is this region in the eyeball? Okay, what is this? Cornea, very good. So what region will this be? Ciliary body. So there's something in the ciliary body. Let's look at this picture. Can you see the ciliary processes? So you see there's an ocular surface neoplasm that's going into the ciliary body. So in a specimen of exentration, when your pathologist reports it, it is very important to ask him whether there's an intraocular spread or no, because that's going to decide what you want to do next. Okay, so coming back, in a patient with OSSN, what do you look for in a pathology report? In a OSSN, you have two types of samples. You have an excision biopsy, you have an exentration. So the things that you need to look for are also going to be different. In an excision biopsy, you want to look for one, of course, if there's neoplasia or no. If there's neoplasia, whether it's intraepithelial or it's invasive. Now, if it is invasive, you need to know whether the tumor has gone to the base. And irrespective of whether it's intraepithelial or invasive, you need to ask your pathologist whether the margins are involved. If the margins are involved, you'll probably need to go back and excise it. In a patient with exentration, in addition, you'll also need to look for skin margins, soft tissue margins, optic nerve involvement, and like I said, intraocular tumor spread. Okay, now this was a case which Feroz had sent me. You remember this?
Yes.
Okay. So this was a young man with these nodules on the ocular surface. Spotter. Okay, let's look at the next picture. Second year microbiology. Okay, what do you see the structures over here? These round structures, and they contain some dots inside. Basically, the round structures that you see over here, they are sporangia. And the ones that you see inside them are sporangiospores. So now that I'm telling you this, what do you think is the diagnosis? Rhinosporidium. And what's the etiologic agent? Rhinosporidium? Seaberry. Very good. Okay, now this was a mass in, let's just say, a 30, 40-year-old male. Two differential diagnoses. What do you see here? Is it solid or cystic? Huh? It's cystic. It's cystic, right? There's a cyst over there.
Lining, you can see the lining.
There's a lining over there, right? See this wall. And there's a cyst. So something with a cyst exists in this region. Sorry?
Cyst.
Yes. Very good. Dermoid cyst. Commonest. If it is not dermoid, what could it be? Epidermoid. So what's the difference between dermoid and epidermoid? Dermoid has skin adnexa in it. Epidermoid will not have skin adnexa in it. Spotter. Again, second year microbiology. Close. Close. Yes, hydrated cyst. Can you see this? What are these called? Scolices, colex. And what is the organism? Echinococcus, what? Granulosus. Very good. Okay, coming to the next myth. Again, I know someone out here who does this. Weight loss is cardio. You know, that's a myth that is followed by everyone. Everyone goes to the gym, you know, takes a look in the mirror and hits the treadmill. Right? If not, HIIT. Everyone wants to do HIIT. So is this correct or is it wrong?
Kaustubh, it is cardio is important.
Oh, okay, someone is offended over here. No?
It's important.
Yes, it is important. Cardio should be a part of your regime when you do getting into a fitness regime, but strength and conditioning is also important. You cannot just do cardio. Please go and lift your dumbbells.
So listen, how many days in a week do you do cardio?
Oh, no.
No, I'm just asking.
Two.
See, 2 days and then weights,
Yes.
3 days?
Yes,
3
3
days
days,
weights.
yeah.
Okay, got the secret.
Okay, spotter. Okay, let me tell you, this is a tumor. And we're not going to talk about fact or myth now. We're going to get into proper diagnosis. It's a tumor.
Red color.
Red color, yes. Sorry? Rhabdo, no.
Many O's.
Many O's. Lipo, very good. You are very close. Who said that, lipo? Why do you say lipo? Sorry? Yes, oil red O, very good. That's a special stain that you use to demonstrate fat. Very nice. So which are the fat-containing tumors? Liposarcoma is one, lipoma is two. Something that is more common. How often do you see a liposarcoma in the eye? Lipohemangioma? No. Sebaceous carcinoma. Isn't it made of sebum, fat? Right? So, that's how you demonstrate it. This is how the patient presented. Now, coming back to where I asked Feroz to leave. You know, if this patient had this, what are you going to think of? Yes, Muir-Torre syndrome. What is Muir-Torre syndrome? Yes, it is an association of sebaceous carcinoma with a visceral malignancy, the commonest one being HNPCC. But what is Muir-Torre syndrome actually? What is the abnormality? Normally, when our cells multiply, there are breaks that happen in the DNA, right? And then those cells are discarded. But if that repair is not taken care of, then it becomes carcinogenic. So it's a defect in the mismatch repair genes. Okay, let's not get into the details. Now, this was a 45-year-old female who had these dilated episcleral vessels, some high reflectivity mass in the choroid. The eyeball, when cut open, had this kind of mass. What do you think it is? Give me a differential diagnosis. Very good, melanoma. Is a melanoma white? Amelanotic melanoma. Very good. This was neither of the two. No. Okay, take a closer look. What is the region? Ciliary body, which is a tumor that's more common in the ciliary body. Okay, before that.
Yeah, maybe 2 of them you can ask them.
Sorry?
2 ciliary body tumors.
2 ciliary body tumors. Okay. Name 2 ciliary body tumors. Okay,
Like,
what is ciliary body made up of? Let's get there.
Right. Yes, correct.
Pigmented and non-pigmented epithelium. Okay, so there is a tumor that can arise from the epithelium. What else does ciliary body have?
Muscles, they said.
What does it, what helps it to? I'm giving a hint. Muscles.
Yeah, they said muscles.
There are muscles in it,
Huh.
right?
They said muscles.
They said muscles.
They
Okay,
said
sorry.
muscles, yeah.
So a tumor that arises from the, okay, what kind of muscle does exist in? Is it striated or is it non-striated? Smooth muscle, basically. So what is a tumor of a smooth muscle?
Myoma
Leiomyoma.
Leiomyoma.
Uterus,
right. So,
fibroid. Don't you
myoma,
get
right.
that? So leiomyoma, ciliary body leiomyoma. That's the commonest tumor. So this was a leiomyoma. Now, if that tumor was this color, what do you call it? Melanoma. And you see, Dr. Santosh showed you a while ago that, it goes through the Brooks membrane and it comes out into the cavity, mushrooming, right? So you see the typical mushrooming over here. Now, if the same tumor had this appearance, what would it be? Amelanotic melanoma. Okay? Okay, fine. Let's look at the next case. This was an orbital mass in, say, 60-year-old lady. Totally excised, sent it to me. I took a picture. This is what it looked like. Now you must be wondering, what is the lesion? Is it the yellow one or is it the gray one? Okay, yellow one. Sir just showed you a picture a while ago. Rolika? Yeah, xanthogranuloma, yellow in color. Okay. Now that you know the condition, the picture on the right or the left is what I see under the microscope. What do you think is seen here? Yes, these are Teuton giant cells. Now, in another histiocytosis, if you see this picture, okay, before that, let me come to the third question. What are the types of xanthogranuloma? Or adult onset xanthogranuloma? There are 4 varieties. Can anyone tell me the 4 names? That's not pathology, it's clinical. 1, 2, 3, 4.
Yeah,
One is AOXG. Second is AOXG with asthma. Third, necrobiotic xanthogranuloma. And fourth, ECD. What is ECD? Erdheim-Chester disease. Right? So in a Erdheim-Chester disease, if you see something like this, the arrows which point out here, what are these bodies? Yes, Burbeck's granules, very typically tennis racket shaped bodies. And what is the procedure that we use to identify them? Electron microscopy. Okay, we are coming to the last 2, 3 now. Push. Okay, this was a mass that was excised in a, say, 40-year-old gentleman. Lipoderma, okay, because it is yellowish. No. Okay, wait. What do you think is this? This is a nerve. So there's a tumor around a nerve. Okay.
That is optic
Schwannoma.
nerve.
Yes, very
Who
good.
said it's optic nerve here? On the tip of the lesion.
This is not
Optic-
the eyeball, this is a
Right.
mass.
Mass, right?
Okay.
Yeah.
Okay, so one is schwannoma. Any other differential? Meningioma, very good. So it can be either of these two. Now in this mass, if I see this under the microscope, yes, it is a schwannoma. Now what does the black arrow point out to and what does the red arrow point out to? Sorry? Yes. Palisading, what are those called? No, the palisading of nuclei, what is it called? Yes, Verroque bodies. And what are the 2 areas that you see now? Antony A and Antony B. Very good.
So they are like 10 out of 10 in ocular oncology pathology. They're
Yes,
so good.
absolutely.
Right.
Okay, the last myth. How many of you have seen, gone to the gym and noticed, everyone has a bottle and drinking a protein shake? And I see a lot of it, people come to the gym, even before they warm up, they are like shaking and, one sip down. Proteins. Okay, this is again a myth. Do you need proteins? Yes, you do. Do you need only proteins? No. Okay, now the second myth in this, say no to carbs and fat. I want sugar-free. I want everything fat-free. Fat-free cheese chalega, but it has to be fat-free. No. Again, fat and carbohydrates are very important. It's just that you should avoid trans fats and refined carbohydrates. Okay, 2 more. This was an African patient who had this intraocular mass. Come on, quickly, differential diagnosis. Intraocular mass in a middle-aged man. Can you see the cysts out here? Okay, sorry. What is the commonest intraocular tumor in an adult? Okay. Sir just told you a while ago. Hemangioma. And what is the commonest malignant tumor in an adult? Metastasis. It's not melanoma. So this was a case of renal cell carcinoma that had gone into the eye. Okay. Spotter. I'm not going to tell you anything. No. Mritika is not going to comment on it. Yes. Color again. Sir was just talking about colors. Green color. One more hint. Changed color. One more hint. Which means that the mass, when taken out of the body, changes its color. Metastasis? Okay, maybe. What metastasis? Metastasis of what? Okay, young boy. Again, one more hint.
Young boy. Ptosis.
Ptosis. Fever.
Anemia.
Okay, now I think I should give that a
Anemia.
diagnosis.
Pancytopenia.
Okay. AML, not ALL, AML, chloroma. And why does it change color? The name says it, chloroma. It contains a pigment similar to chlorophyll, chloroma, which is green in color, right? It contains myeloperoxidase pigment, myeloperoxidase enzyme, which causes the change in color to green. So this was a case of AML. You see these blasts out there? It's in the peripheral blood. Now, if in these cells you see something like this, the arrow pointing out, what are these? OR rods. Very good. So it's a AML. Okay. One more. Spotter. Two differential diagnoses. Optic nerve sheath tumor. Which tumor? Meningioma. It can be a glioma. Yes, very good. Okay, now this was an adult male who presented with proptosis, and this was a mass that was excised. What is it? What does it look like?
Spongy.
What does it appear like?
Spongy.
Honeycomb appearance.
Yeah.
Which tumor has it? Hemangioma, cavernous hemangioma to be more specific. And that's what the radiological picture. Okay, thank you. That's it.
Thank you so very much, Kaustup. So he has kept it so interesting, and I'm so impressed about you guys, answering all the
absolutely.
questions.
You guys were wonderful.
Right. And one more thing, Kaustup is a physical fitness trainer. He trains most of the Collywood stars. It's a high-level thing, okay? All right. It's a secret. I've put out the secret over here. And it's going live also, Kaustup. You're going to get clients.
Thank you, Feroz.
So, yes. So, we're going to have Dr. Santosh Honavar back on the podium with his favorite topic. And he is the person who has brought about so much of, contribution in the field of retinoblastoma to begin with. And we all follow his path. And he has done amazing work in retinoblastoma. And we cannot have him go without talking about retinoblastoma. Over to you, sir.
Thank you so much. We have about 15 minutes and I can cover some of the important aspects of retinoblastoma. So these are the things that you must know about retinoblastoma, that it is the most common primary intraocular malignancy in children. It's a deadly tumor with up to 50% mortality if it is not detected early enough and treated appropriately. And parents actually go to ophthalmologists first with this, as one of the symptoms being being leukocoria or strabismus, and it is completely curable if it is detected early. Now, evolution in the management of retinoblastoma, this slide sums it up all. In just about 120 years ago, in 1900s, we began with 98% mortality. In 2020, we have more than 98% survival. That kind of a dramatic turnaround has not happened in any other malignancy except retinoblastoma, because it's something that can easily be diagnosed and easily be treated. If you look at the world retinoblastoma map, India is in the dark green, indicating that it has one of the highest incidence of retinoblastoma, mainly because we have a high live birth rate, and for every 10 to 15,000 live births, we have one new case of retinoblastoma. So estimated incidence in India There's about 1,500 to 2,000 cases a year, of which what come to tertiary care centers and retinoblastoma referral centers range from 600 to 800, which means that about half of these children are treated at the level of primary care or medical colleges, where enucleation may be the only option. And even when you do enucleation, you have to do it well and also take histopathological risk factors into consideration so that we can optimize survival. Clinical manifestations, leukocoria happens to be the most common primary presenting symptom as well as sign. Parents come with a child with leukocoria, and when you look at the child, you also find leukocoria. That's about 40 to 50%. 40 to 50% leukocoria, which could be either unilateral or bilateral, whereas squint happens in about 20% of children. They come with either esotropia or exotropia depending on the location of the tumor and age of onset. Esotropia is more common than exotropia, but in all about 20 to 25% of children will have squint. These are rare. Redness would mean that there is either inflammation because of a necrotic tumor or there is extraocular extension, proptosis indicating extraocular extension, and also patients who have sterile inflammation can also develop proptosis. The diagnosis is very, very simple. In fact, the most important tool to diagnose would be examination under anesthesia and a good indirect ophthalmoscopy. That's it. So you don't need any specialized techniques to diagnose retinoblastoma, whereas if you have any doubt at all about intra-lesional calcification, then you can do ultrasound B scan that will help you diagnose it and also measure the height of the lesion. MRI is reserved for patients where there is bilateral or multifocal tumors to screen for pineloblastoma and also rule out optic nerve extension and also extraocular extension. Now, what are the simulating conditions to retinoblastoma, pseudoretinoblastomas? These are the top 5: Coats disease, PHPV, toxocariasis, astrocytic hamartoma, and medulloepithelioma. In Coats disease, the quality of the reflex is totally different. In retinoblastoma, it is leukocoria. That means it is pale yellow white. Whereas in Coats disease, it is xanthocoria. It's golden yellow. Golden yellow is almost close to orange, that kind of a reflex. So when you look at the child with even torchlight or distant direct ophthalmoscopy, the kind of reflex that you get is totally different in retinoblastoma as opposed to Coats. That is one of the pointers to diagnose. The second is that you find a lot of busy retina, a lot of blood vessels in the retina, whereas in retinoblastoma it is well spaced out blood vessels. So if you find a lot of blood vessels, even on a cursory evaluation, that means you are possibly looking at a case of Coats disease. And if you look at it more carefully, you will find peripheral retinal telangiectasia and intra and subretinal diffuse yellow exudation. That's very typical of Coats disease. Very easy to diagnose. About persistent hyperplastic primary vitreous, you find that it is present at birth. There is relative microphthalmus. That means that it may not go to 9 millimeter corneal diameter, but even a difference of 0.5 millimeter or 1 millimeter between the right eye and the left eye. That's called relative microphthalmus, or axial length maybe 1.5 millimeter less than the other eye is considered relative microphthalmus. That is present in the ipsilateral eye. The second thing that you observe when you do slit lamp evaluation or on UA would be that there are dragged ciliary processes, prominent ciliary processes coming on to the lens like that, and the lens itself will have a posterior polar opacity or a posterior subcapsular opacity from which there will be a stalk. That's a fibrovascular stalk which goes to the optic disc. So if this is the lens, that's the fibrovascular stalk that is going to the optic disc. That is to complete the picture of persistent hyperplastic primary vitreous. So it's very classical the way it manifests, and there's no reason why you should diagnose this as retinoblastoma. Toxocariasis can be confusing. There are two variants of toxocariasis. One is peripheral toxocariasis, which comes with this special falciform fold, which is a fibrovascular front, which is going towards the center. And the central toxocariasis presents with a posterior polar lesion with a lot of desmoplastic activity. You can see that the blood vessels are dragged towards it, and it also drags the disc towards it. So it's called the dragged disc appearance. So if you have a posterior polar granuloma with dragged disc appearance, then you're looking at a patient with toxocariasis. Already touched upon retinal astrocytic hamartoma, the two variants, one acalcific variant, one calcific variant, both can look like retinoblastoma. Most important differential diagnosis would be medulloepithelioma. Now, medulloepithelioma is an embryonal tumor. That means that it is present during the developmental phase of the child. So, zonules in that area don't develop at all. That's called zonular coloboma or lens coloboma. Zonular coloboma is the correct word. Lens coloboma is not the correct word because there is no loss in the parenchyma of the lens. It is the zonules that are lost. So, the lens appears pseudocolobomatous because there is no traction of the zonules towards the periphery, and that is the tumor, and that is the zonular coloboma. Now, going on to classification of retinoblastoma, there are two ways of classifying. One is called grouping, the second is called staging. Grouping always prognosticates eye salvage. Staging always prognosticates life salvage. So this is international grouping of intraocular retinoblastoma, kindergarten or ABCDE classification, where group A means small tumor which is less than 3 mm in diameter. Group B means slightly larger tumor, more than 3 mm in diameter, macular in location, or less than 3 mm from the fovea, or less than 1.5 mm from the optic disc. That is group B. B for slightly bigger tumors. C is for confined tumors, confined subretinal seeds or confined or focal vitreous seeds. Subretinal seeds or focal subretinal seeds develop in exophytic retinoblastoma. Focal vitreous seeds develop in endophytic retinoblastoma. Either which way, it belongs to group C. D is for diffuse. Diffuse subretinal seeds in exophytic retinoblastoma. Diffuse vitreous seeds in endophytic retinoblastoma make it group D. E are potentially enucleable eyes where there is more than 50% of the intravitreal volume occupied by the tumor, neovascular glaucoma, blood in the anterior chamber or vitreous, or invasion of any of the structures of the eye make it group E. This is A to E classification. Now, international staging of intraocular retinoblastoma is to prognosticate life. Now, what is important to remember is that up to stage 3, we have 95% survival. Once it crosses stage 3, survival is less than 5%. So this is the watershed zone. Stage 3 and stage 4, between this is the watershed zone. Stage 0 is when you have not done enucleation. That means either by chemotherapy or laser or whatever conservative measures that you have, tumor has been completely controlled. That is stage 0, which means there is hardly any risk for life. These patients survive nearly 100%. Stage 1 is when you have done enucleation and the tumor has been completely resected and pathologist tells you that the tumor has been completely resected. That is stage 1, again 100% survival. Stage 2 is when you have done enucleation and the pathologist tells you that there is microscopic residual tumor. That means optic nerve transection is involved or sclera is full thickness involved. There is tumor cells outside the confines of the sclera or in the vertex veins. That is enucleation with microscopic residual tumor that has about 2 to 5% mortality if it is treated with adjuvant therapy. Stage 3 is regional extension or optic nerve extension to the transection, orbital disease and regional lymph node extension. A and B, orbital or regional lymph node extension. Even here, if you do multimodal treatment, you have 90 to 95% survival. Stage 4 is metastatic disease, hematogenous or CNS extension. Now, this is new about retinoblastoma. You're often asked about classification of retinoblastoma as a theory question. Earlier, we would simply write grouping and staging. Now, we are expected to write even TNM classification because TNM has come out with AJCC 8, which is the latest. This is a very busy slide. You don't have to kind of write everything about TNM in your answer paper, but you should definitely mention that there is a new alphabet that has been added to tumor node metastasis, that is H. H is for heritability, bringing genetics into the forefront in the screening, diagnosis, and prognostication of retinoblastoma. So H is the alphabet that's been added to TNM, and you should be aware that TNM AGCC 8 is the latest classification of retinoblastoma that includes both staging and grouping. Going on to management, goals of managing retinoblastoma are life salvage, eye salvage, and vision salvage. In that order, you never reverse the order. And the management modalities are quite a few, and you tailor it according to the need of the child. Suppose you have a small tumor which is only about 3 to 4 mm in diameter and 3 to 4 mm in thickness. We know that life is not at risk. We can save the eye. Then you don't blast the eye with inappropriate treatment to lose vision. Your priority now would be to save as much vision as possible now that you're sure that you can save the eye and life. So how do you do that? You do that by using focal therapy. Focal therapy is when you destroy the tumor by applying measures focally, not to the entire eye, but just to the tumor. One of the favorites is cryotherapy. Cryotherapy is done by what is called triple freeze-thaw cryotherapy, where the tumor is frozen thrice and is allowed to spontaneously thaw thrice. And you do that by using a 3 millimeter cryoprobe. This is the tip of the cryoprobe, and this is a tumor which is elevated onto the tip of the cryoprobe. When you press that, that causes anemization or reduction in blood supply to the tumor for the moment that you have pressed it. So what does it do? It hastens the process of cryotherapy because you have cut off its blood supply temporarily by elevating it and centering on the tip of the cryoprobe. So when you freeze it, this is the end point of freezing, that is the tumor being completely become white, and that's a cuff of vitreous that is anterior to the tumor that is also frozen. So that's a very heavy cryotherapy that you do. So consequently, tumor goes away, it has about 90% success, but the scar that is produced is always going to be larger than the tumor that you began with. Cryo has an overrun phenomena where rest of the retina around the tumor is also frozen. This is the tumor that we began with, it's gone, but the larger scar that is produced is sometimes a concern, especially if you have a tumor which is close to the equator. It can cause epiretinal membrane formation, it can cause atrophic retinal holes or rhegmatogenous retinal detachment. These are the problems with cryotherapy. So cryo is still used, but very, very selectively. Photocoagulation is something that is very powerful, where we cut off blood supply to the tumor. How do you cut off blood supply? If this is the tumor, we surround it with 2 rows of large diameter laser burns. So this is how a small tumor lasered would look. This is the tumor, and once it is lasered, the scar size becomes much larger, and you can see blood vessels that pass through the area of laser would also be coagulated. In addition to vascular occlusion, it can also produce visual field defects, and that happens because if this is a tumor and if this is a juxtapapillary tumor which are photocoagulated, the child will lose the entire inferior visual field, right? So photocoagulation is good in terms of tumor regression, but it is not good for vision salvage, and hence the current treatment of choice, if somebody asks you what is the current treatment of choice, focal therapy, then that is transpupillary thermotherapy. It uses semiconductor diode laser. The aim of TTT is not to photocoagulate, but to use laser to induce intratumoral apoptosis. By heating the tumor to about 45 to 60 degrees centigrade, it is done right on top of the tumor. So scar is never going to be larger than the tumor. Even if you do very close to the fovea, you can see the scar is crisp and the blood vessels that pass through the area are quite patent. So it is the least visually disfiguring form of treatment for any tumor, and since it is delivered using indirect ophthalmoscope, you can reach anywhere that your eye can reach. So location of the tumor in the retina is not a barrier to using TTT. About chemotherapy, in 1996 we began with standard dose chemotherapy. That was the treatment of choice at that time. And now we have all other forms of chemotherapy. The routes of giving chemotherapy have changed. We have become so localized that we can deliver it in the anterior chamber, we can deliver it in the posterior chamber, we can deliver it in the vitreous cavity, we can deliver bicamerally. So a lot of variations have happened in the way chemotherapy is given. It's of reducing the size of the tumor by doing chemotherapy, giving 3 drugs. Standard drugs are carboplatin, etoposide and vincristine. So drugs of choice for intravenous chemotherapy is a combination of carboplatin, etoposide and vincristine given every 3 to 4 weekly for 6 cycles. That is the standard of care for intravenous chemotherapy. Now how does it help? It helps by 3 ways. One is that it reduces the tumor size itself. So if this is the tumor, there's one more small tumor here. Finally, when it resolves, you see that the scar is much smaller than the tumor that you began. So what happens as a consequence is that the macula fovea is exposed very early in the course of treatment, thus maximizing vision. Ultimately, if you were to have a scar as large as this, then that would impinge on the macula fovea, thus this child may not have good vision. So scar being smaller is a major advantage with intravenous chemotherapy. Second is the principle that the tumor always hangs on to its source of blood supply. Most of the blood supply for posterior polar tumors would be from the arcade. Supranasal, supratemporal, infranasal, infratemporal are the source of blood supply. So now if you give chemotherapy to this child, you can see that it is abutting the fovea. So the moment we start chemotherapy, tumor has become smaller and it has actually moved towards the source of blood supply, which is the supratemporal arcade. After 3 cycles, you can find that the tumor is nearly flat, and the bonus is that the macula fovea is exposed. So that's maximizing vision. So the second way it maximizes vision is by regressing towards its source of blood supply away from the macula fovea. The third is that it regresses subretinal fluid very early in the course of treatment, thus maximizing vision. One more patient where macula was actually affected, you can see initially. Now you can see healthy fovea at the end of treatment, thus maximizing vision. So chemotherapy is very useful in maximizing vision by these mechanisms that I said. It is still the standard of care in India, although in the West it's been replaced by intraarterial chemotherapy, mainly because it is effective, and also it can be given in even ophthalmic hospitals with a little bit of help from pediatric oncologists. It is cost effective, costs maybe 5% of the cost of a premium IOL. So it's that cost effective, and it does not need high-end resources. But the trend has definitely shifted towards super selective ophthalmic artery intraarterial chemotherapy. It is also called chemosurgery. If you ask somebody in the West what is the standard of care, they will only say this: intraarterial chemotherapy is the standard of care for retinoblastoma in the West, whereas in India, although we have the technology available, we can't do it as often as we want to because of financial considerations. Here the issue is that somebody has to get you access to the ophthalmic artery, which has to be an interventional neuroradiologist. They do it as a cath lab procedure. Once they get you access to the ophthalmic artery, then you take over and inject 1 to 3 drugs. The drug of choice is melphalan. Melphalan is the standard drug that is used for intraarterial chemotherapy, although we use a combination of topotecan, melphalan and carboplatin, so that we use fewer number of cycles. The only advantage of using multiple drugs is that the number of cycles of intraarterial chemotherapy would be fewer, so it becomes more cost effective. Instead of giving 6, you may end up giving only 2 or 3 cycles of intraarterial chemotherapy. Advantage is that it gives rise to faster regression of subretinal fluid, more powerful regression of the tumor, more powerful regression of even recurrent tumors. So what happens in intraarterial chemotherapy is that the tumor starts regressing very early in the course of treatment, and it regresses and remains regressed, and it's very useful for group D and E tumors. A to C, there is hardly any difference in prognosis between intraarterial and intravenous, whereas D and D, there is a huge difference that it makes, at least 10 to 15% difference in eye salvage. Now, this is something that may be important from the point of view of exam. Tumor regression patterns are often asked in the exam, where type 0 is when tumor completely disappears, leaving no retinal scar, is type 0 regression. Type 1, when there is complete calcified mass appearing like cottage cheese. Type 2, when there is completely non-calcified mass, fish flesh appearance. Type 3 is when there is partially calcified mass. There is some bit of calcium, some bit of fish flesh appearance, or mixed type is type 3. Type 4 is a flat atrophic scar. So no scar to flat atrophic scar. In between that comes the cottage cheese, fish flesh, and a combination of both. So that's how you want to remember tumor regression patterns in retinoblastoma. Now about the vitreous seeds. There's a revolution in the management of vitreous seeds. Earlier we only knew vitreous seeds. Now we know them by different locations: prehyaloid, subhyaloid, epiretinal, intraretinal, subretinal, and intracameral. Intracameral is in the anterior chamber. There are 2 types. One which come through the zonules and get simply deposited in the anterior chamber. Second, come into the angle by contiguous infiltration of the ciliary body, anterior chamber angle, and peripheral iris. That's called infiltrative. So you have depository and infiltrative. And morphologically also, vitreous seeds can be classified as dust. Dust, as you see here, dust-like appearance of vitreous seeds. Cloud, just like you saw in patients with lymphoma. Spear, where as the name indicates, large balls of vitreous seeds. So all these are the morphological variants, whereas the mixed variant remains most common, a bit of this and bit of that. How do we treat vitreous seeds? The current treatment of choice is intravitreal chemotherapy. For this, you can't do it when the tumor is active. So we have to wait until your routine treatment for the main tumor is completed, which could be intraarterial or intravenous chemotherapy. Once the main tumor is nearly totally regressed, then you bring in intravitreal chemotherapy. The one sentence description is safety enhanced intravitreal chemotherapy, which is given through the pars plana and given through an ice ball so that the tumor cells, if they come out, are killed readily. There are other ways of enhancing safety, that's called death by water technique, or raising a bleb of subconjunctival topotecan in the area where you have injected. There are many ways of enhancing safety, but cryotherapy remains optimal. So the drug of choice again is melphalan. If somebody asks you what is the drug of choice for intravitreal chemotherapy, in the West it is melphalan. We started using melphalan with good effects, but as we went by, we noticed a new complication that was not reported earlier, that is RPE change. That happens in pigmented eyes, and also uveitis and posterior subcapsular cataract are more common in Asian Indian eyes. So melphalan is good, very powerful. It is given every week. So adding to your logistical issues of bringing these patients over from wherever they are from every week for an EUA and injection becomes a logistical hassle. So that is again a disadvantage. What is important is that intravitreal topotecan bypasses all the complications and logistic issues. It does not have retinal pigment epithelial toxicity. It is given lazily every 3 to 4 weeks, not every week, and it is very effective. So currently in Asia, in India, Africa, treatment of choice is intravitreal topotecan, not melphalan. So two drugs are used, topotecan, melphalan, although carboplatin has also been used. It works very beautifully. Scarless healing. This is a child with 2 doses of intravitreal topotecan, again 2 doses of intravitreal topotecan. Roughly you need about 3 to 6 injections of intravitreal topotecan before the vitreous seeds completely disappear, or they become crenated and calcified, or they become calcified. So there are many ways of vitreous seed regression also that has been described by Munia. Now intracameral chemotherapy is used when there are anterior chamber seeds which are depository. And the one more use of intravitreal injection is that subretinal seeds also go away. Earlier we used to laser subretinal seeds. Now since you laser in the posterior pole, there would be scarring. If you give injection, these seeds also go away. Finally, about enucleation. Whenever you do enucleation, you always use a primary orbital implant so that cosmesis is maximized, and you take the help of the pathologist to identify histopathological risk factors, which he already enumerated. But the point to note is that 50% of eyes that we enucleate in India have one of the histopathological risk factors, which could be anterior segment infiltration, ciliary body infiltration, choroidal infiltration, which is more than 3 mm in diameter or 3 mm in thickness, that's called major choroidal infiltration, or optic nerve invasion beyond the lamina cribrosa. In such patients, we are supposed to give adjuvant chemotherapy. Now, the role of adjuvant chemotherapy was controversial about 20 years ago, but this paper actually helped settle it. 24% was the chance of metastasis if we did not give adjuvant chemotherapy, whereas if you give adjuvant chemotherapy, chance of metastasis reduces drastically to 4%, thus giving a survival advantage to about 20% of children. This was later verified by a multicentric study, that's Children's Oncology Group study. Now it's become a standard of care that any child with histopathological risk factors receives adjuvant chemotherapy, and if the optic nerve transection is involved, additional stereotactic radiation as well. In orbital retinoblastoma, again we have a classification. Primary is when the child presents with an orbital retinoblastoma. Secondary is the one which develops after enucleation as a recurrence. Accidentally somebody does a intraocular surgery in a child with retinoblastoma unknowingly. Overt is when you miss it, but on enucleation you find that there is an extrascleral nodule. Microscopic is when the pathologist tells you that there is full thickness scleral invasion. It can be either diagnosed clinically or radiologically. That is secondary, that is accidental, a child with hyphema drained and trap done, and the child develops extraocular extension. Overt is when you notice this kind of a nodule when you do enucleation, and when the microscopic, when the pathologist tells you that there is extrascleral extension. So either which way, when you do management of orbital retinoblastoma, earlier there was only one treatment, that was orbital exentration, with a very high mortality of 70%. Now we do multimodal treatment where we begin with neoadjuvant chemotherapy. Example is this child with orbital component. After neoadjuvant chemotherapy, you can see that the eye has gone into phthisis and the orbital component has reduced. Then you do a enucleation with a long optic nerve stump. Then you give stereotactic radiation as an adjuvant measure and adjuvant chemotherapy as well. This is a patient with anterior intracranial extension to cavernous sinus. Now after neoadjuvant chemotherapy, eye has gone into phthisis. You can see residual tumor only at the superior orbital fissure, which is amenable to stereotactic radiation. Cosmesis is definitely a bonus to these children, whether it is primary or secondary. We can retain the eyelids in its normal shape and anatomical size, and you can actually fit a good custom ocular prosthesis. So with all this put together in India also we have 95% survival, and chemo reduction has resulted in about 90% eye salvage. 95% of those whose eyes are saved have some vision, and 50% have vision more than 20/40 when they are old enough to estimate vision. So in conclusion, retinoblastoma management is complex, it is evolving, it is work still in progress, but current trend is definitely towards conservation with chemo reduction, intravenous and intraarterial chemotherapy, and appropriate focal therapy. Thank you. Thank you so much.
Thank you very much, sir, for this excellent overview, and I hope it was useful. And thank you very much for interacting, being with us here. I hope it was useful to you too. Do we have any questions? Everyone is running, hungry, tired, I know. Any questions? Shall we call it off? Okay. Happy lunch and see you back. Thank you so very much.
We will be start.
They have left, Rolika. Yeah. What time you want them back? 2 o'clock sharp, okay? Be back. Quick lunch.